His all vital signs are normal. There is no pathology. Our preliminary diagnoses are Orchilis epididymitis, testicular torsion, hematoma, and testicular rupture. There was no pathological condition was detected in the whole blood biochemistry and the urine test. Right testis had increased herniated testicular tissue with a diameter of approximately 2 centimeters was observed in the upper pole of the right testicle. No blood supply was observed in the herniated testicular tissue. Compatible with testicular rupture in scrotal color Doppler USG. Patient was consulted the urologist and underwent emergency surgery with the diagnosis of the testicular rupture. Urologist planned emergency surgery. Patient lost his right testicle. If the diagnosis and treatment of the testicular rupture is delayed, it can cause conditions such as testicular atrophy, infertility, gonadal insufficiency, and they may result in loss of the testicle. For this reason, testicular examination should be done carefully and in blunt traumas of the genital area. Further examination should not be avoided when it necessary. Thanks for your interest.
Thank you for your presentation. Any questions? I have one, actually, not a question, but mostly a thought. I think you need to use a radiological picture or image to make your point clear, because right now it's just a sentence that we need to understand, but maybe you can use a picture so we can understand better.
There is a problem for this. Our hospital, the USG pictures, we are not see it. We just see the reports. And
you didn't collect your picture, right?
Yes, but I decide this case report after then that pathology, and I can't find their pictures.
Okay then. Thank you again. The next one is bilateral testicular dislocation after traffic accident. Sümeyye Tuğba Sarkıcander.
Bilateral testicular dislocation after traffic accident. Traumatic testicular dislocation was first described by Claubre in 1818. It's defined as extrascrotal migration of one or both testicles secondary to scrotal trauma. Traumatic testicular dislocation is a rare complication of blunt scrotal injury and can easily be overlooked due to the presence of other serious concomitant injuries. In most cases, an operation is needed to prevent malignant change or infertility. Traumatic testicular dislocation is a rare consequence of blunt scrotal trauma. Case: a 21-year-old male patient presented with complaint of inguinal pain after a motorcycle accident. Physical examination revealed that both testicles were not in a well-formed scrotal set and he had bilateral inguinal swelling. Glasgow Coma Scale score 15, conscious neurological examination is normal. There was swelling in both inguinal regions in the abdomen and 2 centimeter abrasion on the left superior of the gland in the penis. There was tenderness in the left hip, no midline tenderness. Tetanus vaccine given, antibiotic was provided, and PAN-CT requested. In this, there is displaced fracture in the iliac wing in the pelvis and bilateral testicular dislocation. The testicles were reduced by urology. Urological emergency was not considered in the patient with normal urine output to the Foley catheter. Orthopedics, urology, and general surgery were consulted. Intensive care follow-up was recommended by orthopedics. The patient was admitted to the intensive care units. Traumatic testicular dislocation is rare and can be difficult to recognize. Passengers of the groin area should be suspected in motorcycles and high-energy accidents and depend on a careful physical examination. Prognosis is expected with appropriate management to all trauma patients, especially those who have had a secretal examination, if pelvic injuries are suspected or if there is a high risk of motor shock, to avoid missing the diagnosis and avoid serious behavior. With proper management, the prognosis is excellent. To avoid missing the diagnosis and serious complications, we recommended that all trauma patients undergo a secretal examination, especially if a pelvic injury is suspected or if there is a high risk of being struck by a motorcycle.
Thank you for your presentation. Any question? Okay then. The next one, complications of dorsal split circumcision as one of the reasons for admission to the emergency clinic. A retrospective cross-sectional study. Tugay Aksakal. Okay then. The next one, a rare case of ovarian torsion. Okay. The next one, ovarian torsion of a rare case of ovarian torsion in a pregnant patient. Ekrem Taha Sert. Dilek Atik. Comparison of maternal inflammation scores, NLR, PLR, SII, and Syria in abortion imminence cases admitted to emergency department.
Good morning, everyone. Abortion imminence is one of the most common reasons for applying to the emergency department with the complaint of vaginal bleeding in the first trimester of pregnancy. Following the diagnosis of intrauterine pregnancy with ultrasonography, cases with vaginal bleeding with closed cervix are diagnosed as abortion imminence. The cause of bleeding is often associated with the decidual vessels on the maternal-fetal surface. It has been reported that the pathogenesis is related to multifactorial factors such as genetic disorders, chromosomal anomalies, endocrine and immunological causes. Between 2022 and 2023, 60 abortus imminence cases admitted to the emergency clinic who were hospitalized between 7-12 weeks, and 59 pregnant women of control group who were followed up in the obstetrics outpatient clinic were participated in the study. Cases that presented with infections and inflammatory diseases with multiple gestations, mother under age 18, were excluded from the study to avoid confounding factors. Other exclusion criteria was the use of anti-inflammatory and corticosteroid therapy. When evaluating of the mean age of the participants in the study, it was observed that the abortus imminence group had an average of 29.1 years, whereas the control group had an average age of 29.8 years. There was also no statistically significant difference between the groups in terms of parity, body mass index, and elective curettage numbers, as shown in Table 1. But when the previous abortion histories were compared, a significant difference was observed. This is the table of the demographic and obstetric variables of the pregnancy. In addition, leukocyte and neutrophil counts were found to be significantly higher in abortion imminence cases, but no significant difference was observed in lymphocyte and platelet counts, as demonstrated in Table 2. When we compared the neutrophil lymphocyte ratio and platelet lymphocyte ratio values, we didn't see any difference. This is the Table 2. ROC curve and AUC cutoff sensitivity and specificity were analyzed to differentiate the leukocyte, neutrophil, and systemic immune inflammation index parameters of abortion imminence patient to guide the clinician about the patient's condition in patient follow-up. And this is the ROC curve. This study aimed to compare pregnant women who presented to emergency department during the first trimester of pregnancy with complaints of vaginal bleeding and were diagnosed with abortion imminence with those who didn't receive this diagnosis. In another study, 121 abortus imminence cases were follow-up and 60% of them ended with abortion and 39 of them continued until the 24th gestational week. In a study conducted an evaluation of the impacts of systemic immune inflammation index and systemic immune response index on the maternal-fetal outcomes of cervical circulation in a cohort of 374 pregnant women. The study examined the duration between the placement of the circulation and the subsequent birth in the group of 2,068 pregnant women who had successful circulation. The findings of our investigation also demonstrate that the levels of inflammatory markers seen in abortion imminence cases are consistent with the findings reported in the previously mentioned studies. Thank you for listening.
Thank you for your presentation. Any questions? Okay, thank you again. There was a presentation before, missing presentation. Now we're gonna announce him. Kurtuluş Açıksarı. It's gonna present it by Bilgehan Ahmet Cumhur, I guess.
Sonrakisine Good morning, I'm Dr. Ahmet. Thank you for your attention firstly. And I'm working in Istanbul Medeniyet University Medical School Hospital. And I'm going to talk about the effect of hydroxychloroquine and zinc therapy in a rat model of sepsis created by chacal ligation and perforation in rats. First, I want to introduce that sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection, which is a big deal for most of the countries and also developed countries. Approximately 40% of the septic shock patients cause with a mortality. And also zinc. Zinc is an intracellular element used by almost all cells of the immune system. I'm talking about 99.6% of the immune cells use zinc to function. You know, the zinc can be prescribed or can be bought by pharmacies without any prescriptions. It functions as modulation of production of inflammatory cytokines, production of pro-inflammatory cytokines by monocytes, presentation of MHC class II molecules on dendritic cells, formation of extracellular neutrophil traps by neutrophil granulocytes. As I said to you, 99.6% of the immune cells need to use zinc. These are just a few examples. Hydroxychloroquine is one another drug. Hydroxychloroquine usually does not prescribed by emergency physicians. It's used as an anti-inflammatory and anti-malarial drugs. Just a few features of it. It's a cell ionophore that we are going to use for our experiment. It reduces the production of pro-inflammatory cytokines. It inhibits the production of interleukin-1, interleukin-6 in monocytes and T cells. And it's a pharmacological inhibitor of autophagy. You can ask me that why did you choose hydroxychloroquine as an emergency physician? I have decided to do this experiment. When I was working in the COVID department, in the first wave of the COVID department, we routinely give the COVID-19 patients hydroxychloroquine. At the same time, the patients was buying zinc supplementation, or sometimes medical doctors was prescribing zinc supplementations to the patients. But hydroxychloroquine is a zinc ionophore, cell ionophore, and it increases intracellular zinc levels. Aim of this study: hydroxychloroquine is a cell ionophore. In the previous studies has been shown that hydroxychloroquine increases intracellular zinc levels. Zinc functions intracellularly. If intracellular zinc level is normal for a patient, if we supply zinc extracellularly orally with oral intake, and the immune system does not need such a zinc, so we can't see so much effect on the immune cells. But if there is intracellular zinc deficiency, when we supply zinc, we are going much more better benefit during sepsis, during function of immune cells. But we don't know that if we increase intracellular zinc level more than normal, is it a good thing for a patient or a bad thing? Now, we are going to give the patients hydroxychloroquine, and we are going to perforate the cells. The intracellular zinc level is going to increase, and after that, we aim at what's going to happen. Because, as I said, during the first wave of the COVID-19, hydroxychloroquine has been prescribed routinely, and most of the patients start to take zinc supplementation with a prescription or without prescriptions. We have used a sepsis model. We have used spectrally male rats. For all procedures, we have given analgesics and sedatives. We opened the cecum, tied it 1 centimeter distally, and perforated with the needle. And after that, we brought the cecum previous anatomical position and produced sepsis model. And we have 5 groups. The first group was sepsis group, and sepsis introduced in 6th day, and rats sacrificed in 8 days. Second group, we again sepsis induced in the 6th day, but with 12 hours interval, we supplied zinc for 7 days. Third group, sepsis-induced 6th day, and hydroxychloroquine 300 milligram per kilogram has been administered 12 hours interval, and again sacrificed 8 days. And the fourth group, and in this group, we have administered zinc plus hydroxychloroquine, and also we produced a sepsis model. And the last group was sham group. Cecum was reached, opened, and without sepsis model, and we closed it. Sacrification has been done with thriving blood 10 cc via cardiac puncture. And kidney was removed for histological tissue examination because sepsis is one of the most common tissue that affected by sepsis. Let's talk about the results. We have checked histological parameters, and we have worked with biochemical parameters. And interleukin-6 and procalcitonin, one of the two of our biochemical parameters, but unfortunately our biochemical kits didn't work. As you can see the results, there is no difference between the sepsis and the sham groups and also treatment groups. All the results were the same. This is a failure of a kit. But we have also checked what blood cell neutrophils and lymphocytes. As you can see the results, sepsis In the sepsis group, we can see the elevated white blood cells, neutrophils, and lymphocytes. And in the treatment groups, both phase groups was much more better and has benefit from the treatment. And with these results, we can say that sepsis model has been established successfully. And our histological examination, we have checked tubular dilatation, tubular epithelial necrosis, cast formation, glomerular vacuolization, free Bowman area, glomerular atrophy, and monocyte infiltration and hemorrhage inside of the tissues. And also this was the parallel to our biochemical parameters. And we can see that in the sepsis groups, we can see much more damage if we compare with the sham group and also other treatment groups. Discussion. We have checked histological examination and biochemical examinations. In the whole sepsis groups, in the whole histological groups, we can see that sepsis damage on the organ or the tissues is higher than the treatment groups. But if we check the treatment groups, means that hydroxychloroquine, zinc, and hydroxychloroquine plus zinc group, there is no significant difference between each treatment groups. But sepsis group, as expected, P lower than 0.01. I can say that there's no statistical difference between hydroxychloroquine, zinc, and hydroxychloroquine and zinc groups, but numerically we have seen that, we have observed that the tissue damage higher than hydroxychloroquine plus zinc group. In the examination made by biochemical parameters, white blood cells, neutrophils, and also lymphocytes was parallel to the histological examination. Numerically, we can see the difference between hydroxychloroquine plus zinc groups. There were higher damage on the red tissues and red biochemical parameters, but this was not statistically important. This can be because of we have used 9 rats per group, and 3 of our rats died. Because of this, we have resulted this experiment with 6 rats. Maybe if we do this experiment with a much more higher number of the rats, maybe we can find statistically important results between the hydroxychloroquine plus zinc group and with the others. Although it was not statistically significant in histological and biochemical examination, inflammation and organ damage were higher group in the group in which zinc and hydroxychloroquine given together, in the group which hydroxychloroquine or zinc were given alone. If the amount of zinc inside of the cell increases, tissue damage is higher in both histological and biochemical examination results, and it's not significantly statistically important. And it is parallel to the older groups, older experiments. Zinc level increases inside of the cells, inflammation increases, and hydroxychloroquine also suppressed our inflammation and with the treatment groups. Thank you.
Thank you for your presentation. Any question? I have a recommendation actually. Your presentation is a bit longer than normal time, so maybe next time you should. Thank you so much. Okay, the next one, results of a 12 years old clinical experience in cases with Fournier gangrene. Tunç Ozan. Okay. There's another presentation. It's going to be presented by Beliz Öztokten. We don't know the name, so thank you.
Good morning, and thank you very much. I'm Beliz Öztokten. I study in Bolu İzzet Baysal University in medical department. I will talk about a case report we have seen in emergency department. It was invasive fungal sinusitis. Nasıl ilerletiyorum bilmiyorum ki.
You can use the green button. Yeşil.
Okay, sorry. Fungal sinusitis are rare infections caused by fungal organisms and in nasal cavity and paranasal sinuses. Fungal sinusitis are divided into two groups, invasive and non-invasive. Invasive fungal sinusitis often cause generally, we see that in diabetic patients or having corticosteroid treatment or immunosuppressed patients. Generally, they have non-specific symptoms like bacterial infections, fever, headache, or epistaxis and nasal congestion. And fungal, especially invasive fungal sinusitis, have a high mortality rate, 85.100%. For early diagnosis in emergency department, we can use only 3 ways: endoscopic examination, computer tomography, and magnetic resonance imaging. And we can see the sinus cavities, opacity, the thickening of the sinus walls, and bone construction and destruction in the computer tomography especially. For definitive diagnosis, however, it's not so possible in emergency department. We can use both histopathologic examination and microbiologic examination. For treatment, we have 2 choices: systemic antifungal agents and surgical approaches. Our aim in this presentation, we have to talk about a case report who had recurrent admissions to the emergency department with complaints of epistaxis, and he have finally diagnosed with invasive fungal sinusitis. He was an 81-year-old male patient, and his history was recurrent admissions to the emergency department with epistaxis. He was a chronic alcoholic and 55-pack year for smoking history. He had hypertension, but no regular anti-hypertension agents using. And he didn't use any anticoagulant or antithrombotic agent use. And he hadn't a history of trauma of all admissions with epistaxis. And we had after our first examination, we had otorhinolaryngologist consultation, and they had nasal endoscopic examination. They saw the mucosal erosion, purulent secretion, and fungal hyphae. And then we both think about seeing a computer tomography, and we saw paranasal computer tomography, and we saw left maxillary sinus walls and soft tissue had destructive lesions, as you can see here. Şuradan gösteremiyorum herhalde. Left maxillary sinus walls destruction, and invasion from left maxillary sinus to the left orbit and left middle cranial fossa. He was interned in otorhinolaryngology service and was started systemic antifungal treatment as voriconazole. Fungal sinusitis should be considered in the paradiagnosis of patients presenting to emergency departments, especially with recurrent epistaxis and who has risk factors. We have to think about these fungal organisms, especially having diabetes or immunosuppressive patients. Early diagnosis and treatment of life-threatening invasive fungal sinusitis are vital, and these patients should be evaluated by otorhinolaryngologists. Thank you for listening.
Thank you for your presentation. Any question? Okay, thank you, Dan. And the last one, I guess, by Fatih Cemal Tekin, subcutaneous emphysema of the extremity after foreign body penetration, a case of necrotizing fasciitis.
Good morning. Thank you for your attention. Foreign body penetration is a prevalent cause for individuals seeking medical attention at the emergency department. Superficial traumas, particle case of nail penetration, are commonly found within this context. In these circumstances, dressing, tetanus vaccine, analgesic, and antibiotic therapy are typically considered adequate treatments, unless the patient has comorbidities. The purpose of the presentation is to highlight the potential development of severe complications in patients who present to the emergency department with nail penetration, and to underscore the significance of doing a comprehensive physical examination. 22-year-old male patient was admitted to the emergency department with swelling and redness in his leg, and was informed that he had a nail had lodged in his leg. On examination, diffuse heat increase in the right leg and redness around the area where the nail was inserted were noticed. In addition, crepitation was felt under the skin from above the knee. The tetanus vaccine was administered 3 months ago, and antibiotic therapy and analgesic treatment was started in the emergency department. In the image examination, diffuse foci were observed around fascia and vascular structure of the muscle in thigh, extending the right iliopsoas muscles, and were evaluated as necrotizing fasciitis. The patient was hospitalized in the orthopedic ward, and no growth was observed the wound culture. Fasciotomy was performed in the medial and lateral region. Meropenem, vancomycin, and tigecycline were started with the recombinant in infection disease. After 20 days, the patients developed granulation tissue and no drainage at the wound site, and skin closure was planned. Nail penetration cause presentation on the emergency department should not be considered as sample case. As seen in your case, complications such as necrotizing fasciitis should be kept in mind. For this reason, the initial examination of the case should be done careful, and treatment to prevent this complication should not be forgotten.
Thank you for your presentation. Any question? Okay, thank you. Is there anyone behind left? Okay, thank you then. Have a nice day.
doctors, many generations of doctors. So today I'm actually going to talk to you about how the healthcare simulation spectrum is transforming itself and how we are moving forwards and moving beyond. Right, the picture that you see here is actually a picture from Bhutan. How many of you have been to Bhutan? It's the country with the highest happiness index at one point in time. And this is the Hanging Tiger Nest Monastery up in the mountains. And it was quite an effort to actually climb the steps and trek upwards to this monastery. But then, you know, it's just like our path in life. We all have to transcend and move on, and there will be challenges and barriers as we move along. The path to becoming a high-functioning professional emergency physician is not easy. There will be many challenges during the course, but however, hopefully the results will be good and it will be satisfying to you as well. And we'll see what happens. Now, technology is driving all of us. Everything we do is technology driven. So therefore, anything from our children, the younger generation, the teenagers, even into the older generation, you know, in Singapore, we are actually teaching our seniors how to be technology savvy, how to use their handphones to negotiate a lot of things and a lot of programs as well. So therefore, it is actually very, very technology driven. However, we must not forget the human touch and the elements of humanism as we move along in this era where technology is driving everything that we do, including in the practice of medicine and emergency medicine as well. So we have to make sure that we adapt. Let's look at this video for a while. Can I have the volume up? The sound? Okay, so this is what happens when you go shopping these days. You don't even have to put the clothes on. You can just look at the mirror and AI will show you what you're going to look like. Oops. Okay, that's a technology glitch. So let's just wait for that. So nowadays you can just look into the mirror and then you don't have to try the clothes on and it will just show you what you're going to look like with those clothes. Okay, just give them a minute. We got the volume up already, thank you. Yeah. Okay, so let's just see how it's going to be like when we go shopping these days with AI and with a technology-driven world.
Show me skirts.
Okay, so all the skirts will come up. And that's how you're going to look like without even having to try the clothes on. You can actually see what you're going to look like, how color coordinated you can be. And this is really not the future anymore, it's already here. So therefore, technology is indeed driving us in all aspects of our lives. This is really quite fun, especially for ladies, because you know how many times we change our clothes in the morning because we think that it doesn't match nicely. And it can also take a photograph for you.
Yes.
In case you want to ask for your spouse's opinion. With different backgrounds as well. So this is actually quite interesting, and this is already around. And you scan the QR code and you can do your payment online. It's cashless. So this is the world we live in today. So in the midst of all that, we must not forget that humanism must still prevail. It is at the center of everything that we do, including when we use technology as well. So humans must be at the core of everything, whether it's related to our patients, our learners, their family members, and the community around us. And don't forget the healthcare staff, all of you as well, because oftentimes we care about others, but we forget to care and think about ourselves, which is really very important, because we are not there, then there's no healthcare provider really. So the characteristics of humanism in anything that you're going to approach to do really comprise of the human values, the human emotions, which is very unique because when you use technology, those things are not there really. And your humanistic approach, always think about how a person is going to react to you. And of course, all the other considerations like values, personality, your style, and all that, okay? So, I'm not sure whether any one of you have read this book. It's Man's Search for Meaning by Viktor Frankl. And he says that the hardest part of being human is to continue to be human with each passing day. Just think about it, with all the technology surrounding us, do we really feel like this, you know? So therefore, what are the technology that we are most exposed to in medicine and in education or medical education? Well, we have a lot of technology-enhanced learning, everything. This afternoon, I'll be talking about my simulation technology at 4:30, so you can see all the kinds of technology and toys that we are involved in these days. Technology-driven communications. We cannot live without our mobile phones. You know, everything is there, even all your learning, important learning curriculums and everything are all on your phone now. And serious games. I developed serious games to teach healthcare providers how to excel in certain tasks and skills. So that's the game-changing technological tools. And then of course we do a lot of VR, virtual reality, augmented reality, extended reality, mixed reality, and all these, including robotics. Robotics is not new anymore. People are already using this to do surgery and surgical processes, and I'm sure it's the same in Turkey as well. And a lot of AI. We are looking at how to integrate AI into a lot of the things that we do in the emergency department to make things more efficient and also seamless for our patients and also for ourselves. So what does AI comprise of really? You know, we talk about AI all the time, we talk about smart technology, but then do we really know what we're talking about? Well, so AI really comprises of computer-controlled processes. So there's algorithms, there's a lot of mathematics and physics involved, there's calculations, for example. You can have an AI algorithm for assessing how likely is your patient with a right lower quadrant pain likely to have acute appendicitis, or a right hypochondrial pain likely to have gallbladder disease or hepatobiliary disease. There are mathematical algorithms to help you with this, and it's run by AI. And of course, there are many solutions that you can use, equations, logistical optimization. You can see your patient flow through your emergency department using AI technology. If you're building a new emergency department, you want to look at how to run the flow of patients directly from registration to triage, to your resuscitation room, to your consultation areas. You can actually use AI to look at the flow as well. And of course, a lot of other software as well. Now, AI's entry into medicine perhaps will redefine our role as the educator, as the teacher, as the mentor, right? So at the same time, as we are using all this technology, we cannot run away from the fact that we need to use technology, because if not, our younger generation learners are not going to be motivated. And you know, they like to do things fast, short, sharp, targeted, focused, and they're very mobile. They like mobile learning, you know, and they don't want to sit there all the time for a few hours and look at the desktop, for example. So this is the kind of learners that we have to appeal to today. So therefore, we have to think about how we want to do all these things. So as we are reaching out to this group of learners, don't forget the humanistic approach, which is we want them to come at their free will, because if they are internally motivated, they will do better and they will be more passionate about what they are doing in their work, of course. And then, of course, the emotional and the motivation part is very personal, very human. These things you cannot duplicate with technology. And of course, with the changing face of technology today, we find that we are learning more in isolation. We can do it on our own. We don't have to have group learning anymore. We can have our technology devices in our own homes, and we can study anatomy by putting on a pair of spectacles, which is AI savvy, and you can actually learn anatomy on your own practically. So people are becoming isolated. People don't talk and meet face to face anymore. They can interact through their mobile devices, for example. So therefore, think about the human-to-human interactions that we have. Our patient contact with the physician, that's important. I mean, that is something you cannot run away from, because I think in medicine, no matter how much technology we have, the face-to-face contact is still definitely important. In healthcare, including emergency medicine, we are, I would call, a high-tech and high-touch industry. You know, there are some technology or some industries which are high-tech but low-touch. But for us, we are high-tech and high-touch because we need technology, it has to drive us, but we also need high-touch because we need the personalized approach to patients, we need to have the face-to-face contact, we need to have the therapeutic touch as we manage our patients, for example. So therefore, I like to term it as high-tech and high-touch in terms of using technology in medicine, including emergency medicine. And as AI move into medicine and into medical education as well, the human touch must not be a casualty. So don't forget about that part of it, because you know, in Singapore, all our emergency departments are computerized. You know, everything is computerized, everything is digital. So therefore, what my medical officers and residents do is that when the patient comes into the room, it's a consultation patient, not a resuscitation patient lying on the bed. Then they will be typing at their computers, you know, the history, the physical and all that, and sometimes they forget to look at the patient. They forget to look at the patient, and we get complaint letters. As the director of quality in the emergency department, I get people complaining, say that when I came into the consultation room, the medical officer was typing on the computer. He practically never looked at me, you know. So we forget the humanistic aspects of the practice of medicine. We forget to look at the people that we're talking to. And because we're so driven by the task that we want to do, we're just typing on the computer, you know. So don't forget those elements. And robotics is already in. So this is a picture here about how robots are being used in seniors rehabilitation. It's very useful, you know, and they are even being used in aged homes, seniors homes, how the robot keeps the seniors occupied by singing along with them, by teaching them simple exercises and all that. But, you know, it keeps the seniors occupied. But again, you know, they need the human touch and the humanistic elements as well. Let's look at this video. Sound up, please.
The Hong Kong team behind celebrity humanoid robot Sophia is launching a new prototype, Grace, targeted at the healthcare market and designed to interact with the elderly and those isolated by the COVID-19 pandemic. Dressed in a blue nurse's uniform, Grace has Asian features, collar-length brown hair, and a thermal camera in her chest to take your temperature and measure your responsiveness.
So this is a robot nurse.
She uses artificial intelligence to diagnose a patient and can speak English, Mandarin, and Cantonese.
So look at her emotions and her facial expressions.
Let me introduce you to my sister Grace. Come over here. Hi,
She's
Grace.
got a sister as well.
Thank you, Sophia. Hello, everybody. I am Grace. I am built by Hands and Robotics for Awakening Health. I can do all kinds of things for elderly people. I can visit with people and brighten their day with social stimulation, entertain and help guide exercise, but also can do talk therapy, take bio readings and help healthcare providers assess their health and deliver treatments. Hi, my friend. Nice to see you. Okay, great. So while we talk, I will take your temperature reading and pulse with this little thermal camera on my chest. See? You are 36.6 degrees Celsius, by the way. No risk of COVID. Also, I note that you are responsive and
So this
aware,
robot can
which
be
is
taught
good, and
to
then
speak
I
different
share that
languages.
important data back
So
to
in
the
Hong
doctors and
Kong,
nurses
they've
at the
actually
institution.
taught them how to speak Cantonese,
Grace's
because that's
resemblance
a
to a
Chinese
healthcare
dialect that is
professional
very
and
commonly used
capacity
in
for
Hong Kong,
social
for
interaction
example.
is
So you can
weak,
customize your
alleviating the
robot,
burden of frontline
personalize it
hospital
as
staff
well.
overwhelmed during the pandemic, said founder David Hansen.
So we designed Grace to look professional in a healthcare setting. So that would mean so that she would resemble the sort of human-like appearance of healthcare staff. And so then this would facilitate more natural interactions. A human-like appearance facilitates trust and facilitates natural engagement because we're wired for human face-to-face interactions. That's just the way human beings are. And so giving her a face that would be familiar to people, comforting to people, and also language abilities that are comforting. So we now have Mandarin and Cantonese capabilities for the Grace and Sophia robot platforms. Hey Grace, why don't you look at my face, thank you, and I'm going to show you a smile, and let's see what your smile looks like. Okay, yeah, look, or sad. Oh yes, reacting a little sad if I feel pain. And then maybe like imagine a big loud noise happens, bam! So, with the Grace robot, we are simulating over 48 major muscles in the face. So we have 36 motors in the face that are reversible, which means that each motor can simulate 2 muscles, because human muscles require 2 for the actions, like my eyebrow is going up and down, kind of. So that's actually 2 motor groups, but in her it's just 1 motor. So Grace is designed for Asian markets, also markets all around the world, but we did make her look a bit more Asian than Sophia, but her face is actually a bit more cartoon-like, a bit more like anime. And the anime design references are often
anime is the Japanese cartoon, right? Yeah, if you're
Asian
familiar.
styles and Western
And they have big eyes, and they look very approachable.
Awakening Health intends to mass produce a beta version of Grace
Yeah,
by
so
August.
that's what technology is leading us to these days, okay? So for the seniors and the elderly who is sick in bed, they might just recognize this nurse as a, real nurse. So every touch point with a healthcare provider will provide an impact. So therefore, make sure that we use that possible touch point that we have, but perhaps it could be a machine touch point. But really, it's up to us. Whatever technology we're going to use these days, how do we integrate the humanistic aspects and the humanism aspects into what we're doing? We cannot run away from having technology because I think it's already here to stay. And technology can offer us a lot of things. For example, during the pandemic, that has given us a booster with the adoption of technology in healthcare. Healthcare was lagging behind in terms of technology adoption compared to other industries. But I would say COVID-19 has given us a booster, and really I think it is going all out, and the trajectory is a correct one. And of course, technology can provide us more time. We're always busy. It makes us do things faster. We can create more free time for ourselves. It's environmentally friendly. You don't have to have so many papers and to carry all those heavy load and files that you have. It will also allow for repetitive practice. So if you have simulation, for example, you can practice again and again and again without hurting any patients, and you can do it until you reach a proficiency level or a mastery level that you would like to attain. Of course, it will save on storage space. You can do it on your own free time as well. So people are very mobile nowadays, especially the younger generation. In Singapore, we have a Smart Nation move, which is to make everything more IT driven. So therefore, these are all on the agenda for different institutions, different industries and all that. But what technology cannot really offer well is really the relationships and the interactions that we must continue to have. And of course, the social skills, the communication skills, the deeper emotions, the finer aspects of correspondence, and the touch and feel as well. That's very, very important. So therefore, technology can offer a certain amount of things, but there are certain things that we still need to have the human elements to it. So therefore, technology can enhance, but I don't think it will replace the human representations and interaction. So whenever we are adopting technology, make sure that we think about the humanistics and the humanism aspects. It's a very interesting area. And of course, these aspects of humanism are very culturally driven. How it's driven in Turkey, for example, could be very different from how it's driven in Singapore, because we are all culturally different, and in multi-ethnic, multi-racial society, we have to think about those aspects of practice, of interaction with different people, different age groups as well. So that's really quite an interesting element to think about as well as we're moving into the future. Now, in robotic surgery, a lot of things are programmed. They use a lot of AI, a lot of computer software to program every step, which is done with precision, a lot of precision, better than the human cut, for example. But the important thing is that the human controls the robot. The human controls the computer software. So you still need to have the human elements there. So if we look at this trajectory of the path to humanism in the world where technology is being adopted, make sure that we look at some of these things to make sure that our learners are taken care of. They have the human elements and the humanistic aspects, and they also can experience the joy in learning, the wellness, the comfort, the ease and all that. That cannot be machine driven. In Singapore, we have a movement called the Joy at Work movement. And this Joy at Work movement is about maintaining psychological safety amongst healthcare providers. Nobody has really looked at the psychological safety of healthcare providers until COVID struck. And then people became more concerned about our psychological well-being, whether healthcare providers are doing well, are okay, are breaking down, are burning out, So I think COVID-19 has brought certain positive elements to our practice in medicine as well. So all these things are still very human, and technology may not be able to do it all. So therefore, for all of us, it's about a balance, how we want to create that balance in the work that we do, in the practice that we have, for example. And really we have to be conscious about the human elements. So when I'm using simulation to teach my residents or my doctors or even faculty, so I will inject situations and scenarios to make it more human. How do we do this? By injecting narratives to humanize the experience. Because when you write scenarios for simulation, you will actually write from experience that you have had in your emergency department, where a patient comes to life presenting with acute myocardial infarction in cardiogenic shock, or diabetic ketoacidosis, with severe sepsis, So those are the stories, the narratives that are very important, that helps us to keep our scenarios and our simulation human. When we do debriefing after the simulation, we are usually doing it face-to-face. That's the best. And of course, there are virtual debriefing sessions, which we have done during COVID especially. But again, there are certain limitations to it, but it can be done. It still works, and I've done many of those virtual debriefing sessions as well. But of course, it will be more satisfying if you can do it face-to-face. And then of course, we can use hybrid simulation to humanize our simulation sessions. I'll be talking about this in the afternoon at 4:30. If you're interested to see how we integrate a lot of different tools and toys into simulation by using hybrid simulation, do come for that session later. And of course, we can combine live and virtual sessions together to make it more humanistic as well. So the way to go forwards is to balance the technology adoption together with the human elements, and then of course maybe to even have smaller group for bigger interactivity, and let humans be humans and let machines be machines. But when they work together, the outcome of the integration can really uplift the level of intelligence. And this is another interesting book. For those of you who are interested, you can actually check out this book, Deep Medicine, How AI Can Make Healthcare Human Again. Quite contradictory as the title, but I think it's quite an interesting read for you who have the time. Again, I cannot overemphasize the need for balance with technology and humanism. Moving forwards, I think the digital economy is here, the green economy is here, the care economy is here. But in all the things that we do, make sure we consider the human elements. So the 3 S's to remember will be safe, smart, and sustainable, because we definitely want to save the earth and make sure we are green. So back to that hanging tiger nest monastery in Bhutan, the country with the highest happiness index at one point in time. So I mentioned earlier that I actually climbed all the way up. Using your own 2 feet, you climb. Of course, it's a lot of effort to climb, but then, at the end of it, you actually get to see a beautiful sight, and you get to go into the serene, calm monastery, and perhaps technology will now be able to get you up there sooner. Perhaps there'll be a conveyor belt, perhaps there'll be a cable car, a technology-driven vehicle that can bring you up there easier. But just ask yourself, will you be more satisfied when you get up there? Will your inner satisfaction and motivation be as good as if you had climbed it yourself? So that's a question for all of us to answer. So our future is a race between growing power of our technology and this wisdom, which we're going to use it. So let's make sure that wisdom can have a bit of an edge over that. So thank you very much. And if there are any questions, I can take them. Thank you. Our next speaker is Dr. David Carr. You guys know him already. So he's going to have a long tutorial session with you on dermatology, because I think we only have the two of us this morning at this session. So if you have any questions, just ask him. So David, over to you.
Good morning. Thank you for coming. It's early, and it's amazing to see, no, I'm okay. It's amazing to see so many faces I met in the last 3 days here this morning, because that inspires me to do better, to see my friends here. And it's been amazing to be part of this conference for the first time, to be part of your country, and to be welcomed so warmly. So thank you all for that. Yesterday, I gave a talk on 20 years of my career and what I think about. Today is different. Today is 20 years of my career in pictures. This is it. These are 20 years of rashes that I've captured on my phone or my camera that made a big difference to me. And what I'm going to do today is I'm going to show you 16 rashes. In front of you is a piece of paper and a pencil. You are going to take this as a quiz, and you're going to write the answer to all 16. My hope is you get 0. If you get 0, I've taught you 16 things. The wonderful thing about dermatology is once you see it once, you don't forget it. So the lower your score, the better my talk. So don't feel threatened. And what I'm not going to do today is talk about treatment, because I believe this kind of treats almost everything. I once, when I was a medical student, I did a rotation in dermatology for 2 weeks. And I went to see a patient, and the dermatologist said, "What do you want to give the patient?" I said, "Some hydrocortisone cream." And she looked at me and she said, "That is a great answer, but if you write hydrocortisone cream from a dermatologist's office, people aren't going to think we're dermatologists. You have to write something different to confuse the other people to think we're specialists." So we're not going to talk about this. 16 pictures. Is everyone ready to go? Okay, so what I'm going to do is I'm going to give you 16 pictures with 16 stories. I'm going to go quickly in my Turk English. I'm going to go slow, and then we're going to come back and we're going to make it like a quiz. Now, you in the purple shirt in the back, do you want to come closer? Or you this is a really fun, intimate session. You two, I know you're having fun together. Come closer, more intimate. Let's just make this like a fun activity. Sorry to pick on people. I won't pick on people for answers, though. Okay, the first person gets referred to your emergency department. They've been on cephalexin for 7 days. Both of their legs are infected. They get referred to you for intravenous antibiotics because they're not getting better. That's your first patient. So jot these all down. Your second patient, the nurse asks you to sign an EKG. In Canada, we have to sign every EKG the nurse does within 10 minutes. You guys have to do that in Turkey? Yeah. So I get shown the ECG, the heart rate is 170, and I said, what's the story with this kid? He's 20 years old. Oh, he has a rash. He was tachycardic. So I did an EKG, and can we give him something for pain? His heart rate is 160, 170. His blood pressure is about 90/60, and he would just like something for pain. Do you think I could give him some Toradol or morphine before you see him? He's just got a rash on his leg. This is a kid that I saw this summer, and I see him every summer. He's a kid who got stung by a bee. It got hot, it got red, it got warm, and he got put on some cephalexin. It wasn't getting better the next day, so he's referred to the emergency department for intravenous antibiotics. This is my daughter Dylan's foot. Dylan and I were at the basketball game. We're big Toronto Raptors fans, and Dylan said, "Daddy, my foot is so itchy." You know, I'm watching basketball. I don't really care about her foot, to be honest. And she kept, "My foot's itchy, my foot's itchy." I'm like, okay, the game's on. We're not talking about your foot. You know, everyone has that one child who, she's my one child who kind of always, "Daddy, daddy, daddy." So I said, "Dylan, we'll deal with your foot after the game. Can we just watch the game?" She said, "Can I take my boots off?" I said, "You're not going barefoot at the basketball stadium." So the next day, her mother sends me a text that says, "I understand Dylan told you her foot was bothering her. You didn't look at it. I thought I would send you the picture. What's wrong with Dylan's foot?" This is a 55-year-old male, has a rash on his chest, both his hands, kind of feeling not great, and you're asked to see him for this rash on his palms and on his chest. This is one of my favorites. This is the patient's camera. The picture on the left that looks pretty good with the piece of gauze is when he presented to the emergency department. He got bit by a dog, his dog, and he came in. He was given some antibiotics, some amoxiclav, clavulanic acid, and told to keep it clean, to put a dressing on it, some bacitracin, some stuff, just keep it clean, and if it gets red or painful or anything, to come back to the emergency department. And he came back 2 days later with a very itchy rash on his hand, and he said, you know, they told me to come back if it gets worse. And I saw him, and it looked a lot different than it did from the picture he showed me a few days prior. So this is a 50-year-old male who comes in with the chief complaint of, "My wife told me to come to the emergency department." Now, I don't know what it's like where you're from, but in Canada, men are the inferior gender. And if they say stupid things like this, trying to blame their wife, it's a sign of insecurity. But nonetheless, he comes to see me under the auspice of "my wife sent me here." Already I thought he was pretty meager. And he said, "I've had this rash on my legs for about 2 weeks, and I thought I should get this checked out." Okay, this is a strange story. This is a gentleman who was going on a cruise. He was going on a cruise in Hawaii in the United States, and when he was wearing like a tank top, he had recently been sick with strep throat. And when he got on the cruise, do you guys like cruises? Does anyone go on cruises? You're a cruise guy? Okay. So he's about to go on the cruise, and they're in line, and the person says, whoa, whoa, whoa, whoa. You can't come on the boat. Not with that. You could get the whole boat sick. You must see the ship doctor. I wonder if you have chicken pox. So he goes to see the ship doctor with this rash on his back, and the doctor says, oh, he doesn't have chicken pox. He's safe to come on this cruise to Hawaii. And he goes on this cruise to Hawaii, and he's actually gets better in Hawaii a little bit, and he comes back to see me in Canada for this rash on his back. So this is a strange request. This is a woman who comes in saying, can I have a prescription renewal? Now, when people come in for prescription renewals in Canada, they're not asking for cholesterol pills. They're not asking for thyroid pills. They're usually asking for either opioids or benzos. This woman says, requesting valcyclovir. So she says that she has had shingles every month for the past 2 years. And she gets shingles on her butt. This is her left buttocks. And she gets shingles every month, and she's visiting from out of town, and all she needs is a prescription for valcyclovir, and she wants to go home. So every month she gets shingles, she just wants valcyclovir, she's ready to go home. This is an 8-year-old boy. You can see he has an IV. Kids don't usually get IVs, which means he's sick. He has a fever, not feeling well. He has a history of atopic dermatitis, and it seems to have broken out, and he has this rash that's all over his arms and his body, and he doesn't look well. And his mom brings him in to see you. This is sorry for all the buttocks pictures. This is a 6-year-old child. His dad is one of our emergency doctors, and he's had this rash on his bum for a while. So at first, the dad just gives him some hydrocortisone. Maybe it's a bit of dermatitis. Then the dad says maybe he has a pinworm. Any parents here? Have any of you ever tried to look for pinworms in children? So it's a crazy thing once you have kids. You go to your kid's bedroom in the middle of the night, and you put some tape on their bum and a flashlight, and you hope to see worms coming out of their kids' bums. It's actually the most disgusting thing in the world. So this dad keeps checking for pinworms every night, and he can't find pinworms. He treats the kid with pinworms, he treats the kids for dermatitis, and then he says, Dave, crap, can you just take a look at my kid's bum? My wife's gonna kill me because she says I need to see a doctor, not a dad. And he comes to see me. Okay, this is a bizarre story. 2 pictures here. This is the referral letter I get, and I want you to think about what you would think when you read this letter before you see the patient. The letter says, I have seen this young 25-year-old Filipino male twice in my practice. He came to me 1 year ago with an abscess on his neck. I performed an incision and drainage. That's on his right side. Today he comes back with another abscess on his left side, and I think he's going to need a skin graft. I'm reading this note, and I go in to see this patient, and I put him in a gown, I take off his shirt, and he's like Frankenstein. He's like, he can't even move. So I say to him whoa, what the hell is wrong with you? And how long have you looked like this? He said, I've had this for a year. I said, what? Have you seen a doctor? No. You've looked like this for a year and you haven't seen a doctor? No. Can you fix my neck? So I feel his neck and swollen and a bit cold, and I said, hold on a second, I'm not cutting into this. That's him. Next one is a 25-year-old female. She comes to me with sore wrists, sore ankles, and this hemorrhagic pustular rash on her fingers and her body that's been going on for about a week, and she doesn't feel great. So this is a guy I saw last winter. He's a marginalized individual who lives, he's homeless. We have a large homeless population in Toronto. And he came in with some bleeding gums and this rash on his legs. I kind of looked at it. I figured, you know what? He's a drinker. Maybe he has some bone marrow problem. I order some blood work. I get the CBC, thinking this is going to be a slam dunk. His platelets are 350. They're completely normal. And I look at his rash, hoping it was thrombocytopenia, but it ain't. And that's his rash. This is a person referred to me. They just came back from South Africa. And they went there to do safari. And when they came back, they got a fever. And they were told, if you get a fever, they've been all over Africa, you must get a test to rule out malaria. So he comes into our emergency department. My resident goes to see him. We have a rapid falciparum screen, which is negative. I say, okay, he doesn't have malaria. He can go home. He's fine. And the patient says, hold on, can I just show you something in my arm? So he takes off his sleeve and he says, on my right shoulder, I have this black spot. Oh, how come you didn't tell the resident this? He has this black spot here. And he says, on my other shoulder, I have these spots here. And those spots are what the black thing used to look like a few days ago. That black thing used to look like those spots. I thought they might be a bite or a reaction, but now it's got this black thing here. What is it, doc? And the last, number 16, is a woman with a history of hypertension. She's on Ramipril. She has a history of seizures. She's on phenytoin. She has a history of high cholesterol. She's on a statin. And she comes in with a fever. She's not feeling well. And she has these big swollen lips. She kind of looks like Angelina Jolie. And she comes to see you to say, what's going on with this, my face? Why is it so puffy? And why do I have this rash on the body? 16 pictures, 20 years. Who got 16 rashes correct? Do we have 8? Do we have 4? Good. Perfect. This is what I want. That means that if we're mean average of 4, I've taught you 12 things. Okay? If I can teach you one thing this morning, if you take one thing away and nothing more, you take away this. This is the most important thing you will learn by me this whole conference. Who knows what the first rash is? Anyone want to shout it out? So this person has stasis dermatitis. You do not get bilateral cellulitis. Cellulitis doesn't work where you get it here, skips this stuff, and goes down the other way. That's not how things work. If you write in your chart bilateral cellulitis, I want you to know that somewhere I will be watching you, and I will be looking down on you, and I'll be shaking my head like this. Don't ever call something bilateral cellulitis. We get sent these people all the time. You do not get bilateral problems at the same time. And it's a cycle of unnecessary antibiotic after unnecessary antibiotic, and stop the cycle. These people need weight management to lose weight. They need a steroid. Now, usually we just give everyone hydrocortisone, that's fine. They actually need a real steroid. Something like clobetasol, which is a class 1, a very potent steroid. And they need their circulation checked. Ankle brachial stuff to make sure they don't have arterial disease. But this is something we do terribly in Canada, and I'm gonna guess all over the world people just give antibiotics and get these people out of their emergency departments. Okay, let's look at picture number 2. Who wants to guess? This is the guy who has a rash, who's tachycardic, who's hypotensive, and is requiring pain management. I want you to shout out in Turkish or English what this person has and what you're worried about. What's that? What's that? Same here. So let me tell you something. Cellulitis never makes you sick. You don't have unstable vital signs. If you have cellulitis, you rarely have a fever. But if you see unstable vital signs, and if you are giving opioids, this is necrotizing fasciitis. You can see some bruising. This is a young kid, and saw this kid. I don't even care what you think the rash is. If you are hypotensive, tachycardic, with a rash, that is neck fash. And you need to give this broad spectrum antibiotics, some vancomycin, some piptazo, some clindamycin, and get them to see a specialist immediately. This kid, I called plastics. We went straight to the CT scanner. I had done a bedside ultrasound which showed gas, and within 15 minutes, he's in the OR. But the key is, if you write a prescription for morphine for someone with cellulitis, you better assume that they have neck fash. Because cellulitis is just a problem of the epidermis. It doesn't cause pain. If it's painful, there's something deeper going on that you've ignored. So unstable vital signs, and if you're given opioids, you have to think about either a necrotizing cellulitis or a necrotizing fasciitis. Both of these people don't look well. And feel free to scream out, to interrupt me. We've got lots of time. Yeah. What was the culprit? Because his skin, so the question was, what was the cause of the bruising? As you start to kill tissue, you eventually just bruise. Because you go into DIC, and you start just bleeding all over. So he was just in septic shock and starting to bruise all over. I see this kid every summer in Turkey. I wish I was here every summer in Turkey, in Canada. And the key here, who wants to give this kid a prescription for intravenous antibiotics? No. I think we have a major problem, which is somehow people come to see me when they get stung by a bee. Does this ever happen in Turkey? I don't even know why these people are here. And I think the key is that the reason insect bites get infected is because you're dirty. It's because you scratch them. The bee sting, the mosquito bite, they don't cause cellulitis. Humans cause cellulitis. So if someone comes in after a bite or sting, this kid needs an antihistamine, an anti-inflammatory, and ice. No antibiotics. And I say to the parents, it's gonna look worse tomorrow. And if you put a circle around it in pen, tomorrow it's gonna look worse. That's okay. If the story is, I got stung by a bee a week ago, it was totally fine, and now I look like this, that's cellulitis. Cellulitis doesn't happen in 4 hours. That's an allergic reaction. It's another inappropriate use of antibiotics. Apart from being a neglectful father, what rash does my daughter Dylan have? Does anyone know? So Dylan has cutaneous larva migrans. And when you look at her foot, it's like an S shape. It's serpentinous. It's like a thing burrowing her skin. And essentially what had happened is we were in Florida on a holiday and we were playing in the sand. And a dog, typically it's dogs, they pee in the sand, and in that urine there are the larva of this worm, and this gets under your skin. And the hardest part about managing her was how I had to tell her and her 2 siblings that Dylan has a worm crawling through her skin that's going all around. That part was more delicate to manage. But she was treated with something like albendazole or ivermectin, and literally in 2 days the rash was gone. But if you look at pictures of CLM and you don't treat it, that worm will just keep burrowing in your skin. We see CLM in Florida and the Caribbean quite a bit. This is a very important rash. Who knows what this rash is? What's that? You're brave. You're brave. I'm going to come chat with you. What do you think it is?
Hand, like a disease.
Like hand, foot, mouth? Is that what you're saying?
Yes.
Okay. What if I told you the feet and the mouth are normal? What's that?
Just on hand, right?
So it's on his chest and his hands. He's a men who have sex with men. Yes. So this is syphilis, and syphilis is something that we see a lot. Do you have a lot of PrEP? Do you know what PrEP is? PrEP is pre-exposure prophylaxis. So in our men who have sex with men community, a lot of them are on PrEP to prevent HIV. It has done a wonderful job preventing HIV, but people don't use condoms as a result. And we've seen a major surge of syphilis in Ontario and in Canada. What we know about syphilis with our data is 98% is male, and 91% of our syphilis is in men who have sex with men. The most interesting thing for the residents and the learners is you're always taught that syphilis has this chancre on the genitals before. But what's startling is that 85% of women and 65% of men never had the chancre, which means it's not that relevant. It's the classic description of syphilis, but it's not the common presentation. We see tons of this. It often gets misdiagnosed as pityriasis rosacea because it's a rash on the chest. It gets misdiagnosed all the time. Do you see a lot of syphilis in Turkey? Yeah. Let me ask you this. Here's a bonus question. What happens when you treat this person with penicillin? So they have syphilis. You look at this and you're like, you have syphilis. And you give them bendazine penicillin. What happens after you treat them? Do they feel good? They come back the next day with a fever, a headache, and a stiff neck. I see someone nodding. What is that called? Jerish-Herxheimer. So Jerish-Herxheimer means you made the right diagnosis. It's the killing of the spirochete makes them come in with fever and feeling crappy, and you tap yourself on the back, say, I nailed it. Okay, next rash. Of the rashes I show you, this is the second most important rash. The first one is stop treating bilateral cellulitis. And what's the cause of this rash? Remember, this is the dog bite who comes in with an itchy rash, not a painful rash, after the dog bite. What do people think? What's that? So staph infection, okay. I'm going to say he's itchy. Excellent. So this person has contact dermatitis. If you look at the picture, it's very much maps the gauze that it's on. And so many people are allergic to the topical antibiotics, the neomycin, the bacitracin that is put on. But I'm going to make it even simpler. When you see a rash, say to the patient, is it itchy or painful? If the answer is it's itchy, then it's an allergic reaction. Cellulitis isn't itchy. It hurts, it burns, it's irritating. But this is classic, and it's classic, and a lot of the times, again, you just have to say to the person, you don't need antibiotics, stop the bacitracin. And I tell people, because in our culture, everyone likes to put bacitracin on every wound. Remember, there's no data to support this practice. You could put Vaseline on, it would do the exact same stuff. It's just a moist environment for healing in macrophages. If you use Fusidin, you have Fusidin here, that has a lot less reactivity than people who are allergic to neomycin or bacitracin. Go looking for this, because you're going to see it, especially if there's been a break in the skin like you see with the dog bite. Does anyone know what this person has? This is that annoying guy who says his wife told him to come here, hiding behind that, with this rash on his legs. You're going to see this in your practice in people who use heating pads, and sometimes they'll get this on their back. Does anyone know what this is? So this is called erythema ab igni. We see it for people who put their laptops on their legs, or where you will see it is people with chronic back pain who fall asleep with a heating pad on their back. And it's a thermal burn of the back, and it causes this livido-like rash and this brown hemosiderin stain that will never go away. You got this, dude, forever. And it has a small malignant potential for squamous cell. So if you tell people to use heating packs, just tell them, make sure you don't go to sleep with it, put it for brief periods. And you also, it used to be described in people who would sit at campfires and they would burn their shins with repeated heat exposure. Anyway, this is a post-streptococcal rash. Anyone get this one? Okay, so this is guttate psoriasis. And guttate psoriasis, guttate is Latin for drops, and it's 2% of all psoriasis, and it's often the initial presentation. But it happens about 7 to 10 days after strep. What I want to show you is we are a very diverse group here, that everyone has different skin color and different levels of melanin in their skin. This is a person I saw with guttate psoriasis who's Caucasian. And I want you to look at the difference. And what I want you to realize is that you need to know dermatology for everyone. A lot of the dermatology books are just for white people. And they show white people's rash, but they don't show darker rash. And Malone Makwande wrote this great book on minding the gap and showing the way skin presents differently in dark-skinned person. When I saw this rash, I think about it as these are plaques, and if you put all them together on the knee or the elbow, you'd be like, dude, you have psoriasis. Easy. It's harder if you're not familiar with the presentations of different ethnicities. So be mindful of that gap in your skin. And guttate is these classic drops or plaques that, as opposed to being on the extensor surface, are on your body. Okay, tell me, did anyone, this is the woman who's come for the last 24 months. She gets shingles every month. Does that make any sense to you? Zero. It certainly looks like shingles. And the story is it burns. And the story is I get valcyclovir every month, goes away. Does anyone know what she has? So, like in my talk yesterday, I don't know what she has, but I'm pretty sure it looks like shingles. But I know it doesn't make any sense because you can't get shingles every month. So I go on Google and I write recurrent shingles in the buttocks. And this comes up. It says, your doctor is stupid. You have an STD. It's called sacral herpes. Now, if you put this rash in the front, you'd all be like, yeah, they have genital herpes. I want you to think for a second. Think about the way people are intimate. People like to cuddle, people like to spoon. I won't go into any details, I'm in Turkey. But you have to be imaginative, bitches. If this was on the front, you would know this is an STD. That's the same friggin' dermatome. Be creative. This is sacral herpes. You don't need Valtrex. You need to be Valtrexed forever. You need daily suppressive valcyclovir. You have an STD. What happened 2 years ago? Well, I met my partner. Herpes, unfortunately, you got it for life. It's the one thing you never want because you don't shake it. Okay, this is an important one. Kid with the rash, kid who's has sick, kid who has a history of atopic dermatitis. Does anyone know what this is? So this is eczema herpeticum. So what happens here is mom has HSV1. Mom has a cold sore. Child has eczema. Mom is snuggling with child. Herpes plus eczema, eczema herpeticum. And this gives you these painful lesions. Remember, itchy is okay, painful is bad. These are painful lesions which are monomorphic, meaning all the lesions look the same. And this is not impetigo. One of the things you say, oh, maybe it's impetigo, but this kid is sick. And they need IV antivirals, which can precipitate in the renal tubules, so you have to give a lot of fluids. Anyone know what this kid has? This is the one whose father has a doctor in my department who's tried steroids, who's tried pinworms. The kid's not getting better. So this is perianal strep. This is after a strep throat infection. About 6% of children will be positive if you swab their anal region. This is very red, it's very painful. One of the things is we don't like to look at things, oh, a kid has a rash, just try this medication. We don't look. But unlike, this is a very red, painful rash, and in the kid who's not getting better with a diaper dermatitis, swab the bum for strep, and you have to think about treating household contacts. I feel like I'm in a part of the world where you may see more of this than I do. But this is the first time I've seen it. This is a Filipino male who's come in with this abscess on their neck and a recurrent abscess. Does anyone know what this kid has? What's that? Yes. So this kid has scrofula. For me, in Canada, we don't have TB, but I'm going to tell you something. You don't have to travel. You have to look at who are the ethnic groups. Remember, 1 billion people in the world have TB or are carriers. So if you hang out with a high-risk community, you could be exposed to TB. And this person has had this for a year, and it's spreading like wildfire. He's been untreated, living with multiple people, working. He's just exposed the world to TB. No blame, but the point is, I think we're all good at realizing that if someone comes in with a cough and shooting up blood and they're in a high-risk group, you think about TB, but extrapulmonary TB is something you have to worry about. I think I have a couple more. Young woman, arthritis, rash. Anyone got this? You see where I'm focusing on today. This is disseminated gonorrhea. And I think the key thing about disseminated gonorrhea is it happens about 3 to 4 weeks after the initial infection, and there will no longer be urogenital symptoms present. So if you ask her, do you have discharge or odor? She'd be like, no. But if you say, in the last month, have you had an STD-like symptom? She would say yes. And for some reason, it's much more common in women than men. 4 times more common in women than men. And they get this arthritis dermatitis. So they get these hemorrhagic vesicular pustular lesions, and they're just sore joints. And they obviously need treatment. I think we have 2 more. Has anyone seen this, or did anyone get this? This is a homeless guy who came in with bleeding gums and this rash. Erythroderma. What's that? Erythroderma. Okay. Yes, vitamin C. So this is scurvy. And I thought scurvy was something you read about of people who were sailors that's 300 years ago got. I actually saw my first scurvy this year. You will see this in people with precarious social circumstances, and they get these S-shaped hairs. If you zoom in on this photo, you will see that the hairs of the leg are like the letter S. And in between them, they get these perifollicular hemorrhages, and they will often have bleeding gums. And you will see this in your marginalized population. It's not just on sailors who haven't had sunlight and fruit. This is our traveler who's come back with the fever, who doesn't have malaria. What do you got? He has an eschar. There's not many things that cause an eschar. And if you Google search eschar after return from Africa, you find out that he has African tick bite fever. If you work in this part of the world, or you do global health, you're like, yeah, we see this all the time. If you work in Canada, you're like, what the hell is this? If you want to be a good doctor, you need to be able to look after people from all areas of the world. And this is a classic African tick bite fever. I remember I looked it up. I took a picture on my phone. I was so excited, and I called infectious disease, and I said, this is African tick bite fever? He's like, yeah, obviously. He ruined all my excitement. He's like, yeah, everyone knows that. And this was classic. I gave him some doxycycline. I actually called this guy to see how he's doing, because I was really happy. And he was totally fine within a week. And the last rash of the day, rash number 16. Anyone know what this is? This is a person who's on an ACE inhibitor and is on phenytoin dilantin and is sick. And it's a bit of a trap. The trap is, I want you to say that she has angioedema. That's the trap. She doesn't. If you have angioedema from an ACE inhibitor, you don't get a fever, you don't have a systemic rash, your face is swollen, your uvula can be swollen, but you're not sick. She has something called DRESS. Has anyone seen DRESS? Yeah. So DRESS used to be called delayed phenytoin hypersensitivity reaction. It's often started, it's a late effect, so delayed reaction usually after starting phenytoin, and these people are sick, and DRESS stands for drug rash with eosinophilia and systemic symptoms, and they're sick. There's not a lot of rashes that make people sick. In my talk, we talked about neck fash, we talked about DRESS, but most people aren't sick. That's 16. If you got 0, I'm delighted. If you got 16, you're crazy. If you got 8, 4, it doesn't matter. I want to just say thank you so much for having me, for learning with me, and for listening to me in Turkey. I hope to see you all soon. Thank you so much. I'm happy to take any questions about sports, life, anything. Come up, chat with me, because I'm heading to go visit Antalya.
one of those hospitals. This is the night view of Doha, the capital of Qatar, and this is the sea view, because I love sea, and this is a beautiful place. I really invite all of you to come and have a nice time in Qatar. If you have a chance, really you'll love it. Okay, this is very important for me. I have no conflict of interest, so I don't get any money, nobody give me gifts for all these things. Okay, today we're going to talk about ChatGPT and how we use it in the writing and research. And we're going to go through the introduction, application in the medical research, advantages, and of course the most important, limitation and ethics consideration, and future prospect and practical application and recommendation. Before starting the presentation, I just would like to share with you my personal opinion. Actually, I belong to the old school. I'm not sure how many in my batch is here, but during my days, that's we can talk 20, 30 years back, the way we used to get our information, the access to the knowledge or something like that, I used to go, during medical school, I used to go to the library, open my books, search what topics I want with my notes, write down, and then if I get another doubt, I'll open another book, and another book, another book. Within 3-4 hours, I'll end up with 3-4 books in the table, and that is all days. I'm not sure how many of you guys experienced this. And I'll have my notes, I'll summarize it in 4 or 5 pages, and that's done. Things has been changed a lot. Things has been changed in massive way. Now, my son, he's 16 years old, he can do the same job sitting in his room, in his bedroom, wearing pajama, using either laptop or even his phone. Within 10 minutes, he's done. I remember just a couple of weeks back, my daughter, she's 13 years old. She has some project in the school, and she asked my son in the lunchtime, they're discussing something. I said, what's wrong with you? I think she's late to submit that project. So I told her, don't worry, it will be done. I really realized that she's helping her to do the project. So he went to his room, as was I said. After 10 minutes, she finished a bath, and then she went to him. Did you do this? I said, it's in your email. Then I thought, hold on, come here. What's in her email? No, the project. When I saw the project, I was shocked. Now I am head of the Department of Emergency and have been experienced more than 20 years. I cannot do this in 10 minutes, what he did, my son, in 10 minutes. That's really scary. But let us go to the lectures. We'll go back to that. So we're talking about this called generative pre-trained transformer. It is language model developed by the Open Artificial Intelligence. And I think it has been launched somewhere in November 2022, recently. And they use this natural language processing system that uses algorithms to understand and generate a human-like conversation. And that words scare me, actually. And this, you cannot imagine what it can do. It can produce highly coherent, natural sounding text and allow computer to understand the human writing and spoken language, and uses reinforcement learning from human feedback. This is actually, can do anything to you. It can write lyrics of songs. It can write abstract about anything come to your mind. And even it can answer exams. I'm sure if my son uses it in his exams, he can answer his exams while sitting home. That much can do. And it has a lot of application, lot of things to be done. They can do it, which is really scary sometimes. And what happens sometimes, if you ask for a certain article or certain topics, he'll give it to you, and you think this has been given by the most expert, the way they write it, the way presented to you, and then at the end they'll ask you for feedback. Once you give your feedback, it has been programmed in such a way, use your feedback to improve their product. So next time, for example, I want to do an omelet for my wife. So I'll just go how to make an omelet, he'll give me the information, he'll give me everything, then he'll ask me my feedback. So I'll just write my feedback, and then my wife, when she eats the omelet, this is less salt, this is more vegetables. That feedback will improve my performance next time when she asks me to do the omelet. So these guys can make omelet better, like evolving. After 10, 15 times, they'll do the best omelet has been ever done. And this is what actually called reinforcement learning. Every time they have processed some data or some project, they'll improve it. And they're doing it in so fast and so scary point. And they're evolving. The present, what's called, which available publicly, it uses 175 billion parameters. It trained on 570 gigabytes, and ability to learn more novel tasks, which has been mentioned earlier. The previous version, which was like 1.5 billion and trained in 40 gigabyte. And there is a newer version. I don't know, there's more newer now because I finished this presentation 2 days back. I'm not sure what's going on now. So it has like, I'm sure, more advanced than what is going on in GPT-3. This is GPT-4 now. They said it is 82% less likely to respond to requests for disallowed content. And this is very important, actually, disallowed content. And 40% more likely to produce factional responses. We'll go through a little bit of the uses, which has been mentioned earlier here. Language is editing scientific articles and can write literatures and review the health-related topics. It can generate summaries or provide abstracts for articles and can synthesize ideas. It can give you an idea which topic you want to research about, which topic you want to present. Can give you lots of ideas around. And do proofreading and grammar checking and analyze data for scientific purpose. It can be done by this platform. And some of the advantage, it can summarize papers, sometimes can generate plagiarism-free text, which is very important, and has consistency and accuracy in the language, and simplify complex medical information and help in learning unfamiliar topics. And also it can be used as a research engine. I remember like when you start doing researches, so you have to go to the certain site, and this site will redirect you to the other site to get the citation and to get those papers. But in ChatGPT, it's one way. It just gives you everything what you want. And it can identify potential research topics. The main issue actually to start research is to find the topic itself, and those guys are just providing you with different ideas to choose which topic you want to start. And can produce text that's similar to the human author and expert in that field. When you see the product of the ChatGPT, you can imagine or you can think this has been done by the most expert person in that field, but actually this is done by the program which has been downloaded. The other part of the ChatGPT which we have to care of, which is the limitation and ethical consideration. So it is really a tool. It is really, like you can say, way of gaining information, but we have to be very careful in using it, and it has lots of limitation. It actually is not made for only medical field. It's not made for us. We think about it, we are talking about it now because we are in medical field, we are physicians. Those type of access to information and different platforms affect, I'm sure, 100% directly on us as a physician, on our juniors who's learning, the resident, even our patient, our customer who's their patient, their concept of the medical field, their concept of a physician, what the physician can do to them, how they can treat them, what type of medication he can receive. I remember this little bit story out of this topic. 1 week back, I got one patient, he's almost 35 years old, he's hypertensive. He came with me with headache, mild headache and dizziness. His blood pressure was 200 by 120. So I told him, I took history, are you hypertensive? He said, yes. How long? A couple of years. So what happened to your medication? I said, yeah, I'm using medication. Who did describe it to you? Who's your primary physician? He told me he did not see his physician for 1 year. Why? He's not happy with the physician medication, so he started Googling or searching those platforms. He changed his medication 3 times within 1 year. He was not happy with one medication, he changed it to the other medication, and now he's inserting 2 double medication. He Googled it from certain platform, I don't know, ChatGPT or somewhere else, that they advise him this is the best thing for your condition. And doesn't work. His blood pressure is 200 by 120. Then I told him, those things you cannot Google it in the online. The online doesn't know that, for example, you are diabetic hypertensive, your family has high risk of cardiac workup, you are fat, you're obese, you are thin. It doesn't know what's your, your blood works, and you just cannot Google your medication. He said, doctor, it's not only me, everybody's doing the same. And don't think, you'll not lose your job. But I said, it's not a question of losing my job, you're going to lose your life with this one. You cannot just Google medication over the line. And this is what actually, those information has been put in the platform from different sources. Some of them are not even medical, putting the information. I have even seen some papers, some people talking about medical aspect. He's not even have medical background. And this is really scary. The other is it can spread disinformation that based on extraction from available online content. Now, anyone can upload any information belong to his belief, his ethics, his background, and this will be uploaded. And those type of platform, or like ChatGPT or other one, they'll just collect this information, and if you ask for it, they'll just give it to you. They'll just feed you whatever they know. You don't know what type of things are feeding you, but this is what's available to the public. And this information can generate and spread non-medical person in online platform. That's what I said. Like, even non-medical person can put some information related to medicine, and people who have no medical background can use this as really this medical advice, or this is from the expert medical advice, which is actually done by not even experienced person in medical field. And this another issue is the privacy and security. These platforms are open to everybody, and the privacy and security is a big question about that. And data collected may be stored. Whatever, for example, you requesting for certain data, and you present something, this will all be stored. So all your data will be stored, and this also can be used, can be misused for the concern of plagiarism. I did some job, I did some research, I uploaded, then someone else come, take this one, just reframe it and present it as his own. This can be done on those platforms. And the main issue, which I said earlier, is scare me, especially with my child. If you depend on this, even our medical resident will depend on this. The other day I was discussing with one of my colleagues. One resident presented with case presentation. When I saw that case presentation, I was so impressed. I am in the emergency field for more than 20 years. I cannot do this type of things. So I told him, how did you do this? Who helped you? Who's the, for example, other consultant or assistant professor? He said, no, I did it on my own. And we find out some ChatGPT. So people want to start using this, they'll switch this and use this. This is the dangerous. The institution, the what's called critical thinking skills, the communication skills, all will be lost. The humanity, this is my personal, I'm not sure, but please don't misunderstand me. The humanity will be lost. When I sit with you, I discuss with you, I talk to you, we can share information, we can learn. But if you are just sitting over the computer or whatever, getting this information from those platforms, I'm sure 100% has a lot of advantage and has saved a lot of work, a lot of research. But we have to be very, very careful in this. It has other side, which people has to think about it. We are very happy if what can give us, but we have to be worried what can take from us. This is what I think myself. And also, sorry, I went back. The other limitation, lack of accountability. It is just information, it's on the platform, it's your responsibility to take and do whatever you want with it. And cannot differentiate between ethical resources and non-ethical content. This is also one of them. And does not provide a credible, credible citation, and it can provide false citation to prompt, if prompted, and that cannot be found in the medical database. And of course, risk of bias. It depends about who uploaded this information, from where this information came, racial, gender, religious, and also systematic inaccuracies and stereotypes in this language, in the language, influenced by trained data and reflects social and cultural prejudice and the existence of data. This can lead to misunderstanding and spread of harmful and false information. Other than medical field, in general, this can lead to spread of a lot of ideas, lot of ideation, lot of stereotype, you can say. It depends about who uploaded those information. And also that artificial intelligence uses a human annotators to identify and remove offensive content. We said like this one, and this is actually one of the important points, hallucination phenomena. So when using ChatGPT, it will make you convinced that this, for example, product, it is very good, it's the best product you can buy, because they depend their data on the statistics, but not about really the quality. So I can say, okay, I want to buy this car is very nice, nice color, nice engine, nice, but actually, the share, and I want to buy share in that company, but actually the market price of that share is very low. But because the data or lot of feedback that this car is nice, the color is nice, variable color, nice, comfortable, that will give you the false information that this car is good. You have to gain, for example, share in that companies and those type of examples. This is one of the big questions now is asking, since we're using ChatGPT in the research and in writing, can we use it as co-author? This question has been different answer different opinion, and I'm not sure the right answer for that, but some people say like it doesn't even make sense. It is like dignity of science and use of ChatGPT as co-author, and it is fun, but it's not an author. And many scientists disagree with this. But let us see why and how. ChatGPT cannot take responsibility for the content and the integrity of the scientific papers. If you are presenting the paper, they're just providing the information. They're not responsible for what information has given to you, or what is the accuracy or the authenticity or the, what you call say, like the correct information has been given or correct data, and cannot give consent to the term, use, and distribution of the right. And this issue really needs to be discussed and considered. Meanwhile, as we said earlier, we have to use this tool, or we have to use it as a tool or resource in the research process rather than listed as an co-author or author. In the future prospect and practical application, it needs really appropriate protocol and clear guidelines regarding the extent to use and mitigate the risk of associated with ChatGPT. I don't want to say risk, but like concern. License and editorial policies need to be updated, whether GPT can be used in the work or not for research or for writing medical papers or no. And we have to have training separate model to filter the content generated by the language model reinforcement learning with the human feedback. And also the ethical issues is another concern. Here the ChatGPT, what's called ChatGPT, aided in the academic writing. It helped in learning tools and citation and attribution, and we have to understand the limitation while using it. And we have to edit and revise the information which we get from the ChatGPT. And we have, of course, 100%, we have to avoid the plagiarism. What we recommend for the ChatGPT use in academic writing: improve reading and edit, and artificial intelligence generated text thoroughly. We have to really check it out, and we have to close. If you use it, we have to inform. We have to state it that we are using this for a certain purpose, and how extent we use it, how long, what exactly we got from it. We have to declare it. We have to disclose these things. And whatever information we get through them, we have to really verify, and we have to double check it. And multiple AI input can be used. It can be validated and diversified to generate the content. And understand the limitation of AI. It is not substitute for a human expertise and critical thinking. I don't think any platform or any information platform can really replace a human critical thinking, can really replace a human expertise. This is my personal belief. And other from the accommodation, data handling must be secured. Ensure data privacy and security. This is very, very important actually, emergent in the place, and compliance with relevant data protection regulation. And we have to ensure data is ethically sourced and analyze the biases. And for continuous learning, stay updated about the latest advancement and the best practice in AI used academic writing. Still, it is part of our life. Still, it is with us. So we have to really update ourselves with the artificial intelligence and ChatGPT's update. Of course, we're not ignoring it or sub-using it. It is a very useful tool, really very, very helpful tool to be used. And it should be used as adjunct rather than private sources, primary source for the writing process, and always use de-identified patient data to protect the privacy. Disclosure of the use of the ChatGPT is very, very important. We have to disclose that we're using this information, we got it from what source. And cite it when you use the tool or source with the assistance. And AI-generated text must be critically reviewed by medical experts and to validate it before using the content in a clinical or medical consent. I'm sure you have lots of questions. Me too, I have lots of questions, because this topic is really a very interesting topic, since it has a lot of divergence and a lot of different ideas. So we'll keep the questions at the end after the last lectures. And this is part of some of the reference. And this is me if I'm not in emergency doing resuscitation. I love sea, I love to be in the beach. That's why I got you the picture of that. Thank you so much. I think I did not, no need for me to introduce Dr. Sergio. I think he has so many fans here and someone clapping for him. So please welcome Dr. Sergio as associate professor in the Department of Emergency. And once he's ready, I think all those technical issues, but we'll put it in a few seconds. Thank you so much.
Marhaba. Hi everyone. I'm Siju. Without much ado, let me just go straight to my topic. Now, how many students in here? Residents, medical students, undergrads? Oh yeah, quite a fair number. I'm going to actually see, when the topic was initially allotted, I was under the impression I was going to talk more about ChatGPT. But the moment I gave this lecture as a topic, I knew I was in trouble, because the moment I gave this, that was maybe a couple of months back, 3 months back, everything has drastically changed. And now I'm actually modifying it every day, including yesterday evening. So without much further ado, let me just go straight to my topic. And I'm going to start by actually telling you what I'm going to talk to you about. I'm going to talk to you about the current landscape of artificial intelligence in scientific writing. I'm going to talk to you about the good, bad, and ugly of scientific writing using artificial intelligence. We'll go and maybe have some idea about the ethics behind the whole stuff. And Dr. Ibrahim actually made my life much more easier by actually handling all the nuances with regards to the biases. So these are my references, and I would want you to actually take a look at it, because you have the UNESCO, you have the WHO actually coming up with guidelines. The Indian Council for Medical Research has come up with ethics of AI. So you can make use of these, and these has been my references for this session. And the last one is actually an inspirational talk, which I would like you all to hear, the AI dilemma. Now, I'll propose one question to you, everyone who's sitting here, and I want you to think about it to yourself. What do you think artificial intelligence means? What is AI to you? What is AI? See, when you've been hearing about machine learning, you've been hearing about deep learning. See, we've been hearing lots of stuff. It all just boils down to artificial intelligence, machines, computers designed to make your system much more efficient in a way humans are thinking about, so many things. But what I want you to understand is, when someone says AI now, the car is still the same, but the engine has changed drastically. It's changed so drastically over the last couple of years that it's something which I want you to actually embrace or maybe have a look at, because whether you like it or not, it's going to be around you, it's going to be across the board, and you're going to be part of it. So when I say AI, and let me just put just one thing up there. I'm just going to put large language models. You're talking about ChatGPT, I'm going to put large language models. When I say large language models, you're thinking more about text inputs, right? Your text inputs, you put your ChatGPT, but that's not exactly what it is. Every single thing up there is a language. You have text inputs, you have audiovisual inputs, you have sensor data, your GPS data. These are all languages. Now these languages are learning how to talk to each other. Keep that in mind. Keep that in mind when you're actually looking at it. I'll give you 2 examples. So this is a study by Cheng et al. From Singapore. They, to see beyond the brain, conditional diffusion. Simply put, they put a few people together in a room. They showed them a few images. They gave them a visual stimulus. They did their functional MRIs. And the functional MRI was given to an artificial intelligence model, and the artificial intelligence models reconstructed what the functional MRI was looking at. Can you see that? It's quite similar to what they were looking at. If you match it out, I'll give you another example. So this was in 2023 published in Nature Neurosciences. I couldn't get the video from their abstract, but look at the video. So they showed this video to a few people sitting in a room. They did their functional MRIs. They asked the artificial intelligence platform to look at the functional MRI and respond. So it said, I see a girl that looks just like me get hit on her back and get knocked off. So the mind reading machines are here now. So whether you like it or not, the mind reading machines are here. Now, is it a good thing or is it a bad thing? Now that's what we are here to discuss mostly. Is it all bad? How many of you say it's bad? How many of you say it's good? Oh yeah, nice. So let me put it this way. So you're all right. I mean, it's not necessarily bad. You've got all those problems coming up. And Dr. Ibrahim actually went through most of it. It's good in drafting editions. It's good in explaining to you with regards to what you do not know. It takes off the language barrier in most of the non-English speaking countries from where I am from. I can't afford the Elsevier to actually do the drafting for me, but I can actually get ChatGPT to do it for me. I can correct my grammar. It helps me drastically with the way I can actually present my data. Now, I'm going to actually show some extra stuff for the students sitting here. You see, this is one platform which I keep using most of the times. It helps me visualize data. Now, this is orange, and by the way, no conflict of interest, no financial commitments. Just something which I use. So it's simple. You put your data in. You load up your data. You decide to actually. So this is me. I work mostly in snakebite and stroke. And this is snakebite data. So I put it, I want to see what my data looks like. I put a scatter plot. So I have all these options, and I do not know what to actually generate. Maybe, which gives me more informative projections. The AI does that for me. It actually gives me different options to actually scroll through to see what efficiently shows or depicts my data to the general audience. Now that's just one. Earlier when we used to do qualitative studies, we had to sit with the recordings, get the whole recording done and, scribe it down. You have a scribe scribing it down. You go through the data parameters, see what is, and you have the newer analytics softwares which you can use. Yeah, of course, yes. But here I'm just putting it in corpse, and, I have my whole data set ready up for me. That's what they were talking about mostly, about antivenom development, about hypnale. The word cloud is built for me. Now, it took me just that many minutes to actually get it done. Now, I'm doing a PhD in coagulation disorders, so, and doing a literature map to see where my research stands right now. That's me there. How many of you has cited me? Whom did I cite? Earlier, like he was saying, I had to take all these literature, sit down, timeline map them, and then see what happened where. Now, I can do it on a GIF in a press of a button. And for the students sitting here, I'm pretty sure you guys are already doing this. I mean, you have all these, this is Tommy up there. You can actually use AI to actually generate images for you. You want to decide on what kind of a template you want. You want to actually decide on what you say you want to do a study in the near future landscapes. You put it up. You could get the AI to actually edit your slides for you, get your text materials for you. You can actually rewrite the text materials. Maybe if you want to actually have a change in the image, say a brutalistic concrete architectural structure in the Icelandic countryside, it generates it for you. You have a slide made, voila, done. It took me, less than a minute? So, yes, not necessarily. It's going to make, it's going to do this. But is it all good? So that's what I want you to actually, think about, is it all good? So Dr. Ibrahim was actually putting it up in a very nice way. You have the complexity of the review, which this algorithm right now doesn't understand. Probably it will start understanding in the future. I put in something called GIGO out there. Anyone know what GIGO means? Yeah, garbage in, garbage out. You know, you put in garbage, you're going to get garbage. So whatever, it's all pre-trained, right? So your input matters. So whatever you put in, if you don't know what it is, and if you have no clue, and you're going to get garbage out. Now, and with regards to the bias, there's so much biases with regards to confirmation bias, contextual bias. Yeah, you know, these are there. Now, I'll put a picture up there for you. Can you tell me which one is AI generated? Who says it's, let's say, that's A and that's B. Which is AI generated? Why? So, this was me actually putting up an image of saying a very relaxing man on a chair looking at the sunset with a fishing rod in hand. The reason why I put this image up is because it might give you this belief that you're going to make, this AI is going to make your life easier. How many of you feel so? Your life is going to be easier with AI around. Okay, I'm going to put it this way. See, now when, say, we both were students, and he did the particular topic in last 3 minutes using AI. I've been working on it for the past 1 week, and he's giving out a better result. Like it or not, I'm not going to be the guy sitting with a fishing rod. Those days are gone. As technology is going to advance, I'll have to run in his space. Keep that in your mind. You're going to have this problem where you will have to catch up with the technology around you. It's a choice. You can choose whether or not. You can be the Hemingway. You can be the guy sitting with the road. You know, relax, take it on your own pace. It's up to you. But this is a choice which you'll end up making. So, how do you use AI responsibly? Let me put that as the last question. See, this is one thing which I loved. You know, with all new tech around you, all new tech which is coming around you, there's going to be new responsibilities. When the best example which I heard was, you know, the camera phones. You know, data privacy issues, all this came across when you started having small microchipped camera phones around you. So these things are going to change drastically around you. And with all new tech, a new class of responsibility comes, and if the tech is not regulated properly, it's going to end up in a rat race, and the rat race is going to end up bad. Now, I'll put one thing here. You know, this is the interesting paper, Theory of Mind. Theory of Mind. This is by Kosinski. It's in the preprint format. So, if you look at it, you can see. You know what theory of mind is? Theory of mind is what you and I have. You know, the human way of thinking, and able to put, say, unobserved mental states in, spontaneously emerge, but it has seemed to have spontaneously emerged in these large language models. If you put, so ChatGPT was given, ChatGPT performed the best of the lot, and you can see that particular theory of mind has changed over the last, and the time frame, just take a look at the time frame. 2018, 20, nothing happened. 22, 22, 22, 23, March, it was a 3-year-old child, and June of 23, it's a 7-year-old child. So keep that in mind, and it's your responsibility, and you need to know how to use it responsibly. Critical oversight, human oversight. I've just broken it down to 4 different things. 1, critical oversight. 2, transparent reporting. Now, 3, ethical data usage and to be aware about what's happening. Now, I'll tell you why I put it into 4 different things. The critical oversight is quite important in the sense human oversight over this media. I'm thinking about Terminator right now, but I'm pretty sure you need that critical oversight. The second part about ethical, transparent reporting, everyone's talking about it right now, so I'm pretty sure it's going to come, and it's already there. Elsevier has its own guidelines, Springer has one, so right now you have to actually, people are thinking about it. So it's going to come up in a more robust way, and we are learning as we go. Now, the third one, be aware of the biases involved. I want you to be aware of the biases involved in this particular using of AI. Keep that in mind, because if you do not know what you want to, and yesterday in David Carr's lecture, he was actually mentioning, unless you know it, you will not see it. Unless you know it, you will not see it. So if you do not know it, you will not be able to actually see these biases. So you need to know what all biases are involved. I'm not going to go into the details of the same, but still, I want you to actually keep that in mind. And the bottom line is going to be that with all great power, so use it responsibly. Now, keeping that in mind, I want you to actually have an overview with regards to the ethics involved in AI, and the UNESCO WHO guidelines and say the Indian Council of Medical Research guidelines are excellent. And since we are already talking about it in lots and lots of different medias, I think we are in the right direction. I'm going to leave the question about whether we are in the right direction to you. And when you're writing, see, the LCB has got, it's got its AI-assisted technologies in scientific writing. They got Springer's actually having their own policies now. So I'm going to leave that question to you, whether we are in the right direction, because the responsibility resides in you, in using this technology responsibly. With that, that's the last image which I want to show you. This was actually created using DALL-E, Race of Man Against Robot to the Finish Line, as an oil painting with an exploding nebula. Thank you so much for listening. We will have time for questions. Do we have time for questions?
Thank you so much. Yeah, I think we can have some comments.
Thank you.
Thank you so much, Dr. Siva. Actually, we have a couple of minutes because I'm sure you're more interested in lunch now. So any one or two questions we can take for the whole sessions, just raise your hand. Yeah, lady up there. So if you have mic, someone, yeah.
Hello, and thank you for all your presentations. My question is for Dr. Ibrahim Cüneyt, for you. I'm just a beginner in AI, so my question could be a very beginner level. You have mentioned that ChatGPT is fed by so many sources. Do you think it's possible, or maybe it's done already, I'm not sure. Do you think it's possible to develop an app that we can use as doctors to upload all the medical papers that are written by us and use it to reply our questions in that regard? Thank you.
Yeah. Just to confirm, your question is if there is any platform or app can be developed to...
Actually, I don't know if it's developed already, or do you think ChatGPT is good for that use?
To be honest with you, and I'm sure there's no right answer for this because it still is under development, and one of the recommendations which I mentioned in my talks, really it's a tool. It's a very, very useful tool. It's a very, very important tool which has been developed very fast and help in different aspects really, and it helped different professions, especially in the medical field. It is very, very good help, but at the same time it is very, very important to know how to use it, when to use it, how extend to use it. Like for example, I'll just give a very, very simple example. The butter knife or the knife, it is a tool, has been for many years. If I give it to my wife, she can cut apple and make nice fruit salad. If I give it to my 2-year-old child, he can cut his hand. So if this tool has been given to an experienced person, a resident R1 or R2 just starting his life, using this, depending on this, he will lose a lot of things. Confident, communication skills, critical thinking. Yeah, he will get good outcome because not he's the one who did the job, someone else did it for him, and he'll be appreciated and all this, but he will lose the learning. He will lose, the intuitions is what comes from you doing the job, doing learning, doing the research, and getting at the end of it, getting the result. And that, believe me, psychologically, you'll feel more proud of yourself when you did hard work and you get the end product as successful. Other the person who's sitting 5 minutes, 10 minutes and get amazing outcome, but he did nothing, someone else did it for him. it is actually very controversial discussion about this. And to be honest with you, I'm not an expert, an emergency physician. Give me a patient, I can handle critical patient. I'm in emergency for the last 30 years, 25 years. But this is new for all of us. I'm sure when the Dr. Sivas asked who's happy, it is good for us, I saw the hands of all new generation who raised their hand. Maybe I'm eldest among you, but the other little bit elder generation, they kept their hand down. The younger generation are very happy. It is like bright, it's like stars, but it has a risk. It has other side which you have to take care of it. I'm not sure if I answered your question, but I think thank you so much. Any more question or a query?
You could mention whom to the question is and ask your question, sir.
Hello, my question is for Dr. Shizu. I'm Zishan, I'm one of an A&E doctors from Royal Free London. Dr. Shizu, regarding the AI, the concept you have just taught us today, don't you think it is more important for us to conduct more workshops regarding the use of AI in the recent forms, and there should be an inclusion of an AI in academics as we teach the students through the residency program? What do you think of it?
Let me repeat your question. Your question is whether we should include more workshops with AI, right?
AI, how to use an AI in the practice.
Exactly. So I'm going to echo what he just said, and coming back to what I was saying also, using AI responsibly. How do we use it? Now, yes, you're absolutely right. In the sense, we need to have, and I'm pretty sure it's going to come up in the next few months, I guess. You're going to get all these workshops who's actually going to, because see, even, so I've been using artificial intelligence for multiple purposes, including a systematic review recently, but I've been using AI, but it's running so fast, I'm unable to keep up with it. The moment I gave the topic for this lecture here, it's changed so drastically. And for me to actually keep up, and I'm seeing such a big exponential curve that I do not know when's the right time to start, but I think it should be now. Because if we are going to let something grow this exponentially without any responsibility, we will end up in a rat race, which is going to end up in a disaster. So yes, you're right. We need those workshops now, and it is going to be an eye-opener for most of us. Thank you, sir.
Any more question? One more question before lunch? Any ideas? Thank you so much. I think we'll wrap this one, and please, I hope you'll have a nice, tasty lunch. Thank you a lot. Thank you.
Thank you all.
the car and has fallen down onto the curb. And his all other examination is normal. And the question really is whether to do a whole body CT scan for him. So to answer this question, we're going to look at what the current literature tells us to do with regards to this patient. So in UK, we follow the NICE guidance, which is National Institute of Health and Care Excellence, which is an excellent body for us because it has a regularly update on various conditions, and it will have already reviewed the literature and provided guidelines for most conditions. And there is a guideline on major trauma assessment and initial management, which states that for whole body CT scan should be done for multiple injuries and in patients with blunt major trauma and suspected multiple injuries. Patients should not be repositioned during the whole body CT scan, and use the clinical findings and the scanogram to direct CT of the limbs in the adults with limb trauma. So the question here is still, are we going to say that we suspect multiple injuries in this patient with low risk road traffic accident and only a graze and a bruise on a head? Second is a high energy head injury guideline gives a definition for a high energy blunt force trauma. Interestingly, high energy blunt force trauma is not defined within the major trauma guidelines, but it's defined within the high energy head injury guidelines. And it basically states an injury arising, for an example, from a pedestrian struck by a motor vehicle, an occupant being ejected from a motor vehicle, a fall from a height more than a meter or more than 5 stairs, a diving accident, a high-speed motor vehicle collision or rollover motor accident, an accident involving motorized recreational vehicles, a bicycle collision, and any other high-energy mechanism. So it specifically states a pedestrian being struck by a motor vehicle. However, in this case, the history given to us is that he was clipped by a motor vehicle and that he hasn't lost any consciousness. So the question remains whether we would do a whole body CT scan based on what we have read from the NICE guidance. Looking at further literature, there has been an attempt to answer this question by Richa Arora and Abhishek Arora, where they looked at a retrospective analysis of 150 cases of polytrauma who underwent a whole body CT scan in 2017. It was a single center tertiary care major trauma center in North England. And of those 150 patients, including in that study, the whole body CT scan was positive in 46 patients, that is in 104 patients, while 46 patients, the 30%, had normal scans with no trauma-related pathology. The 25 scan requests were made due to high-risk mechanism of injury with no obvious clinical concern and were found to be normal in 20 cases and showed very subtle injuries in the other 5. So the authors concluded that a good clinical examination can reduce the high number of unnecessary high dose of whole body CT scans. So the question still remains whether we would do a whole body CT scan on our patient or not. Looking further, there is a further analysis of whole body CT trauma based just on the mechanism of injury, or an analysis of more than 3,900 patients at a tertiary trauma center. And this is from a retrospective cohort analysis of over 10 years from a single center in Australia. And in these 3,920 patients who met the inclusion criteria, about 40% had a positive CT scan. This is an important confounding factor to consider when looking at the literature with regards to the trauma CT scans. It is the positive rate which determines what the thresholds has been used to actually conduct the CT scan in the first place. So in the first study, we had a positive rate of 70%. In the second study, we have a positive rate of 40%. So they already had a relatively low threshold to actually do CT scans. However, the authors concluded that in high-energy trauma, they should consider the whole-body CT scan based on the mechanism of injury alone, regardless of the clinical examination findings. So the question still remains whether we would do a whole-body CT scan for our index patient. Looking further, we have an outcome of doing a selective CT scan versus pan-CT, which is a whole-body CT scan in elderly trauma patients, a retrospective analysis of a level 1 trauma center in the United Kingdom. So these analyses looked at 481 patients who underwent the whole-body CT scan or a selective CT scan in 2018, divided into multi-system injuries and single-system injuries. So this is a retrospective analysis from a trauma audit which is done nationally in United Kingdom. So what they did was they looked at a whole 1 year's worth of patients, and they classified into multi-system injuries and single-system injuries, and then they looked at how many of those patients had a whole-body CT scan and how many of them had a selective CT scan. The whole-body CT scan defined as pan-CT in this study. So it was a single-center tertiary care major trauma center in England, and interestingly, what they found that within the single-system injuries, when comparing the pan-CT with the single system CT, there was no change in the mortality. However, there was a significant change in the length of stay between the two groups. The ones who underwent a single system CT, there was a significant number of patients who had longer length of stay. So the question still remains whether to do a whole-body CT scan or not for our index patient. So our own experience at North Manchester, a colleague of mine reviewed retrospectively the presence of injury in elderly patients who had undergone whole-body trauma CT. 66 elderly patients underwent a whole-body CT scan over a 12-month period, and of which 39%, again comparable to the Australian study, had injuries identified on the CT scan. 86% were due to ground-level falls. The remaining cases were due to falling down the steps or a low-speed road traffic accident, similar to what we have. So the question still remains whether to do a whole-body CT scan in our patient or not. At this stage, I would want to take a view from our audience. How many of you would want to do a whole-body CT scan on this index patient? Please raise your hands. So we have 2, 3, 4. So we have got about 5 people in the room who would want to do a whole-body CT scan on this patient. So indeed, this patient actually underwent a whole-body CT scan, and we found that he had 3 rib fractures, a small pneumothorax in the chest, and 2 stable fractures in his lumbar vertebrae in abdomen. His head CT scan was normal, as was his x-rays of his thigh, where the superficial injuries were there. So the patient was admitted to the trauma ward in a major trauma center after being transferred there and was discharged 48 hours later without any procedural intervention with rehabilitation and physiotherapy follow-up. So he was treated conservatively with no further intervention into his care. So conclusions, history matters. What we thought initially when we started that he was clipped by a car, i.e. on the side of the car that he was hit and he's fallen down. In reality, He was hit in the front of the car from what we see from the injuries. And he has hit his head on the bonnet and then he's fallen down on the ground. And these things matter. The exact mechanism of injury matters in trauma. At this stage, I would want to remind you of another case where a 12-year-old presented to an emergency department with a history of falling from a trampoline. Now, history was documented at triage, fall from a trampoline. She has walked in, she was examined, and she was then discharged. In reality, the child had actually had a fall after jumping on the trampoline into the air and then landing onto the ground. So rather than a fall from just a 2 foot high from a trampoline, it was actually a fall from more than the child's height after going up in the air from the trampoline and then landing onto the ground. And unfortunately, the child was then later diagnosed with lumbar vertebral fractures, which were unstable and led to a spinal cord injury with paraplegia. So mechanism of injury in trauma matters, particularly in terms of the history taking. And when in doubt, consider the whole body CT scan. So mechanism of injury should be elicited diligently in hemodynamically stable patients with no identifiable body injury. The evidence of superficial injuries in 2 areas of body should raise suspicion and consideration for whole body CT scan. So this is the top tip here. This gentleman had a bruise on his head and a graze on his thigh, which alerted us to think that the body in the middle could have sustained an injury because there were 2 body parts which had contact with some form of blunt force trauma, whether it is from the bonnet or whether it is from lying down on the ground. We presume that the thigh injury is from the front of the car, and head is actually from him hitting his head on the bonnet of the car. In settings with adequate resources, the whole body CT scan should be considered irrespective of the examination findings in high energy blunt force trauma as defined by NICE, which includes pedestrian versus car accident of any speed in any setting with any history. If the car has hit a pedestrian, they should get a whole body CT scan irrespective of the examination findings. And in elderly patients with a fall from standing height, because in elderly patients, fall from standing height generates enough energy for sustaining significant injury. However, in the settings where there are not adequate resources, then there could be a consideration for admission and a decision about the CT scan next day, because as we identified from the last study, the actual difference between a pan-CT and a selective CT is very much dependent on the length of stay rather than the mortality effect, especially in the hemodynamically stable settings. In the settings where we are, whole body CT scan is much more cost effective compared to actually admission into the hospital. These are the references which I have quoted during the talk. I'll take any questions if you have.
Any questions from the crowd? We have 2 minutes. If not, we'll move to the next session.
Thank you very much. So I'm also moderating this session, and I would like to introduce the next speaker, Dr. Vimal Pillai. He's professor of emergency medicine at Kasturba Medical College in India, and his skills include the coordinator for the Medical Simulation Center at Kasturba Medical College as well, and he's also a governing council member of Academic College of Emergency Experts in India. And he's going to be talking to us today about taming the bleed, viscoelastic assays in emergency medicine.
Thank you, Dr. Himanshu. Welcome, everyone. I guess we all had a big lunch, so we'll try to keep it interactive. I'm going to talk about, I'm a emergency physician working in India. I work in Kasturba Medical College. I've got no financial disclosures for this talk other than the fact that I've been teaching resuscitation courses in trauma for more than a decade now. So what am I dealing with? I'm going to start off with an index case like before. So it's 3 a.m. in the emergency department. The usual story for all emergency physicians out here. Can I have a show of hands, people working in the emergency department? Okay, residents in the Department of Emergency Medicine here. Okay, I've got a few residents in emergency medicine too. Perfect, perfect. I think you guys will make more use of this than the others. So you've got it's a typical case. It's a case that I've managed last month. 3 a.m. in the morning, you get a young male head-on collision, comes on with some patterned aberrations over the chest, a big swollen thigh on the left side. The limb length is also discrete. Now he comes completely altered. How do you manage? I think people might talk about ATLS. Yes, sir. Perfect. Agreed, the musculoskeletal component. He's also altered. So you're thinking a brain injury part, so you want a CT scan done. Excellent. So we went on with that. The challenge here, however, is that the triage nurse comes to me and tells me, so the patient is in shock despite giving fluids. We do give a lot of fluids in the emergency department. The patient's still in shock. Now that's going to ring a bell somewhere. What are we going to do for a patient who is persistently in shock? You want to give blood. You're thinking blood, right? You're thinking some strategies to reduce the bleed, right? So we'll talk about how you can change your thought process for managing a refractory shocky patient post-trauma. Emergency medicine is nothing but you recognize patterns, you translate the knowledge that you have, and you have the courage to take the best decision based on the limited knowledge you have at that point in time. Because retrospectively, and I'll tell this to all residents in the room, retrospectively, every other consultant would come to the ER and say, you didn't know this? Retrospectively, they'd come down and say, we had more information, you guys didn't do this in the beginning. So that's a curse that we're born with, the responsibility that we have to work with limited information. We'll talk about some newer strategies in managing hemorrhagic shock. We'll talk about a case-based approach, something that I do day in, day out for hemorrhagic shock in the emergency department. Shock, we all know, it's inadequate perfusion to the tissue. It's not just a low BP. We know that trauma is a leading cause of mortality. There are stalwarts managing trauma in this very room, and you'll hear from them in a bit. Trauma, it just doesn't kill, it kills more than 40% of the world. It just leads to poor quality of life. And that is the reason we just don't need buildings for trauma care. We just need processes in place, systems in place for trauma right from the field to rehabilitation. That is what the focus should be. There's a need for rapid intervention in identifying and managing shock, specifically in the polytrauma victim. The biggest challenge that we have when you're managing trauma hemorrhagic shock is trauma coagulopathy. Now there are different definitions for this. I believe even here in this land, you would have multiple semantics for defining hemorrhagic shock in trauma. Some people would call it as acute coagulopathy of traumatic shock. That is there over there at the edge. The endpoint is the same. All roads lead to Rome. Ultimately, it's about hemorrhage The more we resuscitate with saline, it creates more problems. If you don't get blood very quickly. The shock that you have is made worse by the hypothermia in your setting. All emergency departments are cold places, right? The shock that you have is worsened by the acidemia that you have in that place. Your triad kicks in, your death triad kicks in with severe acidemia and hypothermia leading to coagulopathy. The dilution that we induce on the patient by pushing in a lot of saline is another component. Not to forget the inflammation, the medications that the person's already on, and the genetics part. Now, we are living in an era of longevity. We are living in an era where we are treating more and more elderly, older people. People who are on oral anticoagulants, newer oral anticoagulants, newer antiplatelets, newer drugs, which can lead to more bleeding, specifically in our part of the world. There is a huge focus. The focus earlier when we were doing residency a long while back was on products. You order for blood, you get pack A with a certain ratio of blood, plasma, platelet, and cryo if required. You order pack B, you get a certain pack, and it's time delineated packages. Now the focus has to move from the product to the patient. If you look at transfusion medicine societies right now, they are focusing on the patient. That's why there is a big domain of patient blood management, PBM. We are moving from massive transfusion protocol to massive hemorrhage protocol, where a systematic and a coordinated delivery of care to the patient is focused on. What are the benefits? It reduces wastage, it improves the interprofessional communication, it standardizes the process, there is faster blood reception, and more importantly, it reduces the variability in your treatment. The biggest challenge that we have is how do you establish it? How do you make it work? The 7 T's, I call it the Magnificent 7 protocol, is the way forward. How do you do that? T, first, how do you trigger your massive hemorrhage protocol in your setting? You got to work on that. There are different stratification scores which have come in to trigger a massive hemorrhage protocol. There is an RABT score, there is an ABC score. Converge on a score that is accepted by your university, by your hospital, by your setting. Team prep and performance. It's important to sim again with all the stakeholders. You've got to get the transfusion medicine in. You've got to get the blood bank in. You've got to get the buy-in from the trauma surgeon. You've got to get the buy-in from the emergency physician. You've got to get the buy-in from the critical care physician. You've got to get the buy-in from the nurses. You've got to get a buy-in from the ancillary care lab guys. You've got to get a buy-in from all these people together to run a system. So team prep and performance in advance. Tranexamic acid, I don't need to specify more about it. It's come into literature. It's proven its benefit again and again. We need to test early. We'll focus on testing. We'll focus on transfusion to target in a bit. We need to manage temperature. Hypothermia in itself, we know, aggravates the insult. It worsens the coagulopathy. And finally, how do you terminate a protocol? I remember days where I've started or initiated transfusion. I've given 130 units of blood in a lady who's come in with PPH in the emergency department. Finally lost her in the OR room. The challenge is who closes the protocol? Who closes the call for transfusion? Is it the emergency medicine person? Is it the trauma surgeon? Is it the gynecologist who comes in? Is it the interventional radiology team which comes in? We need to figure that out too. So the 70s protocol here, what I'm going to do is I'm going to focus on 2 aspects here. The early testing and the transfusion targets. We're going to refine the way in which we're going to transfuse blood, one of the most precious commodities. How are we going to do that? We're going to do a dynamic strategy. And what do I mean by dynamic strategy? Everybody here, show of hands, how many people are doing PT, INR, APTT in your setting? Platelets, PT, INR, APTT, and fibrinogen in your setting in the hospital for coagulopathy? I guess everyone in the room. Anybody who's doing any dynamic testing, ROTEM or TEG? I think that is going to be the point of care test for hemorrhagic shock. This is the ECG for hemorrhagic shock for your trauma patient, for your polytrauma patient. And I'll tell you why. If you look at viscoelastic hemostatic assays, they give you a dynamic opinion of where you are in the cascade, whether you've got a hypocoagulability, whether you're hypercoagulable, whether you need cryoprecipitate, whether you need platelet, or you just need fresh frozen plasma. It's as simple as that. Who decides on the product? It is a patient who decides on the product. It is not the protocol of your hospital that decides, I need to give this patient pack A or I need to give this patient pack B. It should be the patient's hemodynamic status. It should be the patient's coagulopathy status which tells you, you need to give him more cryo. For example, all our PPHs need cryo earlier because we know that pregnancy leads to that state where your fibrinogen levels could be a little low. So the way you manage a PPH could be entirely and starkly different from the way you manage a polytrauma shock. And that could be entirely different from the way you manage an upper GI bleed in a decompensated liver disease with portal hypertension in the emergency department. Again, 3 hemorrhagic shock, 3 different flavors, 3 different ways in which you're going to transfuse blood. That is the dynamic strategy. More importantly, I want you to focus on the last line here. The ratio-based transfusion that everyone in this room is doing will be replaced by periodic testing massive hemorrhagic protocols in this decade. Write it down. By 2030, all trauma care systems, all emergency systems would move to massive hemorrhage protocol, which is a lab-based approach where you look at patients, where you look at strategizing blood product delivery to patients based on their coagulopathy status. A patient's going to dictate terms, not the protocol which is fixed in the hospital. Now, how do you do that? You need to look into using TEG or ROTEM. So my center, I use TEG. I have no financial disclosures. I don't work for any company. Thromboelastography is something that we worked on, not just for shock. We do a lot of TEG for snake bites. And 3 years back, we have a pandemic. I hope people still remember COVID. We used a lot of TEG during COVID, and it made a huge difference for us because COVID is a hypercoagulable state, and it helped us treat patients better. So we'll look into how it guides transfusion therapy. We look into how you get objective evidence for endpoints of resuscitation. Now, when you start blood transfusion, the biggest challenge for us is how do you alter the dynamics of blood transfusion from paper to the patient who comes in with shock. The biggest challenge for us is we depend on lactates. We depend on endpoints for perfusion parameters, which might not be the foolproof method. For example, you continue giving fresh frozen plasma or even platelets or let's say other parameters other than cryo to a hemorrhagic shocky patient post-partum, it is going to be catastrophic. You are going to end up with a patient with possible transfusion-associated circulatory overload TACO and transfusion-associated lung injury. And we've burnt our fingers enough to know that you need to go for cryo early. Same thing with upper GI bleeds. You need to ensure that thrombocytopenia is not your target. Your target is the coagulopathy that the patient is coming with. And that can be worsened with our volume resuscitation in the emergency department. You need to dictate terms on how you can correct the same. Now, if you look into the method, it's all in a cup. I call it the cup and pin method. You take in a cup, a pre-warmed cup, either the cup rotates or the pin rotates. You have a shear strain on the cup. It forms a clot, a thin clot, and you measure the clot stability. The mechanical activity is converted into electrical activity. Where have you heard of that? Residents in the room? ECG. You look at mechanical activity or electrical activity and you convert it into some mechanical activity on a piece of paper, right? So this is what happens with this also. You basically look into the formation of clot, the time to formation of clot, the rate of formation of clot, and the stability of the clot. Now, what do you get? You get something called a graph in TEG. Thromboelastography gives you a graph. You start off with vessel injury, and then you form an immature clot. You have the R time or the reaction time. For the residents in the room, R time is reaction time or the time to clot formation. You have the K time, which is a pre-specified clot strength or the strength of the clot. You have the alpha angle, which is a rate of formation of the clot. You have the maximum amplitude or MA, which tells you that it's a very mature clot. The clot is strong on its own. And you have lysis at 30. Now, it has implications not just in trauma, but we in our region, we've got a lot of hump-nose pit viper bites, pit vipers. They do lead to a lot of coagulation problems with us. COVID has led to a lot of coagulation problems. Again, we could have a lot of solutions to how to manage patients using this. Now, if you look at the first half, that leads to the clot formation part. And if you look at the second part, that leads to the fibrinolysis part. Now what we need to do is, we need to use these parameters to just check up where your patient is. Is he in the clot formation pathway or is he in the fibrinolytic pathway? Where is he in that balance? I'm not talking about static parameters where you look at one fibrinogen level value and the fibrinogen is very low. But the time which is passed when you get that value in hand, the patient would have received more blood, more fluid, and would have passed that strategy long ago. So you need to think of dynamic strategies here. So just to look at normal parameters, your R time would be 5 to 10 minutes. You treat it with FFP if your R time has a problem. Your K time, your kinetics time, it is a fixed strength of the clot. Your problem is with fibrinogen, you need to give cryo. If you have the alpha angle which is deranged, you think of cryo again because it's a fibrinogen problem, stabilization, strengthening of the clot. Now the next two, the lysis at 30 minutes would be because of fibrinolysis. So if that is excess, you need to think of tranexamic acid or caprioic acid, epsilon aminocaprioic acid. Now maximum amplitude, you need to think of platelet dysfunctions also. So we had reviewed this in dengue patients with hemorrhagic shock. It's another important entity that this thing would help with. Now, let's look at a rough estimate for the learners in the room. The R time, the K time, and the alpha angle, if it's increased, you have hypocoagulability. The maximum amplitude and the lysis, if it's increasing, you have hypercoagulability. Let's get this straight. Now we're going to move into two cases, just two simple cases. We're going to figure out how this is going to help us. Now the first case is the index case which I started with. It's 3 a.m. It's an emergency department which is quite busy even at 3. I have that patient coming in post-trauma, young male, 23-year-old male, belligerent, completely drunk, post-trauma. We're thinking head injury. We're thinking hemorrhagic shock. The nurse keeps telling me, sir, he is still in shock. What do you do next? I try to give blood. I give 1 pack of blood. At the same time, I send a TEG. What does a TEG tell me? TEG tells me this. If you look at the graph, it might appear a little alien to you because you're not seeing it on a regular basis. I want you to focus on the...
5 minutes warning.
I wanted to focus on the table below. If you look at the table, your R time, your K time is a little deranged. Your alpha angle is normal. Your maximum amplitude has come down. Your lysis has gone up. That means it is lysing a lot. That means you are in a hypocoagulable state. That means this is suggestive of early trauma-induced coagulopathy in trauma. Polytrauma patient with early trauma-induced coagulopathy. Mind you, giving blood alone will not help. You need to think of cryo early in this case, not just plasma. Now next case, elderly male, upper GI bleed, almost 300 ml of blood he vomits out. He's a known decompensated chronic liver disease. We're thinking shock, elderly male with a BP of 90/60, residents in the room, would definitely manage with fluids and then ask for blood. The moment I sent a TEG for him, I did the same. I did the initial resuscitation. He was bleeding too much. I did initiate the massive transfusion or hemorrhage protocol. In our setting, we gave PPIs, we gave octreotide. I asked for the SB tube so that I can place off the Sengstaken Blakemore tube to prevent more bleeding. And then I checked up on the values, severe shock, hemorrhagic, hypo, you've got platelets which are on the lower side too with an APTT more than 120, static value. I sent for the TEG, it turned out to be like this. If you look at the values, again, the lysis is happening at a high level, at an extremely high level, the lysis is happening, and then you have the MA on the lower side. Again, suggestive of hypocoagulability. Again, you need to think of adding platelets and cryo and not just blood. If you keep on giving FFP, fresh frozen plasma for him, it's not going to help him. So the 70s we reviewed, I focus on only 2 aspects because of lack of time. And those 2 aspects are testing early and target to transfusion. But trauma is a different beast. It's just too difficult to manage trauma on a regular basis, day in, day out, if you don't have a well-oiled system. We'll talk about well-oiled systems in a bit. So what do? You need to get all the stakeholders to the table, bring in everyone, including interventional radiology, to the table, talk to them, get towards a protocol that you can implement in your department. Have a policy, have a protocol, and more importantly, you have to ensure that your policy is implemented and your protocol is implemented well. ensure that the processes are in place, create a simulation team where you can collaborate more and more with the whole team, and avoid a one-size-fits-all. Me bleeding a lot might be very different from you bleeding. And us having an understanding of what differences are there for us to transfuse blood would lead to that life being saved. Ultimately, it's about periodic testing and accelerated diagnostic protocols incorporating viscoelastic hemostatic assays. That would make a huge difference in managing hemorrhagic shock in your trauma center, in your emergency department. And it's high time we move from static to dynamic protocols. Ultimately, it's about not being blind in resuscitation, not being blind in hemorrhagic shock, but being able to visualize what is dynamically happening with them. And that in itself will make a difference. And like what our father of our nation, Bapuji Gandhiji, says, it's about what differences you make. You need to make a change to create a change in the world. Thank you for your patient listening. You can have my references from this QR code.
We have 2 minutes for any questions.
Like me, much of this room is working in the emergency department. Also in emergency, when we saw the hemorrhagic shock trauma, our main goal as soon as possible to send the patient to surgery room. So we generally have less time with the patient instead of rare cases. So what do you think about? Also, you mentioned that hypocoagulopathy is more risk for these patients in hemorrhagic shock. To use in a sudden time synthetic factor X3s for coagulopathy. What do you think about?
Right. Thank you, sir, for your question. Very pertinent. You have little time with you before you transfer the patient. The rapid tech that we do in our institute, it takes 20 minutes. It's a point of care test. Like a blood gas that you send, blood gas is even more quicker. But a point of care test which gives you information in 20 minutes rather than 4 hours, where you get a PTNR, APTT, platelet, CBC later, would give you enough time to do something in the beginning itself. And it's important to do things in the beginning well. Because if you do things in the beginning well, you would let down or bring down the number of days a patient presence inside or stays inside the hospital, stays inside the ICU, stays on the ventilator also down. So your surgeons would definitely be helpful or thankful to you guys doing the right thing in the beginning. So maybe this is the way forward. Thank you again.
Thank you, Dr. Pillai.
Thank you.
So we now have a next talk on lethal hyperkalemia during massive transfusion protocol after preservation period of red blood cell products was extended.
Mizobata. Mizobata. Oh, sorry. Welcoming Professor Mizobata, who is Professor of Trauma Critical Care Systems in Osaka University, in Osaka Metropolitan University, Japan.
Thank you. I'm Mizobata from Japan, and I appreciate for EPAT and Wacem for giving me this opportunity to present my study. And also thank you for Professor Himanshu and Professor Bimal to moderate this session. But first, I have no COI for today's presentation to be declared. Massive transfusion protocol is one of the effective procedures to improve survival rate in the severely hemorrhagic patients. There are several reports that the 1:1:2 ratio of transfusion of FFP, platelet, and RBC improves mortality of trauma patients in the studies using historical comparison design. In our institute, we implemented the MTP 10 years ago, and we enabled quick start of transfusion and keep 1:1 blood product ratio. In Japan, the Japanese Red Cross Society is working on the blood donation system and the supply of blood products to hospitals. Recently, the society issued a notice of their approval to extend the preservation period of red blood cell product. This extension is, of course, evidence-based and mainly promulgated to reduce costs and avoid the destruction of limited resources. However, when massive transfusions are administered under the massive transfusion protocol to treat hemorrhagic patients, the incidence of adverse events related to this change are not well known. We report our experiences with 2 cases of critical hyperkalemia during trauma resuscitation with massive transfusion protocol. Case 1 is 24-year-old Asian man who was transported to our hospital after having been stabbed his right posterior chest by a housemate. On his hospital arrival, the airway was maintained spontaneously, respiratory rate was 30 breaths per minute, blood pressure was unmeasurable, but the pulse of the femoral artery was palpable. Heart rate was regular at 136 beats per minute. Glasgow Coma Scale was E3V1M5, and his body temperature was 36.1 Celsius. After we found a massive hemothorax on his right side chest via focused assessment with sonography for trauma, first, we immediately performed tube tracheostomy and activated MTP with the use of O-positive RBCs within 3 minutes after his arrival. In our hospital, 20 units of O-positive RBC are stocked in the emergency room for the emergency requirement. The surgery started 17 minutes after his arrival. During the surgery, we found a penetrating injury in the proximal region of the inferior lobe of the lung and rapidly performed non-segmental lobectomy under the use of a Hyla clamp. However, even though quick hemorrhage control has been obtained within 35 minutes after the patient's arrival, he went into ventricular fibrillation during the surgery. The arterial blood gas analysis were performed 8 minutes and 35 minutes after the arrival. This is 8 minutes after the ventricular fibrillation. Arterial pH decreased from 7.37 to 7.14 with the elevation of blood lactate level. The potassium concentration increased from 3.5 to 8.9 milliequivalent per liter. This elevation of the potassium concentration was supposed to be the cause of the lethal arrhythmia. The amount of blood products used at this time were 8 units of RBCs, 12 units of FFP, and 10 units of platelet concentrate. The calcium-ion products were not yet administered when ventricular fibrillation was observed. The patient could not be resuscitated even with the full use of considerable resuscitative options, including the calcium ion product. Next case is a 44-year-old Asian man. When he was riding on his motorcycle, he ran out to the opposite lane and had head-on crash with a car. He had no helmet and was transferred to a hospital. On hospital arrival, the patient's airway was maintained spontaneously, respiratory rate was 30 breaths per minute, blood pressure was 98/87 millimeter Hg, with a palpable left femoral artery pulse. Heart rate was regular at 138 beats per minute. Glasgow Coma Scale was E1, V1, M2, and his body temperature was 36.1 Celsius. We found a left pneumothorax and fluid correction at the Morrison fossa as a perispring area in the first examination. Then we started blood transfusion with activation of the MTP. As the patient's hemodynamics completely collapsed, left tube tracheostomy was immediately performed, and we prepared to open the patient's abdomen in the resuscitation unit. During the preparation for surgery, as we also obtained radiological information about the concomitant severe pelvic fracture, we initiated resuscitative endovascular balloon occlusion of the aorta lever, but didn't inflate the balloon yet. The patient's abdomen was opened 35 minutes after arrival. The operative findings were minor liver laceration, intramesenteric hematoma, small bowel perforation, and minor splenic injury. Following the damage control strategy, we focused on hemorrhage control with hemostatic agent, Surgicel, and peripheral and perisplenic packing and ligation of the mesenteric vessels, and also we minimized contamination. We finished the operation with open abdomen management using Abcera. However, although the patient's hemodynamics once appeared to stabilize, he suddenly went into ventricular fibrillation 2 minutes after the surgery. The blood gas analysis had been measured 1 minute before the arrhythmia. This was 46 minutes after the start of the transfusion. Arterial pH was low on his arrival with high blood lactate level. The potassium concentration increased from 3.5 to 7.8 ml equivalent per liter. This elevation of the potassium concentration was supposed to be the cause of lethal arrhythmia. The amount of blood product delivered at this time were 12 units of RBC, 12 units of FFP, and 20 units of platelet concentrate. The calcium ion products were not yet administered when ventricular fibrillation was observed. Although the patient was returned to spontaneous circulation and subsequently underwent an interventional radiology procedure, he died from massive multifocal bleeding due to subsequent coagulopathy. The CT images after the IVR demonstrated the intrathoracic, intra-abdominal, and retroperitoneal hemorrhage after the surgery and IVR are not so obvious. MTP is already globally well-known one of the main procedures for achieving success in trauma resuscitation. Recently, although the several protocols for the guidance of massive blood transfusion, such as goal-directed transfusion by using thromboelastography, have been proposed. We traditionally assume that most of the high-level trauma centers, including ours, follow the RBC, FFE, PC 1:1:1 ratio theory based on the previously reported evidence. In our institute, blood product including cryoprecipitate is always available, and once MTP is activated, packages are constantly brought to the resuscitation unit to maintain the ratio of composition as shown on the slide. We usually administer blood transfusion with the use of level 1 fast flow fluid warning system from the peripheral vein by a 16 gauge or larger size needle. In 2023, the Japanese Red Cross Society issued a notice of their approval from the nation to extend the preservation period of RBC product. Since then, the validity period of RBC products have been prolonged from 21 days to 28 days after the blood has been drawn. Previously, the Japanese Red Cross Society had published in their guidelines that the potassium concentration in RBC products after the blood has been drawn is 36.3, 4.8 milliequivalent per liter at 7 days, and that it increases to 60.3 in 28 days. To combat this problem, we currently can only check blood gas values constantly at approximately 15 to 30 minute intervals, use a calcium chloride preparation more frequently, and prepare washed RBC product if available. The option to use a potassium absorption filter is also available, but the filter needs to be exchanged at an interval of every 4 units delivered according to the manufacturer's documentation. In conclusion, we experienced 2 cases of critical hyperkalemia during MTP after the allowance of extend the preservation period of RBC products was granted. Although there might be several other factors involved in the increase of potassium in these patients, we consider it is important to pay attention to these unexpectedly rapid increase in potassium levels during MTP to those who perform MTP with the use of current RBC products. Thank you very much.
Thank you, Professor Misabata. Any questions for Professor Misabata? There are no questions? No. There's one, yeah.
How practical, thank you for the excellent presentation, but how practical changing the filter for the potassium during a perfusion every 4 hours, and the amount of blood transfusion in this patient is quite extensive. So how practical changing, potassium filter to capture all the excess potassium?
Thank you very much. Yes, I know that the filter for the potassium is recommended to change every 4 units. But it is thought to use in the ICU or in the ward. For the mass transfusion protocol, the 4 units of RBC is infused very rapidly. So it is not practical to change the filter. And we are talking about the blood laboratory to use the washed RBC, but it takes times 20 or 30 minutes to prepare the washed RBC, so it is not practical yet. So now we are thinking about change the calcium administration. Before these 2 cases, our protocol was administer calcium ion every 10 units of RBC. But now we change the protocol to check the potassium level and calcium level every 15 to 30 minutes and administer the calcium ion to prohibit the elevation of the potassium ion level. Thank you. Thank you very much.
Thank you, Professor Mizabata. For the last talk on the session in trauma, we have Professor Dr. Hassan Al-Thani, head of Trauma and Vascular Surgery Section at Hamad General Hospital, Qatar, who will be talking about acute kidney injury in trauma. What do we know? Over to you, sir.
Thank you. I would like to take the opportunity to thank the organizing committee for the privilege of the podium and also for the kind invitation and the exciting program. As usual, they never fail me to see an exciting program. This is what Sagar recommended that we have to put the slides. So my name is Hassan Al-Thani. I'm from Doha, Qatar. I have nothing to disclose for this presentation except that I am working in Hamad Medical Corporation. So the specific objective of this is to review the pattern, the predisposing factor, and the outcome of acute kidney injury in a trauma patient. As we know, worldwide, the burden of kidney disease is rising, but the public awareness remains limited, and the public, including physicians, underscoring the need for effective communication by the stakeholder in the kidney health community. The incidence and the predisposing factor for acute kidney injury among patients sustaining a major trauma injury are not well studied. So the theoretical model for kidney disease in a trauma is, or in general, is usually we start with a normal kidney, then we have a raise in the kidney function, then the damage, and then the decrease in the glomerular filtration rate, ending with kidney failure. So with the damage, the GFR start to decrease, and then the damage actually start to increase. With that, the complication start to build up, ending with the mortality of the patient. So the pathophysiology of acute kidney injury in a trauma setting is a similar things. We actually give a contrast for these patients when they come for scanning. We have a tissue damage, we have hemorrhagic shock, we have rhabdomyolysis and abdominal compartment syndrome, as well as the excessive fluid that we give the patient. There is a ischemia, reperfusion injury, hypovolemia, myoglobin is produced, systemic inflammatory process, renal oxidative stress, and then intrarenal vasoconstriction, and the abdomen compartment will result also in renal parenchymal effect with the renal vein compression and actually compromise. And then we'll have the excess of fluid with renal edema, and the inflammatory process will continue, resulting in the aggravation and the start of the immune modulation and stimulation. This will result in renal hypoperfusion and hypoxia, ending with acute kidney injury, and the insult continue with rescanning of these patients. So when we classify kidney injury disease, we have to look at 4 dimensions, and they are structural, functional, and outcome and this is related to the duration and time. And there is a number of classification of kidney injury. Whatever you use, just stick to it. The main definition of this, and I have a big list of this, there's two things. One, the rate of serum creatinine raise, and also the urine output. And this is very important to actually address in any of the renal injury classification that you utilize. So recently, we actually looked at the predisposing factor and outcome of acute kidney injury after blunt trauma in our center for 10 years. And the aim of the study is to look at the pattern, predisposing factor, and the outcome of acute kidney injury in our level 1 trauma center in Qatar. So it is a retrospective study for all the patients who were admitted at Hamad Medical Corporation from 2011 to 2021. We investigated acute kidney injury. During this study, we had 140 patients out of 17,000 admitted during that period of time, which make it 0.8% of the total number of patients who were admitted. And the mean age of this patient is 40 plus or minus 20 years. When we look at the demography and clinical characteristic of patient who did not develop acute kidney injury to a patient who developed acute kidney injury, we can see that renal injury patients were older. The comorbidity is significantly high, including hypertension, diabetes, and the history of coronary artery disease. Also, associated injury were significantly high in a patient with acute kidney injury. Head injury, chest, abdomen, and pelvis all significantly high, as well as the extremities. And when we compare the amount of blood transfusion and the activation of massive transfusion protocol, we can see that acute kidney injury patients were receiving more blood and more activation of massive transfusion protocols. When we also looked at the complication, patients with acute kidney injury suffer from more ARDS, more ventilation-associated pneumonia, sepsis, and also central line and catheter-related sepsis. And the length of stay of the patient in the hospital with acute kidney injury were significantly higher in comparison to a patient who did not develop acute kidney injury. Ventilation requirement is high, and hospital length of stay was also significantly high, with significant mortality. 65% of the patients who developed acute kidney injury died while they are in hospital. The mechanism of injury, majority of these patients were blunt injury. Road traffic accident was accounting for 41%, and then pedestrian is 25%, and the rest, whether it's a fall from height or a thud or others. The presentation of these patients to the trauma room, we had 32% of the patients with acute kidney injury presented with hypotension. 17% had cardiac arrest on the presentation. Myoglobin level on admission was 1,200 and increased after 24 hours to 2,088. The need for vancomycin in this patient was 7.9%. So this is actually increased the insult on the kidney, and the number of CT scans for these patients in average was 4, but it raised up to 11 CT scans for them, and the contrast required for these is quite high. When we looked at also the procedure done for this patient, we have 96% of the patients were intubated, the patient who actually suffered acute kidney injury. Hemodialysis was required in 64% of the patient, and patient who survived and off dialysis was 23%. And there is patient recovered from acute kidney injury with normal kidney function is 32%, and with not normal kidney function but did not require dialysis was 32% also, and 7% of these patients require ECMO. The stage of acute kidney injury, the majority were stage 3, high stage of actually acute kidney injury, and renal replacement therapy was required in 6.4% of the patient. Patients who had direct renal injury were accounting for 6.5%, and we actually published a paper looking at this patient who actually had direct kidney injury, and that can be reviewed in this paper.
But when we also compare survivor versus non-survivor of these patients who had a kidney injury, we can see that the age of the one who did not survive were older, more hypotension, more cardiac arrest, and also shock index was high, and Glasgow Coma Scale was low for the patient who did not survive. Also, the associated injury was higher in terms of head injury and chest injury, whereas the pelvic and lower was also high. The other abdomen and the upper extremity were not statistically significant. Also, the severity of injury was much higher. ISS was 33.7 plus or minus 12 for non-survivor in comparison to 25%, 25.5 ISS. And as I said, all the patients who did not survive with acute kidney injury were intubated in the scene or in the emergency setting. And 30% of them underwent laparotomy and 6% had craniotomy. Complication was also significantly higher for the patient who who did not survive. And the main thing when we look at the multivariate regression analysis for the predictor of mortality for acute kidney injury were age, hypotension, and injury severity score. And this is actually a chart of all the patients who actually had the kidney injury, and you can see they are classified into stage as well as direct injury and non-direct injury. And the majority of the cases in our group were having a stage 3 injury with higher mortality. 70% of these patients died from their acute kidney injury. And the Kaplan-Meier for these patients showed stage 1 injury had the best survival. There is no much difference between stage 2 and 3 for these patients with acute kidney injury in terms of survival. When we looked at what's been published in the literature, there is 10 papers published in the literature regarding acute kidney injury in a trauma setting. There's 5 of them from a multi-center and 5 from a single center. And they were published recently from 2018 up to 2023 in our cases. The largest one is the American College of Surgeons, the TQIB data, which has actually the highest number, but it is 825 institute. And the second is the UK and also the Spanish multi-center study. The duration of the study in our case is 10 years and a half, and in the UK is 10 years, and the rest were between 2 years and 4 years. In our group, we had the mortality group with acute kidney injury is 40 years, and the rest were much higher in comparison to our study. When we look at also the number of cases, you can see that we had 17,000. The American College has close to 1 million. But the percentage of the cases we had, the lowest is 0.8%, which is similar almost to the American is 1%. The highest was actually, the paper was coming from Zaghazigh University in Egypt, which is a single center, and they have 50% of the patient who developed acute kidney injury with severe. The ISS score was high in our group, it's 30, but in the Egypt study was 41. And we had a low Glasgow Coma Scale. The mortality, unfortunately, in our group was 65%, and in the Egypt one is 70%, but in the rest of the studies goes as low as 2.1% in the Japanese population. So when they looked at actually the risk of mortality score with a severe acute kidney injury, you can see that the higher the score, the higher the mortality as demonstrated in the graph here. So in conclusion, acute kidney injury is not uncommon among the trauma patient and associated with high rate of a prolonged hospital stay and mortality. Early detection and prevention of acute injury should be a priority in such high-risk population. I would like to thank you for actually the privilege to present, and I thank the organization committee for the invitation.
Thank you, Professor Altani. Any questions from the crowd?
Hi, Hi, doctor. Thank you for this great presentation. I have one question as I'm a new emergency medicine resident, so I have this inquiry about the rhabdomyolysis. So what is the greatest risk factor of rhabdomyolysis to cause acute kidney injury? Is it the site of the injury to the muscle? So for example, is it in a great muscle, for example, the quadriceps, or a small muscle? Or is it the duration of the injury since the muscle is crushed until we detect the myoglobin in the urine, so we can determine the acute kidney injury is being already detected? Thank you.
Thank you. Excellent question. Actually, rhabdomyolysis is associated with both what you said. It's the size of the muscle and the timing of actual intervention. The best treatment for rhabdomyolysis is actually early detection and early treatment. And early treatment means need for fasciotomy should be done early, stabilization of bone, resuscitation appropriately with the fluid, and stabilizing the hemodynamic status of the patient. That's how we deal with it, actually, to reduce the rhabdomyolysis. And you need to follow it. We do actually follow rhabdomyolysis in the first 24 hours, and after that we don't. Just we see the trending, whether it's going up or down. But that's an excellent question. Thank you.
Any other questions? There are no questions. We are wrapping up the session on time. There's one more question.
Hello, Dr. Altani. About AKI in trauma patients, the crush injury point was a very excellent point regarding the injury pattern. But when it comes to preventive strategies to prevent AKI, is there still an accepted norm to have a prevention algorithm in terms of fluid, or if there is a crush injury, we start with bicarbs early, estimating rhabdomyolysis, or we make sure that the pressures are maintained? Because if the patient is in hypovolemic shock, there is a high chance that there would be a kidney injury. Now, the new papers suggest that the creatinine and contrast don't go hand in hand. Right? So in trauma patients, we use a lot of contrast when it comes to CT angiography. So the angiography has now become prominent in all traumas. So technically, we know that if there's hypotension, there is a chance that we will have kidney injury or there could be a kidney damage. But we still go ahead and scan the patients beforehand without knowing whether there is kidney injury or not. So do we have renal protective strategies which are mentioned in hypovolemic patients to make sure that the three major factors, that is hypotension, rhabdomyolysis or crush injuries, prolonged hypotension, and the use of contrast, when they come together, that could be? So is there a renal protective strategy which has been discussed or highlighted in literature?
That's a good question. In a trauma setting, the best renal protection method is resuscitating the patient early. By resuscitating is trying to stabilize the patient hemodynamically. When you achieve that, you actually achieve the renal protection method. Adding medical treatment, we know that it is not working for a trauma patient, and therefore, in my management of these patients, we looked after the ABCs, and the amount of contrast is factors, we know that, but if the patient requires it, we better do it, because unfortunately when we miss injury, that will actually worsen the condition of the kidney and the patient, and therefore, the best treatment is manage the patient as ABC, and bring them to hemostasis very quickly. Thank you.
Thank you, Professor Altani. Requesting all speakers to come on stage and Professor Dr. Bashar to come on stage along with Dr. Sagar for a photograph.
Okay, thank you. Thank you very much. Şey yapalım. Şunları verin. Viman. Okay, Viman. Doktor Viman. Soruyor.
Çekil kareyi. Onları da vereceğiz. İman şunu.
İman şu.
Bunu da aç.
de şey abi. Yasemin Su. Şimdi heybe vereceğiz abi. Hasan el tane için heybe geçiyor.
Şunu vereceğim. Dur Fatma. Oh, this is so good. And yeah, this for some.
Tamam, in aşağıya. Şu mikrofonu al.
So we'll bring this session to a close now. We had excellent sessions about low-risk trauma decision-making, then a hemodynamically shocked patient using tech-guided MHP protocol, and then 2 cases with unfortunate outcomes following major trauma, and finally AKI in major. Thank you, everyone.
Doktor Başar Cander. Bir diğer konuşmacımız ise Altınbaş Üniversitesi Klinik Farmakoloji Bilim Dalı'ndan Sayın Profesör Doktor Barkın Berk. Sempozyumumuzun ilk konuşmasını yapmak üzere değerli dernek başkanımız Sayın Başar Cander'i buraya davet ediyorum. Buyurun hocam.
Evet arkadaşlar, hepiniz hoş geldiniz. Gerçekten görüyorsunuz 3. gün ve hemen her salonda bir aktivasyon var. Salonlar yetmiyor. Özellikle burada arkadaşlarımız çok ciddi bir koşturma içindeler. Ama Dünya Kongresi olmasının böyle bir heyecanı var, böyle bir şey var. Ya burada yabancı konuklarımız var. Onlara biz Türkçe yapacağız anlatımı. Kulaklık getirebilir misiniz yabancı konuklarımıza? For Hasan El Tahani and other maybe Sagar and okay. No, wait please. Okay. Biz başlayalım. Şimdi arkadaşlar, tabii ki acil servislerde en çok karşılaştığımız semptomun başında ağrı geliyor. Ama düşünün, mesela birinin bacağı ağrıyor veya omuzu ağrıyor veya boynu ağrıyor şikayetiyle geldiğinde ilk hissettiğimiz duygu nedir arkadaşlar? Aslında bir rahatlama hissediyoruz. Neden rahatlama hissediyoruz? Çünkü şikayetinin çok ağır bir şikayet olamayacağını, yani bir ekstremite, kas, iskelet sistemi hastalığı olduğunu düşünüyoruz. Dolayısıyla hani bir kırmızı alan hastası değil de bir sarı alan, yeşil alan hastası olduğunu, reçeteyle tedavi edebileceğimizi veya kısa şekilde tedavi edebileceğimizi düşünüyoruz. Ama burada biraz yanılıyoruz. Neden yanılıyoruz? Evet, ağrı hayatı tehdit eden birçok şeyde ağrıyla geliyor. Ama diyelim kas iskelet sistemi ağrıları bizim hayatımızı en çok etkileyen olaylardan biri. Mesela biz workshop yaptık İstanbul'da. Workshop yapınca bir hocamız workshop yaptığımız otel mesafesiyle hastane arası 500 metreyi geçmiyor. Sayın Boy vardı burada. Otele yürüyüp geleceklerini planlamıştık. Bir türlü gelemediler. Sonra sorduk nerede arkadaşlar diye. Onlar da telefon açtılar, dediler ki ayağını incitmiş, yürüyemiyor. Bu yüzden gelemiyor. Biz bir arabayla aldık. Şimdi şöyle düşünün, biz buraya aylarca, yıllarca hazırlandığımızı söylüyoruz. Ama bir ağrı semptomu, bir boyun ağrısı, bir kas ağrısı bizim bütün aktivasyonumuzu burada ne yapabilir? Geriye düşünebilir. Yani bunu hayatta da gördüğünüz zaman aslında basite alıyoruz ama yaşayınca şunu anlıyoruz. Hepimiz yaşadık, yaşıyoruz. Bunun aslında hayatımızı ne kadar etkilediğini görüyoruz. Mesela hepimizin deneyimi olmuştur. Yaşamadan anlamıyorsun diyorsun ya. Ya mesela her gün çorap giyiyoruz değil mi? Çok basit. Herkes çorap giyiyor. Sırtı tutulan biri, sırtı ağrıyan biri nasıl çorap giyiyor? Ben birkaç defa denedim, neredeyse düşüyordum. Mümkün değil yani. Yardımsız çorap giymeniz mümkün olmuyor. Dahası şu ikisi kapılı arasında ağrısı olan oldu mu? İsa'nın varmış, ikisi kapılı arasında. Uzanmaya çalışıyorsun, birden saplanıyor. Uykun geliyor ama uzanamıyorsun. Uyuyacaksın, şansın yok. Yine çok önemli bir şey var, boyun. Hele böyle uzun boyunlu olanlar, şu 8 omur. Boyun tutulması. Ya sağa dönemiyorsun, sola dönemiyorsun. Yani hayatımızı o kadar etkiliyor ki bu ağrı. Hastalar içinde bakıyorsun, ya bir şey yok ya, işte kas ağrısı geçer, şunları kullan. Ama onun hayatında ne kadar yeri var o ağrının? O yüzden bizim bu tedaviye çok dikkat etmemiz gerekiyor arkadaşlar. Şimdi kas iskelet sisteminde hepimizin bildiği şeyler var. İşte kemikler, eklemler, kaslar, pasif elemanlar ve aktif elemanlar olarak söyleyebiliriz. En genel belirtiler ne? Ağrı, işte sabah tutukluğu, hareket kısıtlılığı, kas kitlesinde azalma, krepitasyon, hassasiyet, halsizlik vesaire, bunlar semptom olarak karşımıza çıkıyor. Tabii bunlar bizim hayatımızı, sosyal hayatımızı engellemek yönünde çok etki ettiğini az önce belirttik. Ama bunun dışında da şuraya görüyorsunuz arkadaşlar, herhalde şuradan göstermem mümkün, pardon, geriye alabilir miyiz? İleriye alalım, bir daha ileri. Evet, şurada görüyorsunuz. Şunu nereden? Evet, acile başvurma, ölümcül olmayan hastalık yükü içinde. Yani psikiyatrik hastalıktan sonra sondan 3. olarak görüyoruz burada. En sık görülen 10 hastalık istatistiklere göre bel bölgesi kas iskelet sistemi problemleri 1. sırada. Yani bize en çok başvuran hasta grubunda ilk sırada yer alıyor. Ama 3'e, 5'e de dikkat edin, 8'e dikkat edin. Bütün bunlar hep ne? Hep ağrı semptomu. Yani sonuç olarak şuraya geliyoruz. Ağrıyı dindirmek çok önemli bir sanat. Bunu kabul etmemiz lazım ve bu ağrıyı kesmenin de önemli bir iş olduğunu anlarsınız. Ben modern tıp konusunda gerçekten şeyler olabilir. Bakın kafamızda bazen soru işaretleri oluyor modern tıp konusunda. Acabalar oluşabiliyor. Ama modern tıbbın doğruluğunu kendi vücudumda en çok hissettiğim yer ağrı kesiciler. Eğer etkili bir ağrı kesici. Mesela bir diş ağrısı çekiyorsunuz. Hayatınız kararıyor. Hiçbir şey yapamıyorsunuz şiddetli ağrı için diyoruz. Ve bir ağrı kesici eğer sizin diş ağrısınızı kesiyorsa veya renal koliyi düşünün veya işte bahsettiğim sırt bel tutulması. Ağrı kesici alıyorsun ve birdenbire bir konfor hissediyorsun. Bir mutluluk oluşuyor. Dolayısıyla arkadaşlar ağrı kesmenin bir doktorun en önemli görevlerinden biri olduğunu unutmamamız gerekiyor. Bu yüzden de tabii ki biz ağrı kesicileri çok fazla kullanmak, çok fazla yazmak durumundayız. Bunun için de mutlaka ağrı kesicileri çok iyi tanımamız gerekiyor. En sık kullandığımız ilaçlar olduğu için. Tabii burada bir ağrı var, bir de spazm var. Bunlar birbirini tetikliyor. Bel boyun ağrıları gibi spinal bozukluklarda bir de spazm ekleniyor. Spazm da ağrıyı arttıran bir şey. Yani ağrı oluştuğu üzerine bir de spazm, bunlar bir kısır döngü oluşturmuş hale geliyorlar. Yani sırt ve omuzlar ben anlattım. Bunların hepsini ben yaşadım. Tabii siz de yaşayacaksınız. Yani bu kaçınılmaz bir şey. Yıllar ilerledikçe daha fazla yaşıyor insan ama yani gençlikken de yine yaşadığımız iskelet ağrıları mutlaka peşimizi bırakmıyorlar. Bunları düşme çarpmayı söylemiyor. Onlar zaten kaçınılmaz ama gerek postürden gerek de yaşla ilgili mutlaka bu ağrılar, bu spazmlar karşımıza çıkıyor. Bunun değişik nedenleri olabilir. Mineral eksikliği olabilir, dehidratasyon olabilir, yetersiz kan akışı. Bunu tersten bakmanız lazım. Yani kas spazmı deyip geçmeyin. Evet, kas spazmı vardır ama belki bunun altında bir yetersiz kan akışı vardır. Yani o zaman ne yapmamız lazım? Ona bakmamız lazım. Dehidratasyon var mı? Ona bakmamız lazım. Yani bir hasta size kas ağrısıyla geliyorsa tamam demememiz lazım. Acaba bu kas ağrısı neden var konusunu mutlaka düşünmemiz gerekiyor. Kasların aşırı kullanımı da kas spazmı nedeni oluyor. Bunu hepimiz yaşamış olabiliriz. En son dünkü maçtaydı değil mi? Ben maçta bu neydi? Fred miydi? Fred değil mi? Fred'in kaslarında bir şey oldu. Kaçıncı dakikada çıktı? Biz bir taraftan kongre takip ederken bir taraftan da bunları görüyoruz yani. 45. dakikada Fred'i çıkarttılar değil mi? Benden başka Fenerbahçeli yok yani. Peki. İlaçlar sebep olabiliyor spazmına. Ani keskin ağrı varsa, cilt altında sert bir kas dokusu hissi varsa, kas seyirmesi varsa biz bunlarda kas spazmını görüyoruz. Şimdi gerçek bir spazmda kasları uyaran sinirlerin aşırı aktivitesinden kaynaklanmıştır. Tek bir kası ya da bir grup kasın tamamını kapsayabilir. Kas yorgunluğu, yaralanma, kasların aşırı kullanımı gerçek kramplara neden olabiliyor. Bir ani bir ağrı ve sizi hareket ettirmiyor. Vücudun su kaybetmesi, sodyum eksikliği gerçek krampların diğer nedeni. Yani acilde çok fazla karşılaşıyoruz tabii sodyum eksikliğine, hiponatremiye ve bu da bizim için önemli. Tetani tipi spazmlar değişik hastalıklarda özellikle kalsiyum önemli, potasyum önemli bu durumlarda. El ve el bileklerinde kas spazmları daha çok biliyorsunuz düşük kalsiyum seviyelerine bağlı. Distonik spazmlar olabiliyor. Bu da daha çok aşırı kas kullananlarda, amaçladığı hareketin ters yönünde kasları kullanan kişilerde görülür. Yine önemli bir şey, belki bizim için önceden önemliydi. Şu anda pek yok ama yazar spazmı. Şimdi klavyeye bağlı oluyor mu spazm olan var mı klavyeye bağlı? Klavyeye bağlı. Kimsede spazm yok mu? Görebilir miyiz? Yok. Yine bizimkiler ama mesaj bu. Çok mesaj yazanlar, Instagram yazanlar, Facebook. Bir bakıyorsun şöyle kasılmış geliyor hastaneye şöyle. Tamam Instagram işi bu. Öyle düşünün yani. Bel kas spazmı bu da kötü. En sonunda bir şey yapalım, anket yapalım. Hangisi daha kötü diye. Gerçekten bel kas. Böyle duruyorsun. Bunları da yaşayınca daha iyi anlıyorsun. Hastaları da daha iyi anlıyorsun. Kas güçlü değilse vesaire bunlar oluyor. Evet bunlar hayatı tehdit etmeyebilir ama birçok insan hayatını tehdit ediyor. Neden? Ya adama hazırlanıyorsun. Mesela şu anda düşünün biz bu kadar çalışmadan adam Hindistan'dan geldi, Japonya'dan geldi. Ondan sonra diyelim ki kası tutuldu, beli tutuldu. Nasıl konuşma yapacak? İşte o sırada bu ilaçlar devreye girmesi gerekiyor. Boyun kas spazmı da çok kötü arkadaşlar. Boyunda bir ağrı vardır. Sırtta kas spazmı, omuz kas spazmı bunların hepsi bir şekilde insanın sosyal aktivitesini, işini, gücünü engelleyen önemli problemler. Bazılarında çok daha sık görülür. Onun için kasların güçlendirilmesi önemli. Ama bu ağrı spazm dengesini mutlaka ne yapmamız gerekiyor? Kısır döngüyü bir yerden kırmamız gerekiyor. Tabii bizim şöyle bazen oluyor, burada biliyorsunuz bu yıl yapamadık ama futbol turnuvası oluyordu. Futbol turnuvasında bazen biz de oynuyorduk. Mehmet Hoca'yla falan işte bir yıldır oynamamışsın birden oynuyorsun. Tabii ne olacak? Kaslar ertesi gün bütün kaslar tutulmuş oluyor. Futbolcular neden ısınma hareketi yapıyor? Çünkü kasların birden hareket etmemesi için demek ki burada korunmak lazım. Yine yemek yedikten hemen sonra egzersiz yapmayın. Hani yemekten sonra yürüyüş yapalım diyenler. Mesela Zeynep Hoca 2'de 1 tutturur. Orada konuşuyor, bizi dinlemiyor. Zeynep Hocam yemekten sonra yürüyüş bak kas spazmı nedeni oluyormuş. Kahve, çay ve çikolata gibi bol miktarda nikotin içeren besini az tüketin. Kahve, çay, çikolata gibi bol miktarda. Allah Allah. O zaman biz niye sigara içmiyoruz? Madem bunlar nikotin bu kadarı içeriyor diyorsun. Bunlar mı nikotin içeriyormuş yoksa falan diye düşünmek lazım. 2 litre su içmemiz lazım. Süt, portakal suyu, muz gibi kalsiyum, potasyumdan zengin besinler ve stressiz bir yaşam diliyorum sizlere. Bu nasıl yaşanıyorsa. Sonuç olarak arkadaşlar tedaviye geçeceğiz. Tedavide bakın ağrı kesici yazarken aklımıza gelen en önemli şeylerin başında nedir? Şimdi Murat Seyit önümde olduğu için soruyorum. Ağrı kesici de ilk aklına gelen ne? Yazarken ne düşünürsün? Hızlıca etki etmesi. Bu ofansif bak. Ofansif duygu. Bu duyguyu yaşayanlar genelde farklı. Ama eğer şöyle deseydi ki o önemli. Yani mesela hızlı etki değil de mesela başka ne denebilir? Atakan'a soralım yanında. Atakan. İşte bak bu da defans. Bak biriniz defans biraz ofans. Şimdi defansif olanlar şöyle düşünür. Zarar vermeyin. Bunların tıptaki kuralı şu. Önce zarar verme. Aman ilaç veriyor zarar vermesin. Bu futbolcu olsa defansta oynar yani. Gol yemeyeyim der yani. Diğer taraf ise hızlı etki etsin. Bu işe gol atayım, kazanayım. Bunların tıptaki karşılığı ne? Salondan alalım. Sema sen duymuşsundur, söyle karşılığını. Yok. Bu diğerleri önce zarar verme. Bunlar önce yarar ver prensibiyle hareket ederler. Onlar diyorlar biz gol atalım da golleri sonra bir şekilde çıkartırız. Gol yesek de olur. Gol atalım önce. Sonra bir de. Ama şu ağrı kesici yazarken bunları düşünüyoruz ama ilaçları düşünürken de güven duygusunun çok önemli olduğunu görüyoruz. Güven duygusu. İşte burada mesela 20 yıl, 30 yıl, 40 yıl kullanılan ilaçlar güven konusunda biraz daha ön plana çıkıyorlar. Hele kendi deneyiminiz de olmuştur bu ilaçlarla. Bu önemli. Dolayısıyla tedaviyi yaparken semptomatik yapıyoruz. Güven duygusuna önem veriyoruz. İlaca güveniyoruz. O ilaca güveniyor olmamız lazım. Tabii burada fizik tedavi yapılabilir, lokal ısı uygulamaları yapılabilir. Bazen soğuk uygulama gerekiyor. Eklem içi enjeksiyonlar var vesaire. Cerrahi tedaviye kadar gidebilir. Ama hem analjezik hem de miyorelaksanlar bize bu konuda yol gösterecektir. Bir an önce tedavi olmak istiyor, bir an önce işine dönmek istiyor. Daha doğrusu o ağrıyla işi yapmak zorunda, ağrısını azaltmak zorunda. Çünkü çoğumuz bu ağrıyla yaşamayı öğrenmek zorunda kalıyoruz. Dolayısıyla stresin de ağrıyla birlikte olduğunu söyleyerek arkadaşlar, şimdi sözü başka bir yere bırakayım ama bizim acil pratiği açısından şunları söyleyebilirim. Bir ilaç veriyorsanız mutlaka güvenmek istiyoruz. Hemen mide rahatsızlığın var mı diyoruz. Acaba bir perforasyona sebep olabilir miyim diyoruz. Bu konuda işte ilaç dikkat ediyoruz. İkincisi yine hani burada uydu sempozyumu rekordat ile yaptığımız için söyleyelim. Feniramidol hem miyorelaksan etki, bunları Arkın Bey anlatacak, hem analjezik etkiyle kısır döngüyü kırıyor. Güven duygusu oluşturuyor ve etkili analjesi, ama bizim için bir kolaylığı daha var biliyorsunuz. 40 yıldır kullanıyoruz. Bir intramüsküler yapıyorsun, bir tablet formu var. Bu da buna özgü olarak diyorum ve burada sözü bitiriyorum. Hepinize teşekkür ediyorum. Siz ben anons edeyim hocam. Profesör Doktor Barkınberk, Altıntaş Üniversitesi'nden daha önce de misafir etmiştik. Bu konularda uzman olan bir hocamız buraya geldiği için, teşrif ettiği için teşekkür ediyorum. Buyurun Sayın Hocam.
Efendim, hoş geldiniz. Tamam, zorlamayalım. Buradan konuşalım, sıkıntı yok. Efendim hoş geldiniz, şeref verdiniz. Hem sizler hem uluslararası konuklarımızla beraber burada olmak oldukça güzel benim için. Çok basit bir soruyla başlamak istiyorum, eğer sizin için uygunsa. Genç, yaşlı, erişkin hepsinin ortak problemi her geldiğinde ne oluyor? Ağrı. Tabii ağrı dediğimiz zaman ağrı ile ilgili olarak birçok şey söyledi hocam. Bağlantılı olarak spazmla ilgili de birçok şey söyledi. Bütün bunların hepsinin temel kaynağında, özellikle mesela spazmın temel kaynağında bir homeostatik dengenin bozukluğu söz konusu. Dikkat ederseniz replasman tedavilerin hepsi aslında homeostatik dengenin tekrar yerine getirilmesiyle bağlantılı olan, özellikle iyonik dengenin yerine getirilmesiyle bağlantılı olan tedaviler. Bunun haricinde 2 tane opsiyonumuz var. Ya analjezik vereceksiniz ya antiinflamatuar vereceksiniz. Başka bir çaremiz yok baktığımız zaman. İşler gençken ve erişkinken güzel de yaşlanmaya başladığımız zaman işlerin rengi değişiyor ve bu durum, bu ağrı durumu, kronik ağrı durumu, kronik enflamasyon durumu çok fazla bir arada görülmeye başlanıyor. Çünkü aslında kas da yaşlanıyor. Kas yaşlandığı zaman normal olarak vücudun verdiği standart cevabı veriyor, enflamasyonu oluşturuyor. Kasın enflamasyonu oluşturması çok kolay bir şey, çünkü buradaki şekilde de gördüğünüz gibi, özellikle altta gördüğünüz gibi kas aslında hücresi olarak bakıldığınız zaman birden fazla nükleosa sahip. Dolayısıyla çok ciddi anlamda herhangi bir durumda hemen hızlıca kendisini onarmaya yönelik olan bir yapı. Tabii otomatik olarak da herhangi bir cevap vermesi gerektiği zaman enflamasyonla karşı karşıya kalıyoruz ve bağlantılı olarak da hemen gene sizin şu anda sağ tarafta gördüğünüz enflamasyon durumu söz konusu oluyor. Yani kasların arası enflame olmaya başlıyor. Aynı şeklin bir başka görüntüsünü burada sol tarafta görebiliyorsunuz. Enflame oldukça aslında kas lifleri hafif hafif birbirlerinden ayrılmaya başlıyorlar ve arası şişmeye başlıyor. Tabii enflamasyon beraberinde kendi medyatörlerini de getiriyor. Enflamasyonun medyatörleri çok enteresan. Enflamasyon medyatörleri bildiğiniz gibi aynı zamanda ağrıyı da tetikleyen medyatörler. Özellikle nosiseptörler üstüne çok ciddi anlamda etkililer ve sensitizasyonunu sağlıyorlar. Ağrının en kötü tarafı şu: ağrıda bir ileti gerçekleştirdiğiniz zaman ağrı yukarıya kadar gidiyor. Yani hani
yukarıya kadar, beyine kadar geliyor fakat cevabı oluşturulamayan bir durum. Yani bir respons veremiyor vücut buna karşı. Sadece diyor ki ağrı var, ağrı var, ağrı var. Bunu bir şekilde gidermen lazım. Bu durum erişkinlerde ve yaşlılarda, özellikle yaşlılarda çok daha fazla gözlemleniyor. Çünkü bu enflamasyon sonucunda çok ciddi anlamda aslında kas kendisini tamir etmeye çalıştıkça da protein consumption'ı, protein tüketimi çok artıyor ve ortadaki durum daha da kötü hale geliyor. Özellikle vücuda binen, böbreklerin üstüne binen yük açısından baktığımız zaman. Mekanik veya non-mekanik herhangi bir etkenle karşılaştığımız zaman bir doku hasarı var. Doku hasarı evet ağrı olarak kendisini gösteriyor. Homeostatik denge bozuluyor. Dolayısıyla spazm olarak kendisini gösteriyor ve cevap olarak da enflamasyon olarak kendisini gösteriyor. Dolayısıyla aslında baktığımız zaman ağrı, enflamasyon ve spazm birbirlerini tetikleyen durumlar. Enflamasyon daha da fazla tetikleyici halde. Ağrının ana kaynağı bir önceki slaytta gördüğümüz medyatörleri yüzünden. Peki güzel de hani akut mu kronik mi her zaman standart sorduğumuz soru. Akut olduğu zaman bizim için iyi bir şey. Hani nereden kaynaklanıyor, nasıl kaynaklanıyor bunu gözlemleyebiliyoruz. Ama akutun ilerleyen safhalarında yani enflamasyon cevabı oluştuktan sonra endotel hasarı başlıyorsa, dokuda ciddi anlamda ödem gerçekleşiyorsa veya doku bütünlüğünün bozulması başlıyorsa o zaman bir fasit daire haline geliyor ve doku hasarı sürekli kendisini yeniler bir duruma geçiyor. Tabii biz bunu hani kronik olarak CRP'nin falan filan çok yükselmediği durumlar da söz konusu bu arada. Ama yani hani akutta gördüğümüz kadar çok fazla gözlemleyemiyoruz. Ama vücut içten içe kendisini hırpalamaya ve dokusal olarak hasar vermeye devam ediyor. Şimdi burada ana hani spazmdan başladık. Ağrı ve spazm için iki farklı grup ilaç kullanıyoruz ama acaba bu iki farklı grubu birleştirmek söz konusu olabilir mi? Veya bir birleşik olsa bu iki farklı durumu ortadan kaldırabilir mi? Biz çalışmalarımıza başlarken bunun üstünde çalışarak başladık ve tabii ki çeşitli antispazmolitikler artı tabii ki antienflamatuar ve analjeziklerin hepsini birden bakmaya başladık. Analjezik antienflamatuar sadece non-steroidal antienflamatuarlarda var. Yukarıya doğru gittikçe aslında durum biraz farklılaşıyor. Yani opioidlere doğru gittiğiniz zaman durum birazcık daha farklılaşıyor. O zaman enflamasyonu ortadan kaldıramıyorsunuz. Bunu birleştiren bir tane yapı var mı diye bakarken feniramidol önümüze çıktı. Feniramidol baktığımız zaman hani doz olarak 400 mg film tableti olarak günde 3 kez kullanabileceğiniz 1 veya 2 tablet halinde veya 800 mg'lık 3 mililitrelik enjeksiyonluk çözeltisiyle kullanabileceğiniz bir birleşik. İlginç olan tarafı çok hızlı etki gösteriyor. Yani ilk 10-15 dakikada etkiye başlıyor ve maksimum yarım saat içerisinde etkisini maksimize edebiliyor. Tabii bu özellikle acil serviste çalışıyorsanız sizin elinizi çok kolaylaştıran bir durum. Çünkü çok hızlı bir şekilde aslında cevap alıyorsunuz ve bu cevapla beraber de feniramidol özelinde hızlı bir şekilde hastayı rahatlatabiliyorsunuz. Özellikle spesifik olarak kas iskelet sistemi akut ağrılı kas spazmlarının semptomatik tedavisinde endikasyonu var. Hem ağrı hem spazm açısından baktığımız zaman. Feniramidolün çok enteresan bir özelliği var. Verdikten sonra, dolaşıma geçirdikten sonra biriktiği yer aslında kas kütlesinin kendisi. Yani spesifik olarak dağılıma giriyor, kasta depolanıyor, tekrar dağılıma kastan devam ederek yavaş yavaş salınarak devam edebiliyor. Feniramidolün ikinci bir özelliği daha var ki özellikle bir nöropatik durum söz konusu olursa, düzensiz sinir iletimi durumu söz konusu olursa feniramidolün kendi metabolitleri de ilaç olarak kullanılabiliyor. Bunun yanı sıra asetilkolin salınım kavşaklarında herhangi bir şekilde değiştirmeksizin düzenli iletim sağlayabiliyor sinir hücresinin üstünde ve de bağlantısı olarak da eğer hasta kronik spazm geçiriyorsa spazm oluşturma özelliğini veya spazm oluşma olasılığını da düşürüyor. Tabii ki mutajenik ve genotoksik etkisi de bulunmamakta. Baktığımız zaman feniramidolün en büyük olaylarından bir tanesi yani enflamasyona giden yolda niye feniramidol çalışmayı seçtiniz, niye bu konuda kafanız hani gidip de feniramidolü nereden buldunuz derseniz aslında prostaglandin yolağı üstünde de etkili olması. Çünkü ağrı mekanizmasını aslında prostaglandin mekanizmasını inhibe ederek sağlıyor. Prostaglandin E2'yi inhibe ediyor ve nosiseptörlerin de bu şekilde uyarılmalarını azaltıyor ve periferik sinir ucunda da bu uyarıyı oldukça düşük seviyeye çekiyor. Ağrı oluşum eşiğini de supraspinal ve spinal seviyede de arttırıyor. Bizim işimiz sizinkinden biraz farklı. Bizim işimiz hasta ile değil, bizim işimiz moleküllerle. Moleküller dediğimiz zaman birçok farklı molekülü aslında özellikle başka bir etkisi var mı, nasıl bir etkisi var şeklinde deneyerek işimize devam ediyoruz. Daha önce yaptığım konuşmalarda bunlardan bahsetmiştim. Aslında bu bir repurposing çalışması ve de hani fenomenidol yapısal olarak da aslında siklooksinaz enzim inhibisyonu gösteren yapılara çok ciddi anlamda benziyor. Ama buradaki kritik kısım şurası. Santral sinir sistemi depresyonu yapıyor mu, yapmıyor mu? Fenomenidolün bir özelliği daha var ki santral sinir sistemine geçişi çok az. Biraz sonra başka bir deney setiyle beraber bunu tekrar söyleyeceğim. In silico çalışmalarda gerçekten de siklooksinazın aktif yöresine etkisini çok net olarak gözlemleyebiliyoruz. Şimdi geçmişte yaptığımız çalışmalara ek olarak bir kısım yeni çalışmalar daha yapmaya başladık. Özellikle fenomenidolün kendisinin adsorpsiyon, dağılım, metabolizasyon, eliminasyon açısından diğer nonsteroidal antiinflamatuarlarla veya diğer antispazmolitiklerle karşılaştırdığımız zaman durumu nasıl bunu gözlemlemeye çalıştık yaptığımız çalışmalarda. Bunlar da aslında in silico çalışmalar fakat klinikteki genel durumla da şu anda örtüşür vaziyette. Oral absorpsiyon açısından bakıldığı zaman fenomenidol %100 absorbe olabilen bir molekül ve ilginç şekilde pasif transportla bağırsak lümeninden hızlıca geçebiliyor. Yani %100 bağırsak lümeninden transfer edebiliyorsunuz. Bu iş için herhangi bir ek kuvvet kullanmıyor vücut. Çok rahatlıkla bağırsak lümeninden dolaşıma pasif transportla geçirebiliyor. Serum albümüne bağlanma oranı oldukça düşük ve aynı şekilde de pasif transportla kan doku epiteline geçiş sağlanabiliyor. Bu da bizim çok hani gene kas dokusu üstünde nasıl rahatça depolanabildiğinin bir göstergesi aslında bizim açımızdan. Yani kasta depolanıyor, kasta depolandıktan sonra salınıyor diyoruz ama hani gerçekten böyle bir durum var mı? Gerçekten de var. Yaptığımız çalışmalar ciddi anlamda da dokuya çok hızlı transport olabildiğini, enerji gerektirmeden transport olabildiğini gösteriyor. Aynı durum dolaşım kan-beyin bariyeri için de geçerli. Kan-beyin bariyerini çok az geçen yapılardan bir tanesi fenomenidol ve bağlantısı olarak da santral sinir sistemi depresan aktivitesi aslında diğerlerinden çok daha az, neredeyse yok denebilecek durumda. Bunun haricinde ikinci önemli olan şey özellikle yaşlı hastalar açısından biliyorsunuz yaşlı hastalarda demin bahsettim protein yıkımı çok yüksek miktarlara vurabiliyor. Dolayısıyla çok ciddi bir böbrek yükünüz var. Siz kronik bir antiinflamatuar, kronik bir antiinflamatuar kullandığınız olarak veya kronik bir ağrı kesici kullandığınız zaman en büyük probleminiz böbreklerde oluşturduğunuz yük oluyor. Dolayısıyla bakıldığı zaman böbrek üstündeki yani böbrek hücrelerinin üstünde de bir toksik etkisi olup olmamasını da bakmak zorundayız. Sağlıklı insan böbrek hücrelerine baktığımız zaman fenomenidolün sitotoksik etkisinin çok düşük olduğunu gördük. Diğerlerine oranla aslında böbrek hücrelerini çok daha az hırpalıyor veya çok daha az yaralıyor bir ağrı kesici ve antispazmolitik olarak. Tabii bunun yanı sıra bir de kalp krizi oluşturma riskimiz var biliyorsunuz. Özellikle kalp krizi oluşturma riski nonsteroidal antiinflamatuarlarda her tipi potasyum kanallarının inhibisyonuna dayalı olabiliyor çoğu zaman. Baktığımız zaman bunu da fenomenidolün çok az bir miktarda yaptığını görüyoruz. Diğerlerine oranla inhibisyon her tipi potasyum kanallarının inhibisyonu çok düşük. Tabii hemen buradan enflamasyon sonuçlarına geçmek lazım. Gene enflamasyon için yaptığımız sonuçlarda yani antiinflamatuar sonuçlarına baktığımız zaman da siklooksinaz 1 ve 2'yi diğerlerine oranla daha dengeli olarak gerçekleştirdiğini görebiliyoruz in vitro eseylerde. Aynı şekilde ağrı için baktığımız zaman da ağrı kesici etkisinin diğerlerine oranla çok daha yüksek olduğunu görebiliyoruz hayvan deneylerinde ve gene hayvan pençe ödem testlerinde antiinflamatuar aktivitesi ibuprofene oranla daha iyi. deksametazona benzer olduğunu gözlemleyebiliyoruz. Buradaki en önemli şeylerden bir tanesi bizim dokunun içerisindeki o stokinleri veya mesajları dengede tutuyor olmamız. Çünkü günün sonunda enflamasyon bir cevap ve enflamasyonun temel mantığı da dokunun iyileştirilmesine yönelik olan bir cevap. Doku iyileştikçe enflamasyon azalıyor aslında kademeli olarak. Ama bu azalım, yani bu dokunun iyileşme sürecini hızlandırabilir miyiz? Veya antienflamatuarlar bu dokunun iyileşme sürecini geciktiriyor mu kullandığımız zaman? Sorulardan bir tanesi bu. Birçok antienflamatuarın ortak olarak yaptığı şeylerden bir tanesi özellikle interleukin 1B ve TNF-alfanın aynı anda inhibe edilmesi. Dolayısıyla dokunun tedavisini geciktirebiliyorlar veya daha net söylemek gerekirse tedavi için gerekli olan moleküllerin birbirleriyle haberleşmesini bir miktar engelleyebiliyorlar. Feniramidolün böyle bir özelliği yok. Özellikle iletişim bozmadan aktiviteyi gerçekleştirebiliyor. Bununla bağlantılı olarak da tabii hani bir kısım yayınlar yaptık ve yayınları yapmaya devam ediyoruz. Klinik araştırmalarını da yapmaya devam ediyoruz. Bu en son fenamidol ile ilgili olarak çıkan araştırmalardan, klinik araştırmalardan bir tanesi. Yaklaşık 100 hasta üstüne yaklaşık her biri 400 miligramlık 1 veya 2 tablet olmak üzere 3 veya 7 gün boyunca günde 2-3 kez fenamidol uygulaması yapılıyor ve daha sonra da sayısal ağrı değerlendirme ölçeğiyle hastaların genel durumu ölçülüyor. Bu ölçek hem hastalara uygulayabildiğiniz hem de hekimlere uygulayabildiğiniz bir ölçeklendirme sistemi. Sonuca baktığımız zaman hekimlerinin %89'un ciddi yandan da global etkinlik değerlendirmesinde fenamidolü başarılı bulduğunu görüyoruz. Hastaları da mükemmel olarak %43 derecelendirilmiş, iyi olarak %38 derecelendirilmiş, orta olarak %15 derecelendirilmiş ve zayıf olarak %4 derecelendirilmiş. Dolayısıyla totale baktığınız zaman neredeyse %70-75'ler oranlı iyi ve mükemmel kategorisi içerisinde hastalar tarafından da seviliyor. Fenamidol kullanıldığı zaman da memnuniyet yaratıyor. Efendim dinlediğiniz için teşekkür ederim. Tekrar sağ olun, var olun.
Evet, çok teşekkürler hocamıza. Arkadaşlar soru katkı kısa bir süre için alabiliriz varsa. Şu anda salonda herhangi bir soru katkı göremiyorum. Zaten anladığımız bir konu, hepimizin muhatap olduğu bir konu. Hepimiz bu konuda deneyimlerimizi paylaşabiliriz. Ama bu kadar vaktimiz yok. Hepinize katkılarınız için buraya geldiğiniz için teşekkür ediyorum. Ve şu anda program devam edecek burada ve diğer salonlarda. Ona göre herkes görevli olduğu veya dinlemek istediği yere gitsin ama salonlara gitsin. Başka yere gitmesin lütfen. Bu şeyi de bitirelim. 2 saatimiz kaldı bugünün. Şunun şurasında çarşambaya ne kaldı diyorlar. Onun gibi bir şey yani. Bekliyoruz arkadaşlar. Evet.
antibody response decreases, and the globulins also decreases. I don't want to go into the deeper and depth into the immunological aspects of the immunosenescence, but to categorize, we can summarize the issue in that context. Okay. So this
20 minutes over.
Yeah, I'm fine. It's 1 minute. So according to the study of Dr. Yahao, this is an meta-analysis. They have shown that when we look at the fever in the elderly population, the median of the fever in these studies is 77%, which means one-fourth of the patient population cannot mount fever response in the elderly. The second one, in some of the studies, it was noted that when the patient is getting elder, compared to young elders, fever response is coming less. The fourth issue, when we look at the hypothermia, which means the detection of human body temperature below 35 Celsius degrees, approximately in 2% of the patient population in the elderly, hypothermia is obvious. And one of these studies published in Journal of American Geriatric Society journal, they have noted that when the patient admitted to the hospital with central line, with previous surgery, with gastroenterostomy, with urinary incontinence, or if the patient has an expectation to die within 3 months, or if the patient is obese or male, then the bacteremia is likely in this group. This is an historical, record. Sir William Osler, in his internal medicine textbook, previously noted that pneumonia can be defined as captain of the men of death, because at that time, in the colder seasons, everybody has the potential to acquire pneumonia, community-acquired pneumonia. And according to our study, we have recreated the data from the historical records of the Turkish General Staff Headquarters. We have seen that the basic aim of this study was to analyze the natural courses of the infections in the absence of antibiotics. So we have seen that pneumonia has 31% mortality 100 years ago in the absence of antibiotics. So most likely to be the bacteremic form at the ultimate stage, community-acquired pneumonia is a significant issue compared to other types of infections which are most likely to be related to the compromised infrastructure in the countries, earthquakes, war times, etc. But pneumonia is an endemic disease and can be seen in colder seasons. So pneumonia is a critical issue which is reflected with other studies which shows as respiratory system as the main sources of bacteremia. So I'm finalizing. And this is the nosocomial bloodstream infection agents in the elderly population. They have included fungi too. But gram-positive bacteria are slightly less than gram-negative bacteria in this group. And advanced age, presence of intravenous catheters and being bedridden are the major parameters that result in the bacteremic courses. Finally, this is my last slide. In the rational management of bacteremias, first, the microbiological diagnosis is excessively important because no antimicrobial therapeutic modality is reliable in our age. Anytime we can see a drug-resistant microorganism that the antibiotic we have provided is not working on. And the second issue is infection control and prevention. This is the basic issue to prevent the dissemination of problematic microorganisms from one patient to other patient. And the third one is the source control. Time to time we have in the management of problematic infections, we have real problems in that context. And the last one of the most important point of view is to integrate local data to our therapeutic recommendations. Because most of the time, the international guidelines uses their local epidemiology. If you are following an American guideline, they are using American epidemiology. So to optimize therapy in the optimization of management, anti-infective management of the patient, we should integrate our local data into our therapeutic recommendations. Thank you very much.
So that was an excellent presentation. I think we'll take the questions in the open session. We'd like to go for the next speaker. That's Dr. Mohammed Hanif. He'll be speaking on geriatric emergencies and its unique challenges in an ED. Very good evening all. So now we are at the session where we'll be discussing about geriatric emergencies. So geriatric emergency and its unique challenges is what we'll be discussing today. As an effect of having a very good advanced healthcare and giving a good quality of life, our population, especially elderly population, is more nowadays. And it's not just in developed countries, it's also seen in developing countries also. A very good example is in India. Previously, to have an elderly population, that is above 65 years were a lesser number comparing to now. When we look at the data in India, if you can see that there's an increase in more than 10% of geriatric population in last 2 decades. This all showcases the importance of having an exclusive care for geriatric age group. We would be wondering, what is special in a geriatric than an adult? How a pediatric emergency department has a role in managing pediatric age group. Similarly, a geriatric age group is also little different. Their problems are different from an adult. So what is a geriatric age group? If you look at WHO's definition, it says when you're more than 65 years, that age is considered as a geriatric age. So we'll be discussing about certain unique aspects of geriatric age. What are their challenges? You'd be wondering, what is the importance of a geriatric age group? There's a specialty called as geriatricians are there to take care of it. But when we look at the data of any emergency department across the globe, you can see that nearly 40 to 50% of our patients are from the geriatric age group. Yes, we do get a lot of younger age group, but still, if you look at the data across the globe, not just, I have a couple of data from India, but still, if you look across the globe, we have a very good number of population who falls in the geriatric age group. It's very much depicted in the picture here. You can see the age group is more than 30%, especially in most of the countries across the globe. In certain countries, it's more than 30%. So the population is growing, and it's even expected to grow more by 2050. So the amount of geriatric patients we are going to handle is going to increase a lot. So let's see what are the unique challenges in this age. So in the demographics, if you look at the demographic, nearly in the United States itself, the population is expected to double by 2060. And 12 to 24% increase in the geriatric emergency patients is estimated in both developed and developing countries. And an aging population has significant implication for healthcare, particularly emergency medicine, because they form a major chunk of emergency department patients. So geriatric patients, on average, a substantial population of ED patients are majorly elderly individuals, which we already told. These patients present a wide range of issues. They need specialized care due to their age-related changes and comorbidities. So like how a pediatric age group requires a special area for care, a geriatric age group also requires a special area of care and special policies, protocols, and their unique challenges has to be addressed. So this is a distribution of clinical symptoms or complaints with which the patient comes to an ED in India. So it is based on a study that we can see the most common complaint is highest percentage presenting is 13% with shortness of breath. The most of the patients, elderly patients come to emergency in ED, they presented with shortness of breath. And second highest was angina, and the third highest was having non-specific chest pain and upper GA bleed, and other major distribution of non-specific complaints. So this non-specific complaints in the elderly population, especially they always have a fear of having some issues, so they come to ED very often, even with certain non-specific symptoms also. All this adds to the burden of emergency physician in order to take care of them. So like how it is very demanding for a pediatric population, geriatric population also at time is very demanding. Their relatives will be there, their kids will be there, they'll be asking a lot of questions what's happened. So I think it's like how, now you can relate how in a pediatric population comes, the parents are very much concerned. The same way the geriatric patient comes inside, their relatives also very much concerned about their father, grandfather, XYZ. So in this age we can see is like there's adequate amount of trauma, and also poisoning, some bites, and urinary tract infection, and also malignancies and psychiatric illness. All these contribute to us to think and develop a unique area or unique way of approaching these patients. The geriatric patients pose a unique challenge for healthcare with the following issues. Like one is cognitive impairment. So in most of the patients, because of their cognitive issues, it will be very difficult to take proper medical history. The patient might have come in and unresponsive. You need to ask, because many times they'll be staying alone. It's very difficult to take history and ask what happened to your parents. They said, we found him unresponsive. He was found unresponsive. He's not talking now. He's not moving his leg. What happened? Nobody knows. So that puts us in a very difficult situation to make a diagnosis or evaluation. Communication, especially hearing issues. So when the patient comes inside, that makes you cannot just talk to them like that. So maybe you have to be a little louder. So you don't understand, because you'll be asking questions, they won't be responding back to you. So this puts you in a lot of, see, all these, you might be a routine thing, it's an adult patient, you'll be asking, you'll be answering, and you'll be giving wrong answers. He might be having some mild delirium. So all this puts us in a lot of difficult situations. So that's why we have to understand this is a special age group where we have to focus on these issues, keep them in mind while approaching these patients. And frailty also very important. Most of the elderly patients, psychology research and response to stresses are very low, so they may get immediately agitated, irritated. So you should be very, compassionate in approaching these patients. So if you come in pediatric also, similarly we try to be very compassionate with the child. We try to understand from the parents what the issues are. So similar way in geriatric age group also a lot of challenges are there. So a comprehensive clinical assessment is very important in these patients. It's because first of all we know that because of their cognitive issues we won't be able to communicate with them properly, comorbidities and also frailty. It will be difficult to elicit all clinical history exactly and get an information what we need specifically for our clinical assessment. So there comes an important tool which we use, is called 4Ms, which is based on mobility, medication, mind and most matters and goals and values. A geriatric focus history and physical examination is essential for accurate diagnosis and treatment. So here comes a 4M screening tool. First is mentation. Confusion assessment method score or CAM score can be used, where you can ask questions to the patient and see whether he's having a proper response to the answers. We'll be discussing about it later. And mobility, ask for mobility, whether there was a fall within the last 3 months. Because many times they will come and tell, my father is not moving his leg from today morning. So you'll be asking what happened, I don't know, nothing, everything was fine, today morning he is not moving. But there might be a history of fall which went unnoticed, or the caretaker was not, experienced enough to appreciate that. use of walkers, cane or mobility devices, and currently feeling dizzy or faint, currently on any fall precaution, because he has a high risk of fall. Because many times patients have a small trivial falls which translate into fractures or bedridden, and they come to us. So if any fall precaution is advised, it means that he has already in a risk, patient is a risk for getting injury due to fall. And completion of fall risk education, time up and go test has to be done. And if there is answer to any of these questions, there is an abnormal time up and go test, it means that there is affected the mobility. Then medication. Medication is also very important, because one of the unique challenges of geriatric population is polypharmacy. They'll have multiple comorbidities, multiple clinical issues. They'll be on multiple drugs. So you should have a proper idea of what current medication that have, and the recommendations is based on AGS base criteria that we'll be discussing soon. And if that is done, then a positive medication scheme is done. What matters is, like, is there any advanced directive or living will? Like the patient is telling, okay, if he's in a cardiac arrest, please do not resuscitate, or anything else. Who should make decision for him when he is critically ill? Because when these patients come, they are not in a position to make a decision for themselves. So we should find out who can make a decision. Is it a son, wife, or his relative, or his friend, or his attorney, who has to make a decision for his clinical management? Another reason for geriatric referral, and that has to be taken into account. So this is how a geriatric patient's workflow has to be established in an ED. The patient arrives, the patient is done triaged by ED nurse, and the ED nurse puts in triage criteria where if it's more than 65 years, emergency severity index 1, 2, 3 or 4, that has to be done. And then the geriatric EM, that 4M assessment is done. And then as per that, the patient is admitted in an area, and current workup and diagnostics are done, specific checkups are done, disposition is planned. Our patient is given to a particular supporting system, in a public supporting system, who can take care of the patients even if the patient is discharged from the home. So social workers, all this has to be included. So it's a chain of event which has to be established. So this is a workflow which is being recommended, and what they say is, like, each hospital or each country has their own way of handling their geriatric population. So we can adapt from this and establish a workflow in the system where the geriatric patient is followed up completely. So this is a distribution of geriatric patient in our in EDs in India. When we saw that nearly more than 60 years, in a year we had more than 3,153 male patients, and female patients are 2,246 patients. And we tried them on the base of ESI. Their level 1 patients were 891, level 2 was 1,583, level 3 was 2,148, and level 4 was 557, and level 5 was 221. And you can see level 3 and level 2 patients constituted the highest number of patients coming to our emergency department. Among these, nearly 21% of patients had ED admission, and 38% patients were discharged, and nearly 1.8% had expired or had a cardiac arrest or other clinical condition in emergency where they died in ED, and broader patients were 3.6%, and nearly 1.3% went against medical advice. So mostly these patients, if you look at them, 78% admission is to ward, so they had minor clinical, and more than 21% they are admitted in intensive care unit. So the falls in elderly, when you look at the risk of falls in elderly, it's more in, it's 1.56 times more in females than males. And the most common cause is faintness, dizziness, and low blood pressure and muscle weakness in legs. So there are intrinsic factors and external factors. If you look at the external factors, slippery fall, tripping, and uneven surface collision and falling in downstairs is the most common way of presenting in ED. So it's multifactorial, and this multifactor has to be addressed in order to resolve this. It's like medication review, education on fall prevention, exercise programs, body health assessment, comprehensive risk assessment, home modification, polypharmacy and vitamin D supplementation, environmental hazard, physical therapy and provisional support, and nurse review has to be done regularly in order to prevent this fall prevention. So delirium is another major issue faced by the patient. Delirium is an acute fluctuating change in the mental status. So this has to be done in 2 steps, where you have to do a first check for any altered consciousness. If it is present, then the delirium test is positive, and if it is negative, then ask for any question like, can you spell the word from backwards? If it is telling without any error, it means that EDS is milder, its DTS is positive. If it is not, then DTS is negative. Then we can use a BCAM negative or no delirium algorithm. So medication polypharmacy is one of the most important challenges. So this can be addressed with AGS-based criteria. So AGS-based criteria is a very elaborate thing which we can have in our department when we are dealing with these elderly patients. So I'll not go into very much detail into that. So these are a couple of drugs which are recommended specifically to be avoided or not used. So dehydration is also one of the major issues. Most of the elderly population dehydration because of their the physiological changes and poor retention of water, poor intake of water and excessive urination and other insensible losses. And frailty is the most important state of vulnerability to stresses or impact factors. That is like aging, genetic, lifestyle and environmental diseases can cause frailty in elderly, which results in like weakness, weight loss and exhaustion and low activity and slower performance. And as a result of that, they may have false disability, dependency, surgery risk and death. So pain management, so you can see we can use appropriate analgesics for the patient based on this scale. So we can use severe, means you can use opiates, moderate means you can use NSAIDs, mild also NSAIDs like acetaminophen, and muscle relaxant and other things can be used accordingly to the severity of the pain. But in geriatric age group, we should follow the base criteria and only use the following drugs which are highly recommended like amitriptyline, ketorolac and other drugs, and certain drugs has to be avoided. Another most important challenge is having pressure ulcers and skin care, which we many times tend to miss because especially these are on the dependent areas like ear, shoulder, elbow, hip and thighs. Whenever a geriatric patient comes, especially from a home setup, is bedridden, please always check for any pressure ulcers or bed sores. So this is geriatric syndrome. Geriatric syndrome is where in the geriatric age group multiple issues come in like pneumonia, diabetes, renal dysfunction, cardiac ischemic cardiac diseases, dementia, depressive disorders. So it's a very complex condition seen in most of the geriatric age group. End of life care. So managing symptoms, patient wishes, spiritual well-being, asking if there is any need for any continuing care. Patient and family has to be counseled adequately. Breaking the bad news is a very important step in ED. If a death happens, emotional support and legal issues like any DNA, DNR, or who has to make decision, etc. And after that, what has to be done. Geriatric emergency guidelines. So this is how a geriatric emergency system should be set in, and this is based on the GED guidelines by the ASAP. And so this we can take as a model and maybe replicate in many EDs. So most important recommendations is some certain societies is do not prescribe a medication without conducting drug regimen review. That's very important because they are on polypharmacy. Do not assume a diagnosis of dementia in an older adult who present an altered mental status or symptom of confusion without assessing for delirium. Never think that he is having a delirium without assessing properly with the proper tools which we already discussed, and avoid using prescription appetite stimulants on high-calorie supplements for treatment of anorexia or cachexia in older patients. Optimize social support, discontinue medication that may interfere with eating and provide appealing food and feeding assistance, and clarify patients' goal and expectations. Thank you. Next, I would like to invite Dr. Rahul Balasubramaniam for delivering a geriatric analysis here.
Good evening all. I would like to thank Team Wacem and EPAT for giving me the opportunity to talk on the topic analgesia in elderly. So pain is considered as a sixth vital, and as a result we need to address analgesia. As the overview, we are going to discuss the topic starting with prevalence and types of pain in elderly. So what are the challenges in geriatric pain management? Already Dr. Hanif has explained the challenges in general care of geriatrics. So what's specific for pain? Pain management principles, pharmacological and non-pharmacological modalities, and in specific regarding opioid use in geriatrics, and also some pain management in special situations. So with the data, almost 49 to 83% of elderly individuals above the age of 60 may be in care homes or as well as in community has suffered from pain. And if it is not addressed properly, that can have serious complication too, like depression, anxiety, sleep disturbances, and mood changes, which will later on progress to some other serious complications too. So pain can be depending upon the location of the pain, like musculoskeletal, osteoarthritic, chronic joint, or peripheral neuropathy. This is only a small list. It can be depending on the location any. As well, we can have different type of pain according to the etiology also, like neuropathic pain, can be a colicky pain due to spasms. So these are the types, and we need to have an assessment of the pain according to the etiology as well as the location. So coming to the challenges in pain assessment, there are a lot of misconceptions that after aging or as you age, the pain is normal and it is an accepted norm. It can be either from the caregiver or the practitioner as well as from the patient itself. So it is not like that. The pain has to be addressed. And often this leads to underreporting of the pain. The patient might not report the pain thinking that, yes, this is fine. But we have to use certain pain assessment tools to dig that out. The other contributing factors are visual or hearing loss and even cognitive impairment, including confusion, memory loss, or dementia, whatever it can be, or the delirium. And other problem is the fear of using proper or oligoanalgesia, which is usually happening, is the fear of adverse effects of the analgesics. So it is very important to use the correct analgesics at the right dose, and also be aware of the drug interaction and polypharmacy. So this is a study which comprises of 1,454 patients with hip fractures over the age of 65 years. I put this study to exemplify the fact that even though the pain was severe, the pain score was 7, over the 40% of the patients were not prescribed an analgesic, and there was no objective assessment done. So you can imagine there can be multiple reasons for the same. But the pain as such has to be addressed as treated. So the oligoanalgesia, if not treated properly, can lead to severe cardiopulmonary morbidity, long hospital stay, which can add on to the cost, then lengthier rehabilitation, frequent readmission of the patient, and even development of chronic pain syndromes. So physiological changes which are the challenges are the central nervous system, decrease in blood flow, which can lead to the altered perception and effective expression of the pain. Peripheral nervous system, maybe due to diabetic neuropathy, can lead to sensitivity to pain, temperature, or touch. In cardiovascular system, there will be decreased cardiac output. As a result, there can be increased toxicity of the drugs. In gastrointestinal system, due to decreased secretions, it leads to impaired dissolution of some drugs, and as a result, there can be decreased effect of drug as such. When we consider the liver or the hepatic system, it can lead to decreased protein binding, and as a result, increased free drug. So increased free drug in turn lead to toxicity. So we need to do the dose adjustment accordingly, whether it be hepatic or renal. When you consider renal, obviously as the age advances, GFR decreases, renal blood flow decreases, and as a result, half-lives also increase, and as a result, toxicity. When you consider musculoskeletal system, you know, as you ages, there is decreased body water and also increase in adipose tissue. So considering the lipophilic or the hydrophilic drugs, there can be either toxicity or there can be accumulation of the drugs. So you should consider these physiological factors before prescribing an analgesic in an elderly individual. So the part of comprehensive geriatric pain assessment, we have to directly go and ask the patient what is. Sometimes he might not be telling you the pain as such, it can be some discomfort. So you need to use the assessment tools and how it can impact the daily function. So it can affect even sleep, the mood, activity, as well as the general energy of the patient. And also consider other comorbidities and the drugs which the patient is also using, because there can be a drug interactions which you are going to prescribe. So you should discuss with the patient as well as the caregiver regarding the goal. What is the goal of the pain relief you are going to get, and other expectations. So what are the available pain scoring tools with us? So we have a famous visual analog score, which can be used in cognitively intact patients. So it can be from no pain to worst possible pain. Okay. The other is numeric rating scale, which is numbered from 0 to 10, and 0 is no pain and 10 being the worst. And next is verbal descriptor scale, phases scale. And phases scale, you can see in the last row, it's usually used not in elderly, but in pediatrics. You can ask the child to indicate which is the phase or which is the type of pain he or she is affecting from. And the last two are mainly for the impaired cognition. So Dolopus 2 is used for impaired cognition individuals, and visual scales and assistive hearing devices can be used for assessing the pain in case of visual and hearing impairment. So this is all numeric rating scale, verbal descriptor scale, or the facial pain scale are all unidimensional approach. But most often in elderly, we can't stick onto a single dimensional pain assessment. We need to approach it multidimensionally, and for that McGill's pain questionnaire is a good tool which we can use, which indicates the pain location, temporal qualities, sensitivity to change. But it is not recommended for use in illiterate or cognitively impaired individuals. For that, the option would be pain aid, which is used in dementia and non-communicative patient. Okay. So our aim is not to attain a zero pain. It is a practically a pain decrease or a accepted decrease in pain. And in the background of opioid epidemic and the adverse effects, we need to have some other options also, other than the pharmacological options. So we will aim for a balanced analgesia. So you can see the basic pain pathway, which starts from the peripheral receptors, going to the spinal cord via myelinated and unmyelinated fibers to the dorsal column, and then to the central pain centers. So here, in the pathway, you can have both pharmacological as well as non-pharmacological options. And this is the changing landscape in pain management. The ladder pattern has been changed. Previously it was 3 from mild, moderate, and severe. So previously only opioid or NSAIDs or acetaminophen were the only options. But along the ladder, we can use some sort of integrative medicine therapy, which includes regional nerve blocks, non-pharmacological therapies, and so on. And this is when we are going to give analgesia, let it be very specific according to the target. The target can be channel, enzymes, receptors. So it is a targeted analgesia approach. So you can see the different targets for appropriate analgesia. So the rule of thumb for elderly analgesia is to start low and go slow. And on reassessment, if you want to increase, it can be done later. So to start with, the paracetamol, which is widely accepted across the globe, it is a safe drug to be used even for musculoskeletal pain and other pain also. And it doesn't have any anti-inflammatory action, so you should consider other analgesics for such anti-inflammatory action. And there is no antiplatelet action too. It is considered safe and not associated with any other side effects. So you can have a ceiling dose of 1,000 milligrams per orally, and there is no superior if you are giving it by intravenous route. So that has to be kept in mind. So when you talk about NSAIDs and selective COX-2 inhibitors, it should be started at low dose and should be for the shortest period and reviewed on regular basis because it can have renal, GI, bleeding, lot of complications. So GI bleeding can be dose dependent. It can be depending upon the duration as well as the age. And if you are going to take it along with some antiplatelets, it is going to increase the risk of GI bleeding. And apart from that, if you are using it with a selective COX-2 inhibitor, you are not going to get the advantage of GI safety. And it's going to worsen your chronic kidney failure if used with diuretic as well as AC inhibitors. As you all know, it can increase water and sodium retention, edema, worsening of congestive cardiac failure. And COX-2 inhibitors are contraindicated in established ischemic heart disease and CVD. When coming to opioids, it's efficient in short-term persistent musculoskeletal pain as well as various neuropathic pain. But you need to think about the complication like sedation, nausea, and vomiting, and it resolves after 2 or 3 days. But the constipation, if at all is there, has to be treated with laxative therapy. And usually, cognitive function is unaffected in patients taking a stable opioid dose. But when you escalate the dose, that can actually impair the cognition for up to 7 days. So in such case, you consider it as a switching or rotation, and a significant adverse events with one particular opioid is seen, you can switch it with another or rotate with another drug, maybe not opioid, or a lesser dose. And modified release oral or transdermal opioid formulation aimed at providing relatively constant plasma concentration. So usually we start with a 25 to 50% of the recommended dosage. And in severe pain, you can start with slow dose, and after frequent reevaluation, you can slowly increase. Other drugs are codeine and dihydrocodeine. Next is tramadol, which is centrally acting with a weak mu opioid agonist and serotonin norepinephrine reuptake inhibitors also. So even though it's used, it has to be used carefully because it can even precipitate seizures and also serotonin syndrome if mixed with some drugs. And always 20% less tramadol than younger adults. So the drug regime is to start with 25 milligram once or twice daily, increase by 25 milligram if increments, and finally a goal of 100 milligram per day. And coming to the morphine, it has a similar efficacy to neuroopioids such as oxycodone. It has a hepatic metabolism where morphine 6-glucuronate and 3-glucuronate and produce the analgesic effect and also the neuroexcitatory effect. It goes and has a continuous enterohepatic circulation, and if you have a renal impairment, and it is not going to be excreted through the feces or urine, and that can accumulate in case of renal failure, and so you need to have a dose adjustment. The regime for initiation will be 2 to 3 milligram every 6 hours with a plan to follow up with 2 to 3 days to assess for efficacy as well as adverse effects. Next is oxycodone. Fentanyl. Fentanyl is an effective drug which can be used in its analgesic dose, much less than the induction dose. Very safe drug if given properly and monitored. And also there are few complications which we see rarely given analgesia like chest rigidity, or which is not seen for analgesic dose of fentanyl. And transdermal fentanyl and also intranasal fentanyl in case of pediatrics can be considered. So usually transdermal fentanyl must not be used for the opioid initiation and should only be used in context of opioid rotation or switching. So there is because of the opioid overdose or the potential side effects, other drugs were considered. One among them is the subdissociative dose of ketamine, the JURIKIT trial. But what they found out in the lower doses, even though it is efficacious in the short-term pain control, it has got certain psychoperceptual adverse effects. So to add on, some adjunct drugs are tricyclic antidepressants, which includes nortriptyline, SNRIs like duloxetine, which should be avoided in hepatic impairment as well as heavy alcohol intake, and anti-epileptics like gabapentin and pregabalin in neuropathic pain. And other topical therapy, as we know, NSAIDs like nocaine, capsaicin. So these are the adjuvant drugs. So as Dr. Hanif discussed, there's a BEERS criteria. Now the American Geriatric Society has, in March, they have published the recent update. The previous was in 2019. So always, if you are working in an ED and you're going to see a large population of geriatric patients, please go read this criteria, and there are very common combination of drugs which should not be using, and or rather you should be very careful while using. So one of the relevant which I found was regarding opioids and benzodiazepine. And opioids and gabapentin, pregabalin, which is a very common combination which can be used but should be used very carefully, or rather used with adequate or reduced doses. Another option, instead of giving analgesic, you can consider regional minimal invasive therapy, as we discussed in the WHO LADAP. So nerve blocks like perineural blocks, neuroaxial techniques can also be done instead of giving IV or other route of analgesia. So take home would be, to overcome barriers of effective treatment of pain, we need to proper pain assessment. Pain assessment using pain assessment tools, consider multiple comorbid condition, and also the changing physiology or altered physiology as well as polypharmacy. A multimodal analgesic approach with non-opioids and regional techniques should be sought, and always start with lower doses and titrate in case of elderly patients. And also consider non-pharmacological therapies along with your pharmacological therapies. So these are the references. Thank you. Any questions?
Thank you, Dr. Rahul. Now the session is open for question. You can ask questions from the previous sessions also. Thank you. Thank you for all.
to present to you a revolutionary finding which can make many of our lives easy. For people who deal with snake bites, probably if you listen properly, you can cut down on your costs and financial commitments involved in diagnostics. So be awake.
Oh, no. Thank you, Lino. And I think I'll just start. So, cloud waveform analysis, that's what I'm going to talk to you about. So when I came for the earlier session today morning, that's when I realized that most of my people here are medical residents, students. So instead of just bombarding you with what cloud waveform analysis in snakebite looks like, I want to actually start by saying a show of hands. How many of you have heard of cloud waveform analysis? Just a show of hands. Okay, so I got, yeah. Okay, I got just 4 hands up there. So let me put it this way. Cloud waveform analysis is what I'm going to talk to you about right now, and I've got a few financial disclosures. One, the results of the study which I'm going to present right now is actually funded by Indian Council for Medical Research. And this is the disclaimer from my institute. And I'll go directly into it. I want to introduce to you cloud waveform analysis. As Dr. Linu was gracious enough to say, I have this tool which came out of necessity for me. Because when we were taking care of snake bites, so I would like to look at TEG, I would like to look at Rotem. We do have Rotem, but Rotem costs maybe 3,000 rupees, which is approximately divided by 3 is what in lira. So if you look at it, it's actually quite expensive for anyone in our part of the world to actually afford. And the people who get bitten by snake is almost always the lowest strata of the society. So looking for stuff which can actually make a difference is when I came across this particular parameter, and probably it would be useful for you also. So first, I'd like to introduce you to this unexplored parameter. 2, I would like to tell you about our work on snake bite. And 3, if you guys go back to your institute, I want you to know if you have this there. I'm pretty sure how many of you have APTT being done in your institute? APTT, activated partial thromboplastin time. Activated partial thromboplastin time. So I'm pretty sure you guys all have CWA in your department. Only difference is we do not know how to interpret the results. You know why I decided to actually look at it? Because the hematologists in my department, my institute, did not know how to interpret the results. That's the reason why I decided to look at it. Like David Carr was mentioning yesterday, being curious. That's the reason why I came across this parameter. So let me give you a brief history about what cloud waveform looks like. See, you have this coagulation cascade being explained in the initial phase by Paul Morowitz in 1905, I guess. And he gave you this cascading pathway, but it couldn't help explain much of the hemophiliac, how does the hemophiliacs bleed, etc. Then came the enzymatic pathway, where you did not know, say, why factor 13 or factor 12 bled, deficiency bled. And then came the modified coagulation cascade. Now, I'm pretty sure you guys are familiar with this one, because this is what most of our text actually tells you, right, what the coagulation cascade looks like. Now, it might come as a surprise to some of you that this is not exactly what happens in the body. Physiologically, it's actually much more complicated than what I just showed, the intrinsic and extrinsic pathway. It doesn't get compartmentalized like that. It actually starts with the subendothelial tissue being opened up, you having the tissue factor being exposed, and you having your warm body brand factors attracting the platelets. You having the intrinsic extrinsic TNAs being formed. You have the 2A, 2As gathering your and forming the intrinsic teenase. So it initiates, it amplifies, and then the clot starts propagating. That's essentially what coagulation cascade looks like. But the problem is, to test all this, what you have is your PT and APTT. You have your prothrombin time, you have your activated partial thromboplastin time. Now, it does look at parts of the coagulation cascade, but it doesn't give you a holistic view. What if I were to tell you that even when you're doing it, you can actually see what's happening in the coagulation cascade? I'll explain it again. Because when you're doing a APTT, this is how you do it manually. You get the serum separated, you add activated partial thromboplastin. So what you do is you look at it, you add phospholipids, calcium, partial thromboplastin, and there's a color change, and you say there's the time taken for the color change. That's what you're looking at when you're doing it manually. Now, once people wanted to do it in an automated environment, once the machines came into play, they had to tell the machines how to see that. So what they did was, the same phenomenon, light source, activated partial thromboplastin time, change in color, but using nephrometry or transmittance or absorbance, you start getting, so this is an absorbance waveform. What it tells you is, if you look here, you can see the milliabsorbance, and here you have the time frame. So as time goes, the coagulation, the color of the plasma changes, and you have a coagulation change in the absorbance. And this is the clot waveform, or the fibrin clot waveform. So this is what is telling the machine that there is an APTT. Now, what is APTT? The point at which there is a maximum slope, or there are two different derivatives which is actually derived from it. So this is the velocity of the curve, and this is the acceleration of the curve. The pink one is the first derivative, or the velocity, and the blue one is the acceleration of the curve. Now, you have both of those happening there, and the peak of the second derivative is your APTT. Now, when you get your results, this is the only thing that you're looking at. You're missing all the other data. You're looking at this particular point where you have the maximum of the peak of the acceleration. So that's where the key lies. There's so much data which is not being used. Essentially what you're looking at is the pre-coagulation phase, the coagulation phase, and the stabilization phase of the APTT. That's what you're seeing when you're looking at this graph. And these are the extra parameters which were described. One is maximum time, maximum velocity, maximum acceleration, minimum acceleration, and delta absorbance. Let me get rid of all those nuances, terminologies, but I want you to know that this is there in all your APTTs, and you're only looking at this particular value there. Now, the drawback is even though all your machines are making use of it, only a few of them actually display it as a curve or a graph. I've just listed out a few from an article from Shima et al. So that's a basic of what clot waveform is. Now let me tell you about our work on snakebite. So I started working on snakebite because I had no other option. We get all kinds of snakes brought to a ER. We get all kinds of snake brought to a ER, and we get all kinds of manifestations with regards to snakebite happening in our ER. So we treat around 900, so last year it was 964 bites, snake bites. And we treat one, so it's like one requiring antivenom every 2 days. So it's kind of a large number, and we have this luxury of having all the snake bites brought to us. So I looked at the clot waveform analysis in specifically Russell's viper bite victims, and this is where we had the first major breakthrough, where you could see here all the APTT values except the last one was normal, but the clot waveform from the ones which I've been showing you were abnormal. Now that kind of triggered our interest, and that's when we started working on it more. We registered a study called waveform analysis in snakebite with hematotoxicity wish as a trial. And now we are in a position to actually propose 3 different uses for clot waveform in snakebite. 1, to detect envenomation. 2, to detect species-specific changes. And 3, to detect response to antivenom. I'll go through each one of them. 1, picking up early presentations. You know, we are in a state where we get people, unlike the common thought process, we don't have late presentations. We have people who come to us quite early because of the awareness in our community. We got people coming to us with snakebite early. Now, say this is a case of a lady who was brought in at 5:30 p.m. and 7:10 p.m. and she reached the ED at 7:10. 5:30 was a bite time, and that's a Russell's viper, which is a hematotoxic snake in our part of the world. And that's the initial APTT. APTT is actually quite normal, 28. But if you look closely, you can actually see there's a slur in the second derivative. Now the patient had local signs and symptoms, but coagulopathy hadn't developed. Now, in a situation where we have to wait for the coagulopathy to develop, for instance, snake bites, you don't have venom detection kits in most parts of the world, including ours. So we have a polyvalent antivenom, and to give antivenom, we have to look if that particular patient is having some sort of an envenomation change. And this actually shows you that. Now I'll tell you why I'm more excited, because once you give the antivenom, the coagulation, the clot waveform normalizes. I'll give you another example. So this is another case, bite time 8, brought to at 9, 1 hour's time. That's the initial waveform. If you look closely, there's this part of the waveform is missing, means that it's prothrombotic in the initial phase. It's initially prothrombotic, then becomes coagulopathic. So that's missing, and post antivenom you can see that has corrected. I'll give you another example. Now, what about the other parts of India, you know, where people get brought to the ER quite late? By the way, all these are Russell's viper bite. I had the luxury of actually compiling only the Russell's viper bite for this particular session. So here it's completely, there's no APTT value, means APTT is more than 180 seconds, more than 360 seconds in this case. You don't have an APTT value. The patient was brought after 6 hours of bite, profound coagulopathy, but after giving antivenom, 6 hours after antivenom, you can see that the waveform has started developing. The APTT is still prolonged, and 12 hours after antivenom, it's kind of starting to normalize. So it shows, the second point, it shows response to antivenom. Now this is the breakthrough which I think which we made, because you have someone with, so this is a control APTT clot waveform, and this is after adding dilute Russell's viper venom in vitro. And this is what the curve looks like in a patient with Russell's viper bite. It mimics the same. You have dilute Russell's viper venom added in vitro, and it looks the same as what you see in a Russell's viper bite. So we propose this particular fact as an experimental data that it can probably be a marker for detecting envenomation, species-specific changes. We haven't looked into it in much. We are right now looking at hump-nosed pit vipers and cobras, but soon we'll have a data. So, and for all those who are sitting here who's not interested in toxicology, so I'm going to actually give you potential application for CW in other conditions. See, CW came out in the picture when it was initially described maybe in 2009 by Toe et al. And it bordered on to becoming one of the most sensitive parameters, sensitive and specific parameters to detect DIC in sepsis patients. And it was almost about to become a recommendation by the British Society. And with high specificity of 97.6 and 98% to detect intravascular coagulation sepsis. So a particular change in the waveform called a biphasic waveform. Later, people started experimenting with it in clot waveform in hemophiliacs. You have multiple papers showing in hemophiliacs it as a useful parameter. And when you look at utility of clot waveform coagulopathy, in the last few years, 2021, 27, something changed. COVID-19. And with COVID-19, people started describing so many more with regards to, I'll just point out a few. So this is a study which was done by Tan et al. In 2023, I guess, 2020, that's when it was published. So I'm not sure if you can actually read it. Bacteremia, dengue, viral fever, and that's control. There is a statistically significant difference, p-value less than 0.001 between. So it helps, in other words, it helps in distinguishing between different kinds of infections. So CW has been proposed as a parameter which can be considered to distinguish across bacteremia, dengue, viral fevers with relatively good sensitivity. Now in coagulopathy, in COVID-19, there's been multiple waveforms which has been described, and experimentally recently in thromboembolism, it has been shown that the values which I earlier mentioned, the min1, min2, the max1, delta change has a significant difference amongst patients and controls. So in summary, CW remains an unexplored parameter, and in snake bite specifically, detection of envenomation, species-specific changes, detection of response to antivenom are things which you can consider, and research potential is still there. Anyone who's here who's actually got, so I want you to go back, find out if you have CW in your system. It can actually probably cut your cost a bit, or maybe at least as an experimental parameter for research purpose. Thank you so much for listening.
Thank you, Dr. Siju, for that wonderful talk. So, do we have any questions? So the next speaker would be Sari Saugen on chemical leaks and toxic effects.
Hi, everybody. My name's Sari, and I want to apologize in advance. I think I have a little bit of a cold, so my voice is awkward. So I'm going to be talking to you about chemical leaks and toxic effects, taking you in a completely different direction, but back to a topic that we started in the toxicology session in Hall B this morning, where we started talking a little bit about some of the toxicologic risks associated with major environmental disasters and kind of what to be prepared about. So chemical leaks are in that category, and I think the next few sessions are going to cover a little bit of preparedness with regard to these issues. I'm not advancing. Okay, a little bit about me. I'm an associate professor of emergency medicine and also a medical toxicologist. I work in New York at Bellevue Hospital and also at the New York City Poison Control Center. I do not have any financial or other interests to disclose. And I think in the next 15 minutes, we'll be talking a little bit about specifically chemicals involved in common industrial accidents. I read a recent review of the chemicals that was published in the last year, stating that at this point there are some over 350,000 distinct chemical entities that are recognized from a regulatory perspective. Now, by all means, from the standpoint of human physiology and how we interact with these chemicals, there's a tremendous amount of overlap, and the number is not that great. But in trying to put together this talk, I really had to think about how to narrow it down. So I asked, what are the most common agents released in chemical disasters specifically? And wanted to give a couple of examples, not to know in any kind of exhaustive sense what each of these chemicals entails and what they do in the human body, but just some general principles, using a few examples to think through what's most common and what we need to know to be oriented in the emergency department to help manage these cases. So this was an interesting website that I found also just in preparation for this talk. It's a relatively new group that started during the pandemic trying to bring some political awareness to the problem of chemical disasters and releases. And they put together, a group of people got together and put together a lobbying platform and a website with an interactive map where they were able to locate every chemical explosion or release happening in the United States by virtue of combing through media reports, websites, government releases, and so forth. And what they realized was that there is a chemical incident happening in the United States alone pretty much every other day. And that number is increasing. Now, there isn't data sufficient to understand what this looks like on a worldwide basis. That has not yet been compiled. And to understand the reasons why this might be increasing is completely speculative. But the WHO has been turning our attention for some time. This was a report, a book that was published in 2018. Looking at the problem of what are called NATEC events, or chemical releases and chemical disasters that follow in the wake of natural disasters. So these are your earthquakes, your cyclones, and hurricanes, flooding and so forth, which are going to put infrastructure at risk and by all means lead to chemical releases and disasters and are actually require a more complicated response, since by virtue of the natural disaster, the health system would already be at risk. So this is a paper that I came across some years ago. It's probably out of date by now, but in just kind of looking through that website that I mentioned before, it seems like it might still hold true. That chemical incidents, you can see here on the right, this is the top 15 out of top 25 chemical incidents that happen in the United States during a multi-year period. You can see that pretty much every sector is involved, right? So it's not just chemical manufacturing, it's agric, it's water quality and sanitation, it's animal husbandry. So these are all sectors of society that would be much more widespread and available anywhere in the world. And you can see that the number of chemicals used and the number of incidents that are involved seems to be pretty widespread. And in terms of specific chemical agents involved, this is again the top 15 out of the top 25. You can see that with the exception of some hydrocarbons here and there, butane is there, propane is there, flammable mixture is there as number 3. The vast majority of these agents all fall into one general category. They're all pretty much irritant gases. So if you were going to try to get prepared, in the last session someone made the comment that most emergency physicians don't have the bandwidth to learn about and to remember every single chemical that's out there. By all means, most toxicologists don't have the bandwidth to learn all 350,000 different entities and what they might do. Absolutely no problem. If you were going to think about one high-yield toxidrome to get prepared on, it would be this irritant gas toxidrome. And these are a group of chemicals much larger than the ones we saw on that initial list and much larger than the examples I'm going to go through right now, but that all basically dissolve in the water within our mucous membranes and respiratory tract to form caustics and create direct tissue injury as a result. So you see here, I've made a little scale of more soluble to less soluble, and that's important in terms of thinking about how we might experience these toxic effects and in what time frame. So number 1 on that list, the most common chemical involved in these big disasters or releases is ammonia. And most of us might have a frame of reference for pneumonia, or ammonia, not pneumonia, though it does cause pneumonia, as something we've encountered in smelling salts. I don't think those are all that ubiquitous now, but certainly when I was in training, we still had them around, these ampules of ammonia that you could break and hold under a patient's nose, and it would be immediately noxious. And most of you can remember what that felt like. So ammonia is something that is highly water soluble and will dissolve in your mucosa, your conjunctiva, your eyes, your upper airway quite immediately to form that noxious effect. And that's kind of protective because you can know to get away with it, from it. The other protective thing is that it's lighter than air, so it tends to disperse. If a big tanker like this were to explode, most of that would go up into the atmosphere and not settle on the ground. By contrast, chlorine tends to be a little bit heavier and to settle where we would breathe it in. That's also something that most of us can relate to as being relatively noxious from our experiences in swimming pools that might have been over-chlorinated and cause us to have stinging eyes and some chest heaviness. This is somewhat less soluble in water, however, and so it dissociates more slowly, and some of us, again, can relate to that we keep swimming despite the pain, and it's only later at night that our eyes are truly tearing and our lungs feel so terrible. So you could conceptually get a bigger dose and hang around longer within a chlorine cloud should a tanker like this explode in one's vicinity. Along those lines, I want to mention phosgene, which itself is not something that we would experience as being noxious all that much immediately. This takes quite a bit longer to dissolve, forming hypochlorous and hydrochloric acid within the respiratory tract. And the detectable limit is about 4 times higher than the upper limit of or upper threshold for toxicity. According to, I've never smelled it myself, but according to these World War I posters where it was used as a chemical warfare agent, it smells like fresh mown hay or like grass, something sweet, and not something that one would immediately want to run from. Again, increasing the risk that one could get a fairly decent dose before removing oneself from the gas. I don't know how many of you clued into what was happening during Fashion Week in Paris this year. There was a huge bedbug infestation in Paris that apparently is ongoing. And as a result, people were spraying a lot of chemicals to try to decontaminate these rooms and kill the bedbugs. I don't know if anybody knows what that agent is that is most commonly used for purpose, but it's sulfuryl fluoride. And this is a bit of an exception to the general irritant gas toxidrome that the other 3 agents I've just spoken about would produce. Sulfuryl fluoride doesn't so much, it does slowly hydrolyze in in the water of our mucosa and respiratory tract to form hydrofluoric acid. But more readily than that, it will simply dissociate to create a fluoride ion, which is highly reactive, an anion that reacts with calcium more so than magnesium and potassium, producing this toxidrome, the mnemonic for which is CATS, referring to convulsions, dysrhythmias. We can see here the classic signs of hypocalcemia, tetany, and so forth. And hydrogen sulfide is the last one that I want to mention as being a real exception. Yes, it absolutely is a respiratory irritant, an irritant gas, but its effects at higher doses or prolonged doses go far beyond the keratoconjunctivitis and the chemical pneumonitis that we might associate with lower doses of this and with the other irritant gases. And this by virtue of its ability to bind to cytochrome oxidases within the mitochondrial membrane and shut down ATP synthesis, creating a high anion lactic acidosis, which is a fundamentally different thing, looks a bit more like cyanide toxicity than an irritant gas toxidrome at higher levels. For this reason, it's been named the slaughterhouse sledgehammer, meaning that if it builds up within a space and someone were to walk into that space, it can cause an almost immediate knockdown, much like cyanide would cause almost immediate coma and shock. So our approach to management really today doesn't differ all that much from what it was or what was elaborated in the First World War as a result of many medics having to deal with high volumes of soldiers being exposed to chemical warfare agents. And back then, the standard of care was to follow the same principles that we use today, which is decontamination, decontamination, and then supportive care. So back then, decontamination looked a lot like using gauze soaked with water or saline to keep the eyes moist, and to have people gargle every 3 hours per this kernel. Today, we might be a little bit fancier about that irrigation. There are eye wash stations. We can provide people with humidified oxygen and, again, have them gargle and so forth. In my ER, when I get these people who come in having been exposed to an irritant gas, I'll frequently hook up a nasal cannula to a bag of normal saline and lie them down with their head in a trash bag, and then do continuous irrigation via the nasal cannula placed just here at the top of their nose. Tell them to hold their eyes open and let it just, irrigate, irrigate, irrigate. Bronchodilators may be important. People will frequently be wheezing. And then the role of steroids is something that you'll see a lot in case reports, but is quite a bit more controversial. If you had somebody with like an ammonia exposure or someone who had significant upper airway swelling and edema, I think I probably would recommend steroids. But their role to prophylax and to prevent the development of long-term sequelae, pulmonary fibrosis and so forth, after a significant irritant assault is much more controversial. And in most review articles that have examined what evidence we do have, mostly from single case reports and case series, as well as animal studies, there hasn't consistently been, no benefit has consistently been found. I know in toxicology we love to talk about antidotes. They're certainly the most fun aspects of therapy. In this case, there are not too many that would be helpful, with one exception, maybe with hydrogen sulfide, which again, as I said, acts a little bit like cyanide poisoning. One could think about it conceptually as being the same. And the therapy here would be to administer nitrite therapy, similar to how you would do that in cyanide poisoning, and to try to induce a methemoglobinemia that might pull that hydrogen sulfide molecule off of the cytochrome oxidase and help detoxify it. There's been some work, mostly with animal studies, looking at an analog to B12, much like we have hydroxycobalamin now being used for cyanide poisoning. That one doesn't seem to work as well for hydrogen sulfide, but this one, cobinamide, has quite great affinity for the molecule, and at least in these animal models, has been shown to be quite helpful in pulling it off and detoxifying it. I guess another exception might be many of you might have heard of giving nebulized bicarbonate, and that's specifically in cases of chlorine ingestion. It hasn't been shown to be all that helpful in other chemical entities, and certainly not been well studied in many human models, but we do have some small evidence in chlorine that it may shorten the duration of symptoms and help people feel better faster. So I want to just end with a brief remark on the long-term effects of these chemical exposures and this kind of subacute management. I haven't focused too much on the history of major incidents, but I feel it would be remiss not to talk about Bhopal, which is both the largest chemical disaster that we've experienced in the last century, I guess. And something where we now have 40 years of experience seeing what happens to people in the aftermath of the event. In this case, an irritant gas, again, was released in massive quantity after an explosion at a factory in 1984. And within about the first 5 days, officially 3,800 people died of this irritant gas exposure and toxidrome that I've been talking about. At the 30-year mark, however, the government officially recognized almost 600,000 people who had been affected and who continued to show the effects at 30 years, including a high incidence of birth defects and of cancers, anywhere from 8 to 27 times increased risk associated with this, as well as significant sequelae from long-term inflammatory changes in the eyes and the corneal opacification, for example, and in the lungs, both bronchiolitis obliterans and pulmonary fibrosis developing kind of 30 and 40 years out. People are still suffering from this. So I wanted to end with just this note that the good physician treats the disease, and I think as emergency physicians, we all have the advanced life support skills to do a great job in the vast majority of these cases without much specialized knowledge of what specifically the chemical was and how to treat it from a toxicologic standpoint. But the great physician treats the patient who has the disease, and in many of these cases, people are going to want to know not just, how can I feel better right now, but am I going to be okay down the road? And in that case, knowing what actually was released and being able to say something specific about the long-term consequences can be extraordinarily reassuring to people and an important part of what we do. So with that, I'm going to end and hand over to the next speaker, who I think will talk more about how one might go about finding out which agent was released.
Thank you, Sari. And we have Sage coming next. And Dr. Sage is going to talk about the prevention and protection measures in the community level.
Okay, so I'm going to talk about what we can do to protect our communities from these kinds of disasters. Brief slide about my background. I'm also a toxicologist who works in New York City. I work in Brooklyn, and I have no conflicts of interest to disclose. So I'm going to go over some background about preparation for chemical releases, talk about how we can identify some of the potential threats, whether they're industrial, whether they're used for malicious purposes, and then how we can prepare, what equipment we might need, how we can prepare about decontamination, how we can get information when we do identify a toxin, and then how we can address the availability of antidotes. So there are a number of ways that chemicals can be released. It can be intentional, it can be unintentional. Some sources include natural disasters, industrial accidents, transportation of chemicals, terrorism, and chemical warfare. And it's important to recognize that to some extent there's a bit of artificiality of this, because while it's true that people who have malicious intent with release of a chemical, there's a lot of agents that have been developed specifically for that purpose. But if if it may not be necessary for somebody to have the ability to synthesize a chemical, if they can identify a dangerous substance that's used in large quantities in your community, they could attack that source of the chemical that's already sitting there and potentially cause a release that could cause damage. So I'm just going to review some examples of some of these. This is an example from Cameroon, where there's a lake in the bottom of a valley that contains a lot of rock that contains carbon dioxide. And one day, the lake essentially burped up a big cloud of carbon dioxide, and that acted as an asphyxiant that killed a lot of people and livestock that were living in that valley. Here in Turkey, there was a release just a year ago of cyanide from a mine into a lake. So there are industrial sources, and Dr. Sari did a great job of reviewing how ubiquitous all of the different potential industrial sources are, and it cuts across a lot of things that we don't necessarily think of as sources of chemical releases. This is one that happened this year in the US, in Ohio. A train derailed that was carrying phosgene and hydrochloric acid, and also led to release of vinyl chloride. And this is a tough one to address, because we can identify the chemicals that might be being used in our community and prepare for those, but then how do you prepare for chemicals that just happen to be passing through your community and are released because of an accident like this? This is from the sarin attack on the Tokyo subway, so this is an example of an actual chemical weapon that was used. And another example of state-level chemical warfare, this is in Syria, and you can see that in the explosion here, the gas release, that green color indicated the presence of chlorine gas. So these are all different potential ways that people could become exposed to a chemical in large numbers. And to just highlight the difference between a chemical attack compared to a biological and a radiological attack, the biggest difference is the time frame, right? People who are exposed to chemicals typically, for most chemicals, and obviously there are exceptions for things like phosgene, but most things tend to have fairly rapid effects, and you need to recognize that, and that's really important in terms of personal protective equipment and decontamination that take a much higher priority compared to biological attacks and radiological attacks, because it's very easy for the person who's taking care of these patients to become a patient themselves if we're not addressing those things carefully. Now, when we see critically ill patients, I think we generally know what to do with those, but the problem is that there are so many worried well, right? The critically ill patient is the tip of the iceberg. They're going to be and a good example is the sarin attack on the Tokyo subway, right? There were about, I think, 688 patients that were transported by ambulance to hospitals after that exposure. 5,000 people presented to hospitals on their own that just transported themselves. There were 1,000 people that had some type of cholinergic effect. I think about 30-something that were significantly ill, and 8 fatalities. So you can see for every really critically injured person, there's a ton of worried well, and we have to think about preparing for what to do with those people when they present to your hospital, and specifically allocating specific space for those people, and have a plan for that. And also to control access to your hospital so you don't have people who have not been decontaminated coming and contaminating the clinical area that you're going to need to take care of these patients. And that kind of tip of the iceberg idea is really just an expression of the dose-response curve, right? And that comes from Paracelsus, who said, what is there that is not a poison? All things are poison and nothing is without poison. It is only the dose that makes a thing not a poison. So people who are exposed to a lot are going to be critically ill, but there's going to be a lot more people who are exposed to a little and might have minor effects, and you really need to sort them out. So in terms of identifying the potential threats that we might be seeing, thinking about the different industrial pollutants that might be used in your community, is going to be important, and preparing specifically for those. And Dr. Sari made an excellent point of that. In general, preparing for pulmonary irritants and asphyxiants is really going to deal with the large majority of these, but there are other threats that are out there. And in terms of preparing, what can you do? Well, we mentioned PPE, and there's going to be a lecture following me that is going to specifically address that, so I'm not going to go into too much detail about that. Preparing for decontamination, both in the field at the scene, at the site of the release, as well as at the hospital for patients who may not have been transported by ambulance from that site. We'll look at how we get information both to the community and for ourselves as healthcare professionals, and then what we can do to address specific antidotes when there is a release of something that does have an antidote. So here's an example of making sure that you have appropriate PPE for your first responders and for your staff in the hospital. Having appropriate equipment to be able to decontaminate people at the scene. Ideally, you don't want to transport contaminated patients in your ambulance because it's going to contaminate the ambulance and take it out of circulation, right? So you ideally want to transport people after they've been decontaminated at the scene. But at the same time, if you're working at the hospital and receiving these patients, you cannot assume that that has been done appropriately. So you have to treat every patient as they are potentially contaminated. And that's really going to mean controlling access at your hospital and making sure that patients are decontaminated before they're brought in. This is an example of our decontamination facilities at one of my hospitals at SUNY Downstate. And when we think about decontamination, you're going to need to separate your hot zone, where you have your contaminated patients, your warm zone, and that has that decon corridor, and ultimately the cold zone, where you're going to go on to treatment. And remember, this is where your chemical exposures are different from nuclear and biological, because decon takes priority over resuscitation, because that chemical is potentially going to kill them and potentially be a threat to you before they die of other things. In terms of getting information, getting chemical fact sheets for the community can be helpful, and a lot of them are online. In the US, we have the CDC and ATSDR, our agencies that produce some of these chemical fact sheets. For healthcare providers, the MSDS, or Material Safety Data Sheet, is going to be a valuable resource, and I'm going to give you an example of how that can be useful. And then, does anyone here have the Wiser app on your smartphone? It's very useful for identifying hazardous materials that are being transported through your community. If you've ever noticed on trucks or trains that are carrying chemicals, there are certain types of a code that basically tells you what's being carried, and that it can help you rapidly identify what's being used. So this is just an example of the CDC website, some examples of fact sheets that are available that are in language for lay people, that will let them understand what the potential risks are, what they should do if they may have been exposed. And ATSDR is another agency that puts out similar information. This is a picture. I was sitting with my wife in Istanbul the other day and having a delicious lunch of fish durum, and I looked across the street and I saw these chemicals there. So that's interesting. That's right near where I'm eating. And so how would I get information about those things if I wanted to look up what the potential effects are? So I can go to Google and I can type in acetone and MSDS. Remember, MSDS is Material Safety Data Sheet. And I'll get a bunch of different sources for material safety data sheets. Now, these were originally developed for industrial purposes, so in the US, any chemical that's potentially hazardous that's being used in the workplace, they have to have the MSDS for that chemical on site. But now these are all online, and you can look them up for basically anything, and they're not just for chemical names, but also brand names of products will have the MSDS associated with them. And it has a ton of information: physical properties, what potential hazards that they pose, what to do for first aid, what to do for firefighters if there's combustion of these agents. So a ton of information with a quick Google search that's available. This is a 10-sheet document just for acetone as an example. This is an example of the hazmat symbols that are being used when a chemical is being transported in the US. And so we can use these symbols to identify what potential threats, if there's a spill, if there's a train that derails, or if there's a collision of another type of vehicle that's carrying chemicals. And the WISER app, which is soon to be replaced by the ERDSS app, is really useful. It's something that you can download for free. It allows you to browse if you know what substance is involved, but if you don't know what substance, you can use the codes and it'll help you identify what the substance might be or what class of substances might be involved. The next thing I want to address is antidotes. And again, most of the things, as Dr. Sari mentioned, is really about removal from exposure, decontamination, and supportive care. But there are a few things that have antidotes, and there are guidelines for what antidotes should be stockpiled for hospitals. This is an example of a consensus guideline for the United States, at least, about what things should be stocked. And this is the New Mexico Poison Center has put how they have interpreted that and what they stock in their hospital. And obviously, this needs to be tailored to each community. If you have different potential threats that are involved, then you may have to adjust that to some extent. And you want to prepare for mass casualty situations by having a pharmacy disaster cart so that you'll have an easy way to get a large amount of needed material to where it's needed within the hospital if you have a large amount of patients presenting at once. And on a larger scale, thinking at the government level in terms of strategic national stockpiles, in the US we have what's called push packages of antidote and equipment, about 50 tons of material in each of these push packets, and it's enough to fill the belly of a wide-bodied cargo jet. This is a picture, and you can see there are a number of carts, and they're designed to fit exactly into the space in the cargo jet. And you can get a large amount of material to where it's needed within a few hours, and they're at strategic locations around the United States for when they're needed. This was first created in 1999 by President Clinton at that time in response to a number of chemical events at that time, the first World Trade Center bombing, the sarin attack on the Tokyo subway, and the Oklahoma City bombing. And initially it was just for CBRNE threats, but now it's been expanded to other types of threats, and they have 2,000 caches of nerve agent antidotes known as Chempacks that are strategically placed around the country separately from the other types of push packets. So just to recap, think about the different potential ways that you might have a release. Think about how we can identify the potential threats, both industrial, and think about how those potentially could be used by people with malicious intent. Prepare in terms of your equipment that's available, in terms of thinking about decontamination procedures ahead of time before you need them, how you're going to deal with those worried well, and how you're going to control access points within your hospital to prevent people who are presenting on their own from getting, who have not yet been decontaminated, from getting into your clinical area, how you're going to get information to the community and to healthcare providers, and think about your antidotes. Are there any questions? All right, thank you.
Thank you, Sage, for this comprehensive overview of prevention and protection measures in the community level. Now, we have Dr. Linu Shekhar talking about the prevention and protection measure on a personal level. This will be the last talk for the session. And the last speaker, which was given as Ashish Bhalla, has already taken a session in the toxicology session earlier. So, Linu Shekhar, prevention and protection measures, personal protection. As the speaker is setting up, if there are any questions which you want to address to the prior speakers. Everyone's having a stretch. That should be good. Now, we'll have Linu back on stage. Linu. In which case, I have a question. Can I have the mic to one of the... the question is to Dr. Sage. With regards to, so we decided to actually have an antidote bank in our place. Now, our biggest problem was the expiry date on these and the cost of maintaining it. So, for us, a cost, say, underdeveloped nation, do you have any suggestion as to how we can actually start one on a smaller scale with regards to what should be stored? Say for the Sinokit, it's 5 lakhs Indian rupee to actually store 1 vial of it, and we get, is the mic available? I think you can take this. Yes, sir.
Okay, so I think that the best way to address that is to continually rotate drug out of your disaster supplies into your regular use and replace the disaster supplies so that it's not had a chance to expire. I mean, that won't help for things that are used very rarely, but for things that are used commonly, you want to restock the disaster cart, move supplies from the disaster cart into your general use so that they're not sitting there and expiring. Is really your best approach.
And what about the expiry dates? You know, say methylene blue. Do they actually expire?
So that is another good point, and I think it depends on your situation, how much you have to pay attention to those expiry dates. Most drugs don't really expire. And there's pretty good data that certainly for things like tablets, they probably are good for years past their date. One of my colleagues at New York City Poison Control did a study where he looked at atropine from a World War II nerve agent antidote kit and found that 70 years later, it still had close to 90% of the original amount of drug in it. So, if you don't have the capacity to maintain those supplies within the suggested expiration dates, it's probably fine to use them. In my clinical setting, that's not considered acceptable outside of an emergency setting. But depending on your clinical scenario and your resources, it may be reasonable to use expired drug. And we do have precedent for that, even in the US. Some of our antivenins, when the YF polyvalent antivenin that's used for crotalid envenomation was all expired, it stopped being produced, they were still making exceptions to allow it to be used after it was expired.
Thank you, Sage. And thank you for filling the gap when Linu was setting up. Thank you so much.
So, good evening. My job is to complete the gap that what you do for personal protection level in case of a hazmat event. And my job has been made much easy by 2 factors. One is our senior Dr. Sage has completed it very comprehensively. And another one would be the pandemic which we had just encountered, which has taught all of us how to do a proper donning and doffing of a personal protective equipment. So I don't have any financial interest to disclose. So disaster is considered as a hazard when it is more of a natural cause. Something's beyond something called as force majeure. It's beyond the control of the humans. And it is considered to be a threat when it has got a more of a man-made character, like active bioterrorism or such things. Be it hazard or be it threat, we need to cater ourselves accordingly so that the event is mitigated properly. So, depending upon what we are dealing with, we will have to change our strategy. But on a personal level, the first and foremost thing to be understood is that unless you have a healthy rescuer, a healthy doctor, a healthy paramedic, a healthy technician, there is no scope for the community who is at the face of the disaster. So before going into PPE levels, the protection levels, I just dwelled on to find whether there are any prevention or mitigation strategies so that there is increased efficiency in handling future events. So as we all know, as emergency physicians, training is the way to go. But apart from that, there are few legislation points which the administrative section with a good political will can handle. Firstly, it would involve improved methods and procedures for transporting hazardous materials and poisonous agents, promoting compliance with safety codes and regulations and status. Many countries of which would have, many of the developing countries don't have the same. And there should be a plan so that hazardous chemicals are manufactured far from civilian areas. So those are few things which can probably mitigate or prevent future events. Increasing public and community awareness and support for the prevention, because in most disasters and most hazmats, everybody is caught in the thick of things very soon. And however hard we train, it finds that whether it is a toxic gas leak or whether it is a bio threat, everybody attains only 50% of the training of the expected outcome. So we need more training courses like hazmat and more training for the emergency first responders in the first place, so that all these things, when put in place properly, helps in improving the efficiency of our management. So personal protective equipment is the main focus of personal protection, and how you engaged and how you effectively manage these events on a personal level. So they should be, the responders should be trained not only in the proper donning and doffing, they should also know what their equipment is going to handle, whether that equipment is sufficient to handle the toxic agent in place on first hand, whether how far can he or she compromise on the available thing, and how do you weigh the risks and benefits of what equipment is being used with. And lastly, how to dispose of this PPE should also be taught to the stakeholders. So now coming to the most important, one of the most important parts, which we learned, many countries learned during the COVID pandemic in a hard way, that if you don't don a PPE properly, then you're inviting trouble. Better off without a PPE. So it applies the same to toxic disasters as well. So there should be a separate area for donning and doffing. Ideally, they should be cordoned off in different places. And the doffing area should be designed in accordance with the biomedical waste guidelines policy of the concerned institution. So these are prerequisites. And what we should understand is that there are different types of PPE, and the different types, each type will have a separate instruction of its own, so that the purpose is served. The purpose is that the rescuer or the first responder is protected properly. For example, this I have taken from the COVID literature itself. An interventional radiology patient who goes to the IR suite, how does he, sorry, not a patient, a responder who goes to the IR suite at the time of, everybody was afraid about COVID, at that time, how he goes and handles a COVID positive patient. So there, the steps have been shown here. So I'm not reading out all these things because it is different in each case. In here, if you see, after completely donning the PPE, he has to put on a lead apron also. So it depends upon what agent you are dealing with. The steps might have a different, but you have to be knowledgeable. That is the take-home point. Unless you are knowledgeable, there is no use having any fancy PPE with you. And this is again a picture of another, I took it from some other place here, whether how you properly doff the PPE. There will be different steps, and it usually starts with the part covering the head, and it ends with the part covering the legs. It is, if the doffing is also not done properly, it can also do more harm than your intended protection. You might be protected, but the PPE would be helping to disseminate this agent to others. So now coming to levels of protection, Environmental Protection Agency of the US defines 4 levels of protection for PPE, with the level A giving the greatest protection and level D giving the least one. So what is level A? It provides the highest level of both respiratory and skin protection. It protects the respiratory tract and mucous membranes and skin from all types of vapors as well. So this is airtight and fully encapsulating, and self-contained breathing apparatus, which is accompanied, will be within the suit. So nothing is left out of the patient. It is wholly encapsulating the patient, and it would be fully chemical and vapor protective suit, and it is suited for all toxins. And in addition, it would have outer chemical resistant gloves and boots as well. So this is the picture of self-containing breathing apparatus, which you would see with in case of most of the first responders. Coming to level B, it provides the highest level of respiratory protection and skin splash by using chemical resistant clothing. But it does not provide skin vapor protection, though it provides protection to the respiratory tract. So here, the difference is that the self-contained breathing apparatus is not enclosed within the suit. It is coming as a separate unit, so it is not fully tight, and there will be some level of protection which is lost. So examples of level B protection would include the SCBA, or the self-contained breathing apparatus used in conjunction or separately, along with gloves and a face shield with some chemical resistant clothing and chemical resistant boots. And coming to level C, the level C protection should be used when the airborne xenobiotic is known, its concentration can be measured, and the toxin qualifies for use of air purifying respirators. And in addition, we don't think that there is a skin or eye exposure is present in such patients or in such toxins. So it protects splash protection at the same level as B, but a lower level of respiratory protection than classes A and B. Majority of the hospitals expect that their EMTs or the first responder team to have level C protection training. But that may not be the case in case of a toxic disaster. So these 3 are the actual levels, and there is a level D which is written theoretically, but it is not used because it is nothing more than a routine uniform or the scrubs which we use in our routine departments. It provides no respiratory protection and only minimal skin protection. And then why is there a level D? So this level D is that this should not be worn in case of toxic disasters. That's why it has been designed. So this gives a picture of level A, level B, and level C of PPEs. Here, as I discussed, you can see level A shows that the respirator device is also inside the suit. So it is a completely sealed issue. And level B would be the respirator would be outside your suit. So it gives us lesser amount of protection. And as you can see, level C, the eyes and the face are actually not covered, but there is a purifying respirator associated with the suit. So this is again just an extension of what Dr. Sage had discussed. All the treatment of the patient should actually happen only in the green zone. So the red and the hot and the warm zones are actually for extrication and for removing for decontamination of these patients. So these PPEs are donned appropriately in accordance to the area as well as the toxin in question. So this is just a summarizing of what level of protection is given by each type of PPE, and obviously the level A PPEs would be the best, which gives comprehensive protection against vapors, aerosols for the eyes, skin, and the respiratory tract. So with that, I end my talk here. If there are any questions regarding personal protection or donning or doffing techniques, I'm happy to take it.
Are there any questions from the audience? I'm pretty sure by the end of COVID kind of helped us understand what donning and doffing meant. You know, it brought that to everyone. So this was the last speaker for the night, and hope you all have a good night. See you all tomorrow. Good night. Thank you.